Good morning. It is my pleasure and privilege to welcome you to the Endometriosis Foundation of America's 13th Annual Endometriosis Medical Symposium, Endometriosis, Here, There, and Everywhere, Pelvic and Beyond, including the thorax. It's my true pleasure to introduce the co-founder of this wonderful event, Dr. Tamar Sechkin. I first met Tamar years ago when we lectured together at several places throughout the world. And when I became chair here at Lenox Hill 4 years ago, I realized the many, many skills that he had. He's an outstanding surgeon. It's very unusual that surgeons come to learn from a gynecologist, but that's exactly the reality here at Lenox Hill. He's a great team builder. He has with him 2 outstanding gynecologists who work with him, Dr. Carly Goldstein and Dr. Amanda Chu, and they work as a formidable team. And he's a compassionate and caring physician. He's been transformative here at Lenox Hill. He's an outstanding educator who's changed the lives of so many people. Dr. Sechkin and his slate of outstanding presenters today are truly remarkable, and they're world-renowned, and you're all in for a treat that you'll be able to go back home to help your patients throughout the world. EndoFound is the leading nonprofit in this country, which was founded by Tamar and his co-founder and patient, who you all know, Padma Lakshmi. For more than 10 years, they have built a strong community that advocates for disease awareness, created programs to educate both patients and providers, and funded an amazing over $1 million in research to 30 leading research institutions. This month, our House and Senate Appropriations Committee has prioritized endometriosis research both at the NIH and at peer review. It shows its importance. And the final legislation is being sent to the president, which includes a $92 million increase for the NIH over the past year to provide $370 million for research. That means more money for well-needed research, and the Department of Defense can continue to increase funding. In 2019, EndoFound advocacy led to the New York law, the first in the United States, requiring the commissioners of health and education to create materials on menstrual disorders, including endometriosis, and making these materials available to schools, medical practices across the state. And I'm delighted to say that Connecticut and New Jersey have followed this important lead. I'm grateful to all the practitioners who are part of this important program today. Conferences like this move us all closer to improve the options for diagnosis and treatment. And this disease affects 1 in 10 women today. It's so well known, as Tamar Sechkin tells me, that the key to treating this disease effectively is early diagnosis. Welcome, welcome, welcome.
Endometriosis patients and their loved ones throughout the world. It is 9:00 a.m. from New York City. I salute you. Thank you for coming here. I hope this is going to be a historical meeting. I thank Dr. Chervenak. He's a great orator. He talks very kindly. I never had a department chief who supported me throughout my life as much as he did. And this is a special meeting. We are gonna round around the theme of Here, There, and Everywhere, one of my favorite Beatles songs, which applies to endometriosis here, there, and everywhere. Anatomically, we know endometriosis is a disease of women, yet far away from peritoneal cavity, it reaches thorax too. And we have the world experts today will cover every aspect of the endometriosis. And let's kick the meeting with our first speaker, Dr. Victor Gomel. Victor Gomel is the father of microsurgery. He has been the leader and the teacher for all of us, and he will speak his take on role of microsurgery in endometriosis. Victor, go ahead.
I am delighted to participate with you this morning, and we will look at microsurgery in the treatment of endometriosis. Endometriosis is a difficult and enigmatic disease, a disease that affects only women directly and her environment, partner, family, etc., indirectly, but significantly. Endometriosis has the following symptoms: chronic pelvic pain, dysmenorrhea, dyspareunia, dyskinesia, and depression. A disease diagnosed with increasing frequency and is the commonest cause of pelvic pain in women of reproductive age. Endometriosis affects women of reproductive age. It is a polymorphic disease in appearance, in the variability of severity of symptoms. It is frequently progressive and invasive. Endometriosis is a lifelong disease that can affect almost every organ in the body. The hormonal imbalance and the pro-inflammatory milieu alter neuronal signaling systems, which can alter pain progressing. Endometriosis is a chronic inflammatory disease and may cause injury to the somatosensory nervous system. Unfortunately, the diagnosis is often delayed, leading to suffering for several years. Early diagnosis is essential, especially in adolescents presenting with dysmenorrhea and chronic pelvic pain. Surgery remains the most effective treatment for endometriosis. For surgery to be effective, the use of a delicate microsurgical technique is mandatory. The microsurgical principles were developed over time with the use of non-human animal experiments and clinical observations, which included systematic second-look laparoscopies performed 8 to 12 weeks after the initial surgery. Microsurgery has been erroneously defined as surgery under magnification. In fact, magnification is only one aspect of microsurgery, which embraces a broad concept of tissue care designed to minimize tissue injury, prevent postoperative adhesions, improve the postoperative course, and the outcomes. Microsurgery principles are as follows. Delicate handling of tissues. We call that a traumatic technique. Judicious use of electrical and laser energy. Irrigation with heparinized Ringer's lactate solution. Meticulous pinpoint hemostasis, very important. Identification and use of cleavage planes. Complete excision of abnormal tissues. Furthermore, excision and removal of broad adhesions. Precise alignment and approximation of tissues. Thorough lavage with Ringer's at the end of the procedure. To instill 500 milliliters of Ringer's solution with 500 milligrams of hydrocortisone succinate before the closure. And use of magnification as necessary. We also suggest to give 1 or 2 doses of dexamethasone post-operatively. Thank you very much.
Thank you, Victor. It is an incredibly well-positioned speech to kick this meeting because it's all about the details, and the quality of surgery is defined by the techniques that you have just explained beautifully. And I will extend another icon of our endometriosis surgery. The next speaker is going to be Dr. Harry Rich, which I could only say very shortly. Harry probably is the most influential person who made endometriosis so much, who encouraged every surgeon from South America to China, from Canada to Europe, everywhere. Harry's techniques have also affected me tremendously. He is the previous medical director, senior advisor to Endometriosis Foundation. With no further introduction, it is Dr. Harry Rich that he will be talking about my journey to cure endometriosis via pelvic pain and infertility. Harry, thank you for being here.
Thank you, Tamir. Well, I'm going to tell you about my journey. And my journey finished following residency program. I trained at Boston Hospital for Women, and I finished up in 1975. And I was one of the few people in endometriosis development that did not have a mentor throughout my career. Maybe good or bad, but anyway, here goes. During my training program, I worked with Bob Kistner in Boston for 4 months. And during that time, I assisted surgery. And during the surgery, typically he would do excellent work on taking out ovarian endometriomas by laparotomy. And usually for the cul-de-sac disease, he would do what's called a presacral neurectomy to deaden the nerves of the pelvis. But my own interest, when I came back to my local area in Wilkes-Barre, Pennsylvania, was to do vaginal surgery. I was very fortunate in that my mother had delivered a lot of babies, and a lot of them needed surgery as I got older. And I also inherited an infertility clinic that had over 100 active patients, none of who had been laparoscoped. So I had lots of laparoscopies. My first year, I had well over 100 laparoscopies. And typically what I would do is I would do a laparoscopy. If I found endometriosis, I bring them back in 2 months, and I do a Kistner type operation. But again, I avoided the cul-de-sac. Soon thereafter, well, most of the patients were for infertility. And as you get more involved in the practice, you start to do pelvic pain patients. But we used to use danazol as a medical treatment, and didn't work very well, but we used it. And early on, I felt that excision was the only way to truly cure this disease. And my goal was cure, not just giving them relief of their discomfort and getting them pregnant. Anyway, excision made a lot more sense. And really, pretty much my guideline was the rule of common sense should prevail in whatever we do. And it made sense to use what worked the best, and that was excision. Now, soon after, with all these cases, starting in the 70s, we started doing endometriomas. I discovered I could easily separate the endometrioma, not easily, but I could separate the endometrioma cyst wall from the ovarian cortex and shell it out. And we started doing that. And when I say no mentors, I should say, well, in 1983, while up in Boston for the Boston Marathon, I went over to see Bob Hunt, who had been one of the people who trained me. And he videoed every case, or I'm sorry, he took photos of every case. So I copied down the equipment that he had. It was an Olympus CLEF camera system. And I started in 1983 taking a photograph of all the cases that I did. And when video came in around 87, we started to use that instead. But anyway, Bob did help me because he suggested I use a camera system and document what I was doing. And that led to me being able to present at AAGL how to excise endometriomas by laparoscopy. So after that in 1985, I went over to France for vacation, not to learn very much, but I heard about a Dr. Bruja, and it's a group that he had in France, in Clermont-Ferrand. So I went there for a few days and I watched Hubert Manis remove an endometrioma by laparoscopy. So really what that did is it gave me confidence that I wasn't the only one doing this type of crazy work. Anyway, we then started doing cul-de-sac dissections in around 83, 84. But we also used to excise a lot of endometrioma or a lot of lesions. So my pathologist said, Rich always runs the alphabet. He always comes up with 26 specimens per case. And because I wanted to know what I was excising. And some of the things he excised are fibrous tissue, but most of the fibrous tissue had endometriosis in it. So I realized that was the right track to remove fibrous tissue that most of the time was endometriosis. So anyway, following cul-de-sac dissection, I started excising the endometriosis from posterior vagina, uterosacral ligaments, but I was very careful with the rectum. But I noticed many of these people where I avoided the rectal disease didn't get pregnant and continued to have the pain. And in many cases, on examination with a rectovaginal exam, I'd feel nodularity on the anterior rectum. So around 87, 88, I started doing rectal resections of the lesion. Just a small lesion of the rectum, and then we'd sew it up with suturing techniques. Come early 1991, I said, why not use a circular stapler? So I brought a circular stapler, which I was able to invert the endometriosis into and excise it. And I went to the Ethicon headquarters and I excised the same lesion, same area of the rectum 3 times, and there was no stenosis of the rectum. So I thought, well, this is a lot easier than sewing with suture and very much quicker. So we started doing that type of surgery. Now, evolution-wise, as I progressed, I used a knife electrode with cutting current to excise the lesions of endometriosis. We progressed then to using carbon dioxide laser to get around the lesion and excise the lesions. And then I think probably in the late 80s, early 90s, I developed the technique of cold scissors dissection. And the reason I did that is I realized that endometriosis lesions don't bleed very much, or if they do bleed, they stop because it's a microvascularization. It's not like a regular blood vessel that's been there for your whole life. So I could excise the endometriosis and let it, I'd excise it without thermal energy. And then at the end of the operation, I'd check to see if there's any bleeding. And I do that by filling the peritoneal cavity with normal saline and do what I call an underwater exam, where I could locate exactly the bleeders because they look like small little snakes, and I could coagulate them quite easily. Anyway, I emphasize some of this because my technique emphasized grasping the lesion and excising the lesion next to normal tissue. I didn't go wide. I still believe that endometriosis lesions are always surrounded by fibrosis, which is white, and I could go along the border of the endometriosis lesion and normal tissue, and you get a characteristic crunch when you do that with the scissors. Now with a laser, come on, you don't get the characteristic crunch, but you probably get more of a thermal energy burn to that tissue. So anyway, I emphasize this because when you use a robot, you don't get that characteristic crunch. You don't see or feel that what's going on when excising an endometriosis lesion from surrounding normal tissue. So anyway, briefly, as we only have a brief period of time, I've told you what I do. And let me also emphasize that I worked in a small area, a small town, and patients who had symptoms would come back. And if they came back, oftentimes I would look for a rectal lesion and excise the rectal lesion, and that was the end of their pelvic pain. If it wasn't, I would hear about it. So I knew from clinical experience, and that sort of area to work with, that these patients were doing very well with excisional surgery. So I thank you for this chance to say briefly, quickly, what we were doing all these years. Tamir started working with me really in the 90s, it was the 90s, but especially my last few years in 2000 when we were associated. So thank you, Tamir. Thank you for this honor to be able to come and speak in front of all of you people.
Thank you. Thank you very much, Harry. What you heard a lot from Harry. I think one thing that really stays with me is with Victor and Harry, it's all about meticulous hemostasis at the capillary level, checking late bleeders from the excision surfaces before you close the case is crucial. Videotaping or picture documentation towards evidence, or basically making the patient believe that they have the disease is an incredible thing. Also, it serves you to later focus on. Our next speaker is a very special gentleman, Dr. Dan Martin, who is the Endo Found scientific and medical director. Dan is an incredible brain which affected me tremendously with his evidence-based documentation of lesions with their pathology, which every surgeon I encourage to go to pathology department, look at their specimens. And he's also obviously the man behind the subtle and definition of subtle endometriosis, I think, which non-pigmented lesions due to that became important, because most of the time endometriosis is not pigmented. It's all white, white lesions. He's the past director of American director of minimally invasive surgery at University of Tennessee, and the past president of American Association of GYN Laparoscopists. He has more than 400 publications. I give the microphone to Dan Martin. Thank you, Dan.
Thank you. It's a pleasure to be with you today to discuss concepts of theories. We're going to discuss how to make sense of theories. The objectives are to understand the development of endometriosis, discuss the cells of origin, and understand activation, transition, growth, stabilization, regression, and clearance. I have no conflicts of interest. For those of you who want a more in-depth study, my concepts file, which is a PDF on the first page of my website, has 578 references. Just go to danmartinmd.com. It's the PDF on the middle of the page. We're going to be discussing ectopic Mullerian tissue, and whether that's retrograde endometrium or congenital rest, those are both Mullerian based. The development of endometriosis starts with the Mullerian cell of origin. There is dissemination during or after embryogenesis. Those cells are stimulated and activated. They undergo transition and growth, or they stabilize, regress, and potentially clear. The cell of origin is generally going to be endometrium, embryonic remnants, endometriosis itself, or non-Mullerian stem cells such as peritoneum or bone marrow stem cells. The last two are thought to engraft or add to pre-existing endometriosis and may have the potential to become endometriosis themselves. Dissemination is cell dependent. If we look at endometrium, it can be disseminated at least 5 ways. Retrograde menstruation is the one that's most commonly discussed. Surgical dissemination, such as at the time of cesarean section. Venous dissemination, which I'm going to discuss in depth. And then also lymphatic and uterocervical extension, which we'll not discuss today, but are worth studying if you're going to do in-depth studies on this. A lot of this is going to come from John Sampson, who lived from 1873 to 1946. Sampson noted that endometriosis differs from endometriosis both in structure and in function. It had an inflammatory reaction like cancer. It was difficult to recognize and could hide behind adhesions, and that he found endometriosis and endometrium coexisting with a transition from one to the other. He also discussed multiple other theories. We're not going to discuss all of those in depth. We're just going to note that by 1940, he believed that retrograde was not sufficient for all endometriosis. You also had to understand a venous dissemination, coelomic metaplasia, and transplantation. Sampson had studied venous dissemination since 1918. By 1927, he had color pictures published. In this, you see the endometrial glands that are within the uterine veins on day 2 of a menstrual cycle. These are whole tissue fragments. The whole tissue fragments are not likely to make it through the lung and may implant in the lung as pulmonary endometriosis, but the stem cells, remember, red blood cells, white cells, and stem cells can pass through the pulmonary circulation. So stem cells will pass through and are capable of going to more distal sites throughout the entire body. Retrograde menstruation itself, we see as small cells that we can find if we do a lot of slides on menstrual products that we see at laparoscopy. And this one is from Tamara Second. Those come out, they implant in the peritoneum. And Sampson in 1927 published pictures of early implantation associated with inflammatory reaction that was similar to that seen with infection and cancer. More recently, we have research publications that show the initial attachment of endometriosis prior to implantation. This is Craig Witz and others at San Antonio. There are multiple other centers that have done this. More recently, Tamara Second showed early endometriosis implanting on the peritoneum 5 years after excision surgery in an excisional site. Those little red blush areas, some of those are stroma, some are glands in stroma. But in the picture, you can see the stroma that's attached to the peritoneum with very early infiltration, but an intact loose connective tissue behind it. Of interest, this blushy picture is similar to what we see in teenagers where you don't see a lesion itself, but all you see is a little red blush appearance that represents stroma on the surface of the peritoneum. In this patient, she subsequently developed glands and stroma in the same area because we did not excise that area. That was only biopsy. This was in the early 1980s before I even thought that was endometriosis. I'd only biopsied it because I thought it was inflammatory and possible an infection. If we look at dissemination of Mullerian rest, the normal Mullerian area is where we expect them to be. I'll show you slides of that in a second. Laughlin suggested a secondary Mullerian system, which could include the peritoneum and the pelvis. And more distal sites are found in endometriosis, and there is normal Mullerian theory does not explain how the Mullerian rest would be in more distal sites unless you start talking about venous dissemination and secondary dissemination. If we look at one of the papers that's commonly quoted for 10% of patients have fetal Mullerian remnants, this is Signorelli et al. In Italy. If you notice, they found those lesions at the base of the cul-de-sac behind the vagina. So if you look at that area, that's the base of the cul-de-sac behind the vagina. It's not higher in the rectum, it's not in the sigmoid, it's not in the ovaries, it's not any place else that we commonly see endometriosis. That is behind the vagina. Even when we look at Adamian stage 4, that area is not generally involved. So behind the vagina is an uncommon location for endometriosis. This may represent 1% or less of all endometriosis. So his 10% in his fetal tissue results in 1% of those patients having endometriosis or less. More commonly, more importantly, Ron Batt discussed Mullerianosis as 4 congenital Mullerian diseases that were like the 4 acquired diseases of the same names. He discussed endometriosis, adenomyosis, endosalpingiosis, and endocervicosis. He felt that these would commonly be organoid. And if we look at organoid Mullerian derivatives, those include things like accessory and cavitated uterine mass, which is also called a juvenile cystic adenoma, or those two may be slightly different. And in this, you can see that accessory mass to the right of the uterus in the slide on the right. These have a structure that looks like a mini uterus. In a similar fashion, endomyometriomas are organoid structures found in the deep cul-de-sac that can be found in the deep cul-de-sac. They can also be found in the ovary, but these look like little mini uteruses. This one is in a female. Similar thing from a male. Even men get these. So little organoid mini uteruses that are found. This was a congenitally normal male. He was XY male. Interestingly, Philippe Konix published this picture in 1993. And if you look in that circle, everything looks basically normal. there's just a 1.5 centimeter nodule you can't see that's behind the peritoneum. So when he dissects it, this is easy to find on a sonogram, an MRI, on physical exam, but at laparoscopy it looks normal. It may be that these are also a form of Mullerian disease, Mullerian remnants. And then how does endometriosis itself disseminate? For those of you who've done a lot of endometriosis surgery, you know you can find it in your surgical incision sites after endometriosis surgery. It may be disseminated with venous dissemination or even lymphatic dissemination. Bone marrows will be venous, and bone marrow stem cells do not appear to initiate endometriosis. They tend to engraft into pre-existent endometriosis. And the last of those, peritoneum, it's just found right where it belongs. It's in the peritoneal lining. So this is coelomic metaplasia. The cells of the peritoneum can undergo metaplasia and transition into endometriosis. And whether that is all engrafting or if that can be a primary technique is not known. More important than all of those is how they activate. We know that even though both retrograde endometrium and these congenital Mullerian rest both fit a diagnosis of endometrial-like tissue outside the uterus, neither of those should be considered as endometriosis. Those are both normal tissue. They become endometriosis by going through transition after they've been activated. And activation is generally from estrogen stimulation, neuroinflammatory induction, and a failure of the immune surveillance. Those are not dependent on the cell of origin. Any cell of origin can be stimulated. Other activation things are trauma, Leindecker's tissue injury and repair, or Sunway-Grove's repeated tissue injury and repair. Both of those have to do with anoxia and other changes at the site. Iron from retrograde menstruation, endocrine disrupting chemicals, dietary factors, the microbiome, and stress have all been implicated in activation and continued growth. The transition, we've known since 1921 that endometrium was different in both structure and in function than endometriosis. Sampson knew that before he even published his retrograde studies. By 2002, David Redwine had published 39 differences and 9 similarities. And more recently, there have been, as you saw from my slide earlier, we have more than 500 references on differences that we can find. And those include inflammatory, angiogenic, fibrotic, immunity, epithelial-mesenchymal transition changes, aromatase within the cell that can produce estrogen, progesterone resistance in about a third of patients, and cancer driver mutations found in deep endometriosis. What we don't know about those factors is whether those are what cause endometriosis, or whether they are caused by endometriosis, or if they work in a cycle so that they tend to reinforce each other. A lot of research is needed on that. Although we understand that inactivation and stabilization occur, there are questions about whether clearance happens. If we look at the natural course in symptomatic diseases, there are 7 studies that looked at this. These are untreated patients in symptomatic studies. 71% of those were stable or regressive. Only 29% continued. That's in symptomatic patients. If we look at asymptomatic patients undergoing tubal ligation, in all tubal ligation studies, there are about 15 of them in Fluente's review, 5.7% of women had endometriosis. If we only look at focused studies where they looked at symptomatology and found that they were asymptomatic, it was 15%. That 15% is probably a more accurate figure because it was a more focused study. These are all potentially diagnosable, and the real question is, should we treat them if we really find them when they're asymptomatic? We know at tubal ligation from Meta Moon's study that when she followed 32 women with no major symptoms for 12 to 14 years, there were no significant differences compared with control. Only 1 had subsequent surgery for endometriosis. 97% of the time, they had no further surgery. And from the way the paper was written, we're not even sure that that surgery was due to endometriosis so much as she had endometriosis and they did surgery. I had 1 patient with a 4 centimeter asymptomatic rectovaginal nodule in the posterior vagina They've been recognized by a family physician doing a pap smear, and he thought it was cancer. So he sent her to an oncologist who did lots of biopsies and sent her back to me. I followed her for 7 years on exams and MRIs, and none of those changed. She didn't develop symptoms, and then she moved to North Carolina, so she was lost to follow-up. Federally found similar patients who had asymptomatic rectovaginal endometriosis, followed those for 9 years, and 6.8% had symptomatic or growth progression. So asymptomatic endometriosis more commonly stays asymptomatic and does not change. Less than 10% of asymptomatic endometriosis will be a problem in the future. Doesn't mean you can ignore it, but it means all you need to do is monitor it. It doesn't require immediate surgery. And if you look back at my case has about had we done a rectovaginal resection right there, mine has about a 1 to 3% colostomy rate. Most patients would rather observe this stuff over time than try to worry about colostomies. And the last is clearance. We're not sure that clearance happens. But if clearance happens, it's most likely to happen in teenage endometriosis where the lesions are less than 1 millimeter and act like pimples. Remember, pimples can clear. You can have big shiner pimples that go away and you never know they were there. We anticipate the same thing could happen with teenage endometriosis if it's appropriately treated or if the immune system takes over. It's one of the reasons that for dysmenorrhea, we need to reject the normalization of pain. We all know that killer cramps are not normal. We need to encourage proactive care and planning and consider hormonal suppression to decrease the estrogenic stimulation, activation, and growth, and consider NSAIDs and holistic care to decrease other inflammation, activation, and growth. All of those are needed for the care of dysmenorrhea, whether we can or cannot decrease endometriosis. This property treats pain that way. If, in addition, it decreases the number who develop ongoing endometriosis, that's a bonus. I'd like to thank you for listening. For those of you who want more information, my endometriosis concepts file is on the first page of my website. Thank you.
Beautiful presentation. Before I introduce our next speaker, I just want to make a comment for our non-physician viewers. What we learn from here, endometriosis is a disease when there's symptoms. Otherwise, endometriosis is a condition. So it can be present up to 1/4 of the women population, maybe. Who knows? We don't know these facts, but it is a disease, probably 10%, maybe a little over when you consider the infertility pool patients as a disease, it exists. So again, thank you. Our next speaker is Professor John Yovich from Western Australia. He is recognized for his pioneering work in vitro fertilization, resulting in Western Australia's first IVF baby delivered in 1982 and establishment of Pivot Medical Center. We invited Dr. Povich for a talk. I actually initiated this through Dr. Martin. I don't know him personally, of his beautiful defense of Samson. I don't think anybody stood for Samson at this present time as much as John Yovich. So he's going to be talking about this. He does introduce himself better than I will. Beautiful work. Thank you, John. John Yovich.
In presenting the subject of John Samson and his relevance to the endometriosis story today, I offer my credentials. Having graduated in medicine in 1970, I gained my specialty qualifications with the RCOG in 1976, following training at the King Edmund Memorial Hospital in Perth, Western Australia. That was following an unforgettable stint in the remote northwest on the Royal Flying Doctor Service, where I became smitten with the need to improve both obstetric and gynae services for those courageous women in the outback of Australia. With my new specialty credentials, I proceeded directly to London with a view of exposure to the very pioneers currently advancing reproductive medicine, finding a home at the Royal Free Hospital School of Medicine with Professor Ian Kraft, to advance my skills in hysteroscopy and laparoscopy. He enabled me to train in microsurgery with his colleague Robert Winston at the Hammersmith Hospital and with Stuart Campbell at the King's College Hospital for ultrasound. As a secondary interest, we took the opportunity of establishing IVF, utilising the resources of the animal embryologists at Wolfson House in London and the Animal Research Station in Cambridge, providing me with enough data to complete my PhD entitled Generating Human Pregnancies from IVF. In the 42 years since returning to Australia and establishing my Pivot Medical Centre devoted to the treatment of infertility, I've been pleased to have progressed the development of IVF as the current mainstay. Whilst most cases of infertility are categorised as poorly explained, the condition of endometriosis, or the conditions of endometriosis, adenomyosis and fibroids underlie around 20% of the women. With respect to endometriosis, our early studies indicated that the condition was a relevant cause of the problem and furthermore required definitive treatment to improve the chances of IVF, particularly for those higher grades 3 and 4, and absolutely where deep infiltrating endometriosis was found. In Australia, there has been widespread adoption of laparoscopies for either pelvic pain or infertility for both diagnostic and treatment purposes. Many women had numerous laparoscopies until the Australian Gynae Endoscopy Society AGES became established and eventually posed a grading system with the intention of steering patients to those gynecologists who acquired level 6 with the capacity to excise nodules completely and safely. Nonetheless, as the journalist covering Erin Barnett's story here describes, the process is not yet running optimally. Another hot-off-the-press publication is that of 50 Big Debates in Reproductive Medicine by Cambridge University Press. The debate between experts Stefan Gortz from Belgium and Matthew Leonardi from McMaster's Canada shows there is actually no high-level evidence supporting the value of laparoscopic surgery to improve infertility or its treatment by assisted reproduction, despite the earlier publications from my Pivot. High-level work obviously needs to be undertaken and with an awareness of the numerous confounders which operate for fertility outcome. When one looks to the authorities in reproductive medicine around the world, the advice is not yet clear or helpful, neither to the doctors treating endometriosis nor to those women harbouring the condition. In the United Kingdom, an all-party parliamentary inquiry has recently, in 2020, concluded that diagnostic and medical management processes must be improved, and the 1.5 million women with endometriosis in the UK require to be better looked after from puberty throughout their adult lives, including into the menopausal years. So what is the chance of fulfilling the demands of the British Parliamentary Inquiry? I personally attended the pre-Congress course on endometriosis by Eschri in Vienna in 2019 and came away with a massive inundation of biochemical studies, best summarised by the, or biomedical studies, best summarised by the Oxford Scientific Group headed by Krina Zondervan, reporting in the New England Journal of Medicine in 2020. They state, the development of endometriosis involves interacting endocrine, immunologic, pro-inflammatory and pro-angiogenic processes. But whether these factors are pathogenic, meaning causal, or merely represent a secondary feature of the pathophysiological process, typically measured years after the symptom onset, remains uncertain, and I'm sure they were suggesting unlikely. Against this inauspicious background, I would respectfully suggest that it is time to review the 68 publications of John Sampson. To understand endometriosis and its infiltrative process, as well as its spread to peripheral, even remote sites of the body, requires grasping Sampson's 3 unique observations. Firstly, his publications of 1913 and 1918, while studying myomata, revealed a unique venous system operating within the uterus. Specifically, his revelation of the anemic zone surrounding the endometrium acts as an effective protective valve against products from the endometrial cavity, unless disrupted. Secondly, Sampson's unique photomicrographs within publications of 1913, 1918 and 1925, some in colour, display metastatic spread of viable endometrium into peripheral uterine veins via receiving sinuses forming in the anemic zone when this area has been disrupted by various processes. Thirdly, after cajoling from eminent gynecologists of his day, such as Emil Novak, Joe Meigs, and Robert Meyer, Sampson undertook his uterine studies on hysterectomy specimens performed during menses, rather than the previous interval procedures. He then published the story of retrograde spill via the fallopian tubes in 1927 and 1940, with some cases demonstrating implantation onto peritoneal and ovarian surfaces, as well as progressing to invasion. Key to understanding the metastatic pathogenesis of endometriosis requires a close evaluation of uterine vascularity. The arterial system is conventional, with the sequential branching of radial arteries to arterioles, finishing in a fine arterial network within the endometrium, with there being straight basal arteries in the basal zone, spiral arteries in the spongy layer of the functional zone, with a protective valvular effect, and the terminal fine arteries in the compact layer of the functional zone, to be desquamated during menses. However, the venous drainage shows a relatively vast number of venules retrieving blood from the rich venular network draining the endometrium, feeding into a rich radial plexus in the outer two-thirds of the uterus, with the most peripheral plexus feeding backwards into the arcuate plexus, which finally drains into the uterine plexus for distribution into the main uterine veins. Once ultrasound progressed from B mode to high-quality phased arrays, a clear halo could be identified surrounding the hyperechoic endometrium, more recently developed as the junctional zone of the endometrium, JZE, with advanced scanning combined with MRI. This thickened JZE signifies a disrupted anemic zone and has a telltale association with adenomyosis. Furthermore, the mechanism for fibroids causing menorrhagia was long held by Sampson to be due to a disrupted anemic zone, enabling retrograde blood loss back into the endometrial cavity, rather than the suggested idea of hypertrophic endometrium, which is not found at hysteroscopy evaluation. This slide depicts the relevant publications from Sampson's 68 articles leading to the 3 unique observations I've presented. Sampson's earliest works involved him injecting a gelatin bismuth mass containing pigments, being Venetian red for arteries and ultramarine blue for veins. Apart from his macroscopic differentially coloured view, Sampson followed with stereoscopic radiographs. In this work, he started at Albany, New York State in 1905. In order to progress from the idea of endometriosis being an enigmatic disease, I present the abstract from my open access article of 2020 explaining Sampson's 2 mechanisms. I note that for unclear reasons, but probably because of the way Sampson himself avoided covering old ground, along with the difficulty until now of tracing those earlier publications, most modern-day authors have focused on the second implantation theory and criticised its relevance as it fails to explain many forms of endometriosis outside the peritoneal cavity. However, I believe all 8 locations of endometriosis, both common and uncommon, can be explained from Sampson's earlier reported studies. This table describes all sites of endometriosis, both common and uncommon, along with the likely pathogenetic mechanisms from which they are derived. S1 refers to Sampson's first described mechanism of metastatic spread via the uterine veins. S2 refers to Sampson's second described implantation mechanism following retrograde menstruation via the fallopian tubes. S3 refers to metaplasia of coelomic epithelium or from Müllerian rests or occasionally from stem cells. Let us examine Sampson's personal evolution. Karl von Rokitansky was the pathologist who in 1860 described benign sarcomas within the female pelvis of some of his 60,000 autopsy cases. Although the relevance of these descriptions have been challenged, esteemed authors of today, Ivor Brosens and Giuseppe Benegiano, in 2018 concluded that these are indeed the first clear descriptions of endometriosis. However, one needs to understand that autopsies at the time were only allowed in the Protestant part of Europe, known as the Holy Roman Empire, not in the Vatican-controlled Catholic South. In fact, the very popular Empress Maria Theresa, acting on behalf of her husband, thereafter her son, created a state mandate in 1753 requiring an autopsy to explain every death in Vienna's two public hospitals, first and second, enabling Rokitansky to amass his large series. Most of the autopsies were macroscopic procedures, although Rokitansky did introduce microscopy at a later stage after visiting centres in France, albeit in a relatively primitive form, awaiting thin section preparations by microtome, along with the evolution of advanced compound microscopy. These are the amazing characters around which the endometriosis story unfolds, each having an incredible story to tell, summarised in my open access article. Friedrich von Recklinghausen is worthy of special mention, having followed Virchow in Berlin and adding thin section histology and improved microscopy when he set up his own facility in Strasbourg, at times a French or a German city. However, his idea that endometriosis, termed adenomyometer at the time, arose from remnants of the Wolffian ducts was shown to be incorrect by Thomas Cullen, who utilised even thinner tissue sections with superior mounting and more advanced compound microscopy at the Johns Hopkins Hospital in Baltimore, Maryland. Cullen specimens were cut with a microtome utilising a diamond cutting blade and mounted in celluloidin, whereas von Recklinghausen's were hand cut with a razor and mounted in amyloid liver. Robert Meyer, William Welch, a colleague of Cullen at Johns Hopkins, who also had studied under von Recklinghausen, along with Emil Novak, all recognised that Cullen specimens were superior, demonstrating a Malarian origin. But none were courageous enough to point this out to their former teacher and mentor. However, von Recklinghausen eventually acknowledged their superiority after presentations by his former students, but not directly to Cullen, whom he regarded as not a suitably trained pathologist. It was then widely considered that endometriosis was a new disease, reported by von Rokitansky in 1860. However, historical tracking, perhaps best displayed by the Nezet brothers in their Fertenstert article of 2012, indicates the condition has undoubtedly been with us through the millennia. Hippocrates from the Greek island of Kos indicated that the ancient Egyptians described the clinical condition of strangulation of the womb, which he endorsed with his protege, the Athenian Plato, although not a clinician, promoted a similar term of suffocation of the womb. These terms persisted until German doctor Daniel Schroen in 1690 provided the first proper descriptions of peritoneal ulcers, mainly on the uterosacral ligaments in the pelvic cavity of such women. These were later termed sanguinous cysts by French doctors Trousseau and Velpeau in the early 1800s, prior to the definitive descriptions of benign sarcomas by Rokitansky. Closer to modern day, the three most prolific authors at the turn of the 19th century included two others apart from Sampson. Most prominent was Thomas Cullen, a Canadian gynecologist who graduated in Toronto, thereafter studying pathology in Göttingen, Germany, under Professor Johannes Oort, whilst awaiting a promised position at the Johns Hopkins University. He held the inaugural directorship in gynae pathology for 16 years, whilst awaiting retirement of the highly esteemed Howard Kelly in 1919, thereafter holding the chair in clinical gynecology for 20 years until retirement. Cullen described adenomyosis of the rectovaginal septum in 1914. He believed gynecologists should be trained as fully competent abdominal surgeons and encouraged complete resection of the constricted segment of the rectum at the hysterectomy. Sampson provided glowing reviews to Cullen's 1908 book on adenomyoma of the uterus. Also was British gynecologist Cuthbert Lockyer, trained at Charing Cross in London. He received secondary training in various German centres, including Berlin and Vienna, prior to returning to Charing Cross as consultant ONG physician. He taught and wrote prolifically and contributed thousands of gynae specimens to the Charing Cross Hospital Museum by his retirement in 1930. Both Cullen and Lockyer used the term adenomyosis extensively between 1913 to 1918. The man whose relevance we are considering here, John Sampson, was born in Troy, near Albany, which is the capital city of New York State. He graduated at Johns Hopkins Medical School and conducted his residency for 7 years under Howard Kelly. He did not undertake any tour of Europe, but was exposed to the lectures and publications of Thomas Cullen, favourably reviewing his book on adenomyoma. From 1906, he held a chair in gynecology at Albany Medical College and conducted his extensive surgical procedures at the Albany Hospital on the same campus. I've already described his three main contributions to the understanding of endometriosis, but would also acknowledge his early utilisation of X-rays from 1905, bearing in mind Röntgen described these only 10 years earlier, and the first machine was established in the UK in Glasgow only 5 years earlier. Even the advent of electrical power used to drive the machines had a recent history, with the historic alternating current power line established in 1896 from Niagara Falls to Buffalo in New York State had occurred less than a decade prior, utilising large-scale hydroelectric generators built by George Westinghouse after he had bought the patents from Nikola Tesla. These are some of Sampson's microradiographs from his publications of 1925 and 1927, which support his metastatic pathogenetic mechanism for endometriosis. They display endometrial tissue within receiving sinuses in the disturbed anemic zone. The main points of this slide introduces the retrograde menstruation implantation theory, which Sampson described in a second study in 1927, then presented at the behest of the American College of ONG in 1940. It became widely known, such that most gynae trainees, like myself, initially believed that this was Sampson's gospel. He did not refer to his former metastatic theory, nor did he mention his findings regarding the venous system of the uterus. He confined his presentation and the ensuing publication to the brief requested by the ACOG. When I began my search into understanding endometriosis, the 1940 article was readily available. All the others I found in the fifth level underground of the dungeon area in the library of the Royal Society of Medicine at Wimpole Street in London. Happily, they have now all become digitised and available, courtesy of Granting Peoples of Elsevier and Andrea Musolf from the American College of Surgeons. Deeply invasive endometriosis involving the rectum, DIER, has become a subject of major interest recently and exposes a debate started by the differing viewpoints concerning its operative management by Thomas Cullen, who promoted bowel resection, and John Sampson, who promoted conservative surgery, writing, "I have purposely kept close to the uterus, undoubtedly sometimes leaving adenoma in the rectal wall, but also strongly advising not to leave any ovarian tissue in order to ensure that the endometriosis tissue would regress." Sampson's coloured pictures from 1918, reproduced in his first article of 1927, are from a case of DIER and shows the metastatic endometrium within the retrieving sinuses and uterine veins with attachment and penetration of the vessel walls. The blueberry nodules within the posterior fornix are pathognomonic of endometriosis within the so-called rectovaginal septum. This slide expands on Sampson's 1940 presentation, describing a three-step process for the retrograde menstruation and implantation theory. Sampson also notes there are many other interesting unsolved problems associated with the pathogenesis and life history of endometriosis of all types. Since it is my desire to adhere strictly to the text which has been assigned me, I have not discussed any of these. However, we would all have a better view about the relevance of Sampson if he mentioned the dissemination of endometrial tissue into the uterine veins required an aberration in the submucous collecting veins, displaying a feature Sampson described as receiving sinuses, which could harbour pieces of endometrial slough, which thereafter travels to peripheral venous plexuses within the myometrium. In modern day, we would understand this as the MRI-defined thickened JZE, junctional zone of the endometrium. So where have we come to in modern day concerning the operative treatments of endometriosis? Commencing with Maurice Brouard from Clermont-Ferrand, France, but also Kurt Sem from Munich and Kiel, Germany, and later Harry Rich from the USA, have all been important contributors. Brouard established his dream team of now famous gynae laparoscopists and conducted the first World Congress on endometriosis in 1986. I attended his facility and workshops in 1989, presenting my work on laparoscopic embryo transfer procedures. But this was competitive with other IVF-related conferences, hence I had to choose which specialty discipline to follow. It might explain why I prefer not to engage in rectal resections, despite the evolution of smart star devices. Despite the excellent results reported from Arnaud Wattier from his ERCAD facility in Strasbourg and Horace Roman's facility in Bordeaux, with the almost complete avoidance of serious surgical complications, I follow the advice of Samson and shy away from resections. I am in good company, as this is the same view of eminent laparoscopic surgeon Jacques Donnet from Brussels, who in 2020 describes rectal shaving as sufficient for the vast majority. Either way, the important aspect of managing these cases is long-term hormonal suppression after the excisional surgery. MPA Provera, sometimes in concert with GnRH agonist Solidex, being my preference. But this is the key important area, hormonal suppression. A further area of special interest relates to the excision of focal or nodular adenomyosis a la laparoscopic myomectomy. Despite neat operative outcomes, 2 of my 40 cases who subsequently achieved IVF pregnancies experienced uterine rupture. One explosive at 37 weeks, the other silently discovered at elective cesarean delivery. Fortunately, both mothers and their babies have survived well, but it appears that healing of the myometrium with adenomyosis can be deficient or suboptimal. We have not experienced this problem from over 350 post-myomectomy pregnancies. In conclusion, I believe that the studies of John Samson are the most relevant to our understanding of endometriosis and its appropriate management today. His discovery by unique studies on post-hysterectomy specimens revealing the anemic zone concerning the venous drainage of the uterus underlies his reporting of the first mechanism of pathogenesis of endometriosis, that of metastatic spread into the uterine veins. When he changed the timing of his hysterectomies to coincide with menses, he was able to demonstrate his second mechanism, that of retrograde spillage of endometrium via the fallopian tubes and subsequent implantation and penetration. Along with some cases of coelomic metaplasia, virtually all cases of endometriosis can be explained. However, there remains a requirement for further advanced studies to explain why endometriosis mostly stays confined to the pelvic region, and whether there is an involvement of lymphatics to contain its spread. Furthermore, another idea proposed by Samson in 1912 for menstrual control was that of a pelvic venous network controlled by the uterus acting like a pelvic heart. This also requires clarification one way or the other. I thank you for your attention.
Thank you, Professor Jovic. This was an incredible presentation, and it will stay incredible presentation forever. I think for all those critics of Samson, there are cultish flat earthers who criticize him viciously on the internet. Samson is going to stay with us because if Samson lived today with the presence of electron microscopy, immunostaining, and all RNAs and DNA technologies, God knows what he would pursue to prove more and more about endometriosis. I appreciate your input. Dr. Jovic was with us. It's 1 o'clock in the morning in Australia. It's unfair to keep him for the question and answers. I'm not sure what his intentions are, but I'd like to introduce our next speaker, who has been a friend and supporter of EFA and also recipient of one of our honorees from the get-go. Our first meeting was stem cells to excision surgery. That was 13 years ago. We did recognize the role of inflammation, and Dr. Taylor from Yale was with us, along with Carolyn Gargett. We explored stem cells from the get-go and the role of inflammation. Without further introduction, obviously, you all know that he is the head of Yale School of Medicine, Department of OBGYN Reproductive Sciences. He is the recipient of many nationally recognized awards. Research in stem cells has been cornerstone and reference to so many. Dr. Hugh Taylor will talk about the update situation on stem cells.
Hello, I'm Hugh Taylor. I'm professor and chair of obstetrics, gynecology, and reproductive sciences at the Yale School of Medicine. And I'm very honored to be here presenting to you at the Endometriosis Foundation of America. Today, I'll give you an update on some of the work we've been doing in the field of stem cells and epigenetics and endometriosis. And in epigenetics, I'll be focusing on some of the work we've done on microRNAs. First of all, we believe endometriosis is a systemic disease, that what we see in the pelvis is an important part of the story, but not the whole story. What we see in the pelvis affects the rest of the body. And I won't go through this in a lot of detail today, but I refer you to a recent paper where we reviewed this topic in Lancet, published at the end of last year. Endometriosis we've traditionally thought of as arising from Sampson's theory of retrograde menstruation, where endometrium flows backwards out the fallopian tubes and plants in the peritoneal cavity. But of course, the people at this conference know very well that endometriosis can appear in areas outside of the peritoneal cavity, the lungs, the brain. Certainly that doesn't arise through retrograde menstruation. Also, in the old days, we had a few men that developed endometriosis when they were treated with high doses of estrogen for prostate cancer. Certainly that doesn't arise through retrograde menstruation or hematogenous or lymphatic spread. We've been searching for other ways where someone can develop endometriosis, and even in these remote areas. And we, some years ago, proposed a stem cell model where stem cells could travel and differentiate into endometrium in ectopic locations, hence leading to endometriosis. And again, I'll review some of our previous findings where we first looked at bone marrow stem cells. Now, the bone marrow is a rich source of stem cells. In addition to the hematopoietic stem cells that we all know about and think of as being the key ingredients in bone marrow transplant, the bone marrow also has these multipotent mesenchymal stem cells that can differentiate into solid organs. So we reasoned if they could differentiate into other solid organs, certainly they should be able to contribute to endometrium, which undergoes a dramatic turnover in each menstrual cycle, is sloughed and completely regenerated. If ever there was a tissue where stem cells would play a role, that would be it. So we did some very simple experiments many years ago in mice where we transplanted bone marrow from males into females and looked to see if we could find male bone marrow cells in the endometrium. And indeed, this is what we saw here. The red dots are Y chromosome. The tissue shown in A is male tissue as a positive control. The tissue shown in B is a uterus of a female that got a female bone marrow transplant, no Y chromosomes, negative control. But in C and D, you can see endometrial cells that are derived from bone marrow. And see the arrow points to a epithelial cell. The black line in the middle is the lumen of that uterus with the epithelium on either side. There's an epithelial cell derived from the bone marrow. And D shows a stromal cell. And I won't show them all. We have lots of other markers to prove that those are really epithelial and stromal cells and not just leukocytes migrating through. We showed the same thing in humans. Again, several years ago, we looked at women who had a bone marrow transplant that had a HLA antigen mismatch, and we could use that HLA antigen to determine the origin of any cell. The brown here stands for the mismatch HLA antigen after bone marrow transplant. It marks cells of bone marrow origin. On the left, you can see the endometrial epithelium, where there are brown cells intercalated into that epithelium. Those are the donor-derived cells that turn into endometrial epithelium. And on the right, you can see the stroma. The arrows point to the brown cells that are bone marrow-derived stromal cells, whereas the arrowheads point to cells that are not brown. These are the cells that are the resident or endogenous stromal cells that were there before the bone marrow transplant. And here we show the same thing in endometriosis. Here we show stem cells. The red cells here are stem cells from bone marrow. They're incorporated into the endometriosis, shown above that white line on the right. Below the line shows that they're incorporated into the new vessels that form to feed that endometriosis, the angiogenesis that we know occurs with endometriosis. Bone marrow-derived cells also contribute to the pregnant uterus. They play a pretty important role in pregnancy. Several years ago, Reshef Tal, working with me, devised a way to do bone marrow transplant that maintains fertility. A partial bone marrow cell ablation replaced some of the bone marrow with here green cells, GFP bone marrow cells, into a mouse after this mild chemotherapy, mild bone marrow ablation, so we didn't destroy fertility. And this is what we found after transplanting the GFP into these mice. We looked at basically every organ. They're laid out here on this in this dish. And the top row shows the control, where there's no GFP transplant. There's no green signal in any organ. The second row shows a non-pregnant female. In the GFP, you can see two organs where this is taken up to a considerable amount. The top one is the lung. Of course, when we do an intravenous injection, some cells will lodge in the lung, and that's not surprising. The lower organ is the uterus, and there's a little bit you can barely see here in bone. So where do these bone marrow cells go after transplant? Well, it looks like the uterus is one of the main places that bone marrow cells go. And if we look in the pregnant mouse, you can see again some in the lung, some go to the bone, but the uterus, and they tend to focus and engraft specifically at the site of pregnancy. So it looks like the uterus has a special relationship with bone marrow stem cells, again, that we'll come back to over and over again. It tells us a lot about endometriosis as well, and probably plays an important role in pregnancy, that there may naturally be a recruitment of these cells to build up endometrium, decidualize the endometrium, and assure a normal pregnancy. Again, this looks throughout pregnancy at the number of these green fluorescent cells from bone marrow after bone marrow transplant that end up in the uterus. Here's a negative control, no GFP cells. Here's the GFP animal itself. The uterus glows bright green, even in the absence of pregnancy. Here's a little bit of green that gets taken up after bone marrow transplant in the uterus of mice with the GFP bone marrow transplant. And here you can see in pregnancy, a lot more of these cells taken up. This whole uterus glows green, and then it is specifically focused at the site of pregnancy. So interesting major flux of bone marrow-derived cells to the uterus in pregnancy. What do these cells become? Well, of course, some are leukocytes and some are white blood cells that migrate there. I won't go through all this data, but what I want to focus on is decidual prolactin is a marker of an endometrial stromal cell that decidualizes, and progestin receptor, again, marker of stromal cell, not leukocytes. You see these markers go up. You see these really are truly differentiating into decidua, stromal decidual cells that help support pregnancy. So this bone marrow flux may very well have evolved to support pregnancy. And again, I think that's why in endometriosis, we continue to see bone marrow flux. There's a very special role and function of bone marrow cells in endometrium. Well, the cells go there, they differentiate, but how important are they functionally? To determine whether they really have a functional role, we looked at knockout mice that don't get pregnant. Here we looked at the HOXA11 knockout mouse. The HOXA11 knockout mouse has a small uterus, and embryos can't implant in that uterus. They make beautiful embryos. They ovulate, they make eggs, they can fertilize, they make wonderful embryos that can implant in a surrogate, but no embryo can implant in the HOXA11 mouse uterus after knockout. What happens if we do a bone marrow transplant, put some wild type bone marrow into that mouse, the HOXA11 knockout mouse? Well, the uterus never developed fully, but it still improves its function. You can see the uterus gets a little bit bigger. Here again, same magnification. This is the transplant of knockout bone marrow. Here's transplant of wild type bone marrow into the HOXA11 knockout. It's larger. But even more striking is the development of glands. The HOXA11 knockout mouse has 0 glands consistently. You never find any. When we do a bone marrow transplant into that mouse, it starts to develop glands. New endometrial cells that are never seen in this mouse start to develop. The bone marrow really is doing something. Again, this graph reflects the increase in the number and size of the stroma. And again, you can see the knockouts have 0 glands. After bone marrow transplant, 80 to 90% of them develop glands. So really changing the appearance and the structures within the uterus. Bone marrow has a really important role in the uterus. And how about, does it actually affect pregnancy? Well, here's a wild type mouse. Here is the HOXA11 knockout mouse, which has a low pregnancy rate, but when we give it a transplant with wild type bone marrow, the pregnancy rate goes way up. And when we give heterozygote the knockout bone marrow, the pregnancy rate goes way down. They get pregnant faster after bone marrow transplant. And these figures just show that for example, the wild type mouse after bone marrow transplant with wild type bone marrow versus the knockout bone marrow, big difference. And when we use the heterozygote and give wild type bone marrow back, we rescue this mouse completely. Here you can see again that the number of viable implantation sites is greatly increased by bone marrow transplant in these mice. So again, we see structural changes, we see functional changes. They get pregnant better with the use of bone marrow without touching the uterus. These bone marrow cells really play an important role in the uterus. So this is a novel origin for endometriosis. Stem cells contribute to endometrium, they contribute to endometriosis. They have a functionally active role in the uterus, and I believe in endometriosis as well. I think these stem cells coming from bone marrow account for the endometriosis we see outside of the peritoneal cavity, that we see in the brain, in the lungs, and other remote locations. And this is a novel mechanism of disease. Although endometriosis can come from stem cells, I suspect we'll find other diseases come from the ectopic displacement of stem cells. Not only do we find the stem cells going to endometrium and endometriosis, but they leave it as well. This is some experiments we did in mice, and we track cells in the circulation coming from endometriosis. We transplant endometriosis that are tagged with fluorescent proteins, and we watch them move to the circulation, and we can measure them in the circulation. Not only that, when we characterize these cells, a high number, matter of fact, the majority, are stem cells. So stem cells can come into the uterus, can come into endometriosis, can cause endometriosis, but then they leave endometriosis as well. So when we think about stem cell trafficking in endometriosis, cells are moving around the body. We've often thought of endometriosis predominantly as a disease of retrograde menstruation. Cells leave the uterus and create endometriosis. But we now know that bone marrow cells can repopulate the uterus, can feed endometriosis, can cause endometriosis in remote locations. And then these stem cells leave the endometriosis. Could they be responsible for some of these remote effects that we see throughout the body, some of these systemic effects of endometriosis? The other thing that mediates the systemic effects of endometriosis are microRNAs. These are small RNA molecules that are encoded in the genome. They're transcribed, but they're not translated. They're spliced and heavily processed into small RNAs of 20 to 30 nucleotides in length, and they bind messenger RNA and generally shut genes down. And this is some of the work we did several years ago just to show that there are differences in these microRNAs in endometriosis itself. The red shows an aggressive endometriosis variant that has very low levels of, say, the LET7 family of microRNAs. Other microRNAs are also, again, aberrantly expressed. But we know microRNAs don't stay in tissues. They can actually be exported from the cells, either as free RNA molecules or in exosomes or microvesicles, and travel through the bloodstream to distant organs, where they can enter cells and bind RNA in those cells and change gene expression. In a sense, functioning much like a hormone, having a remote effect far from where they're made. So we looked at circulating microRNAs in endometriosis, could potentially be useful as biomarkers of endometriosis. And yes, when we screened for all the known microRNAs, we found some that were increased, some that were decreased in the circulation of women with endometriosis. And when we looked to see if we could use those differences to develop a biomarker test for endometriosis, well, indeed, when we looked at our first training set, we asked if we could take a few microRNAs, and here we used 6 that we found could perfectly predict whether someone had endometriosis or not. Of course, when you devise based on the data you have, it needs to be confirmed in the real world setting with a new set of patients. And indeed, when we use the same formula, the same microRNAs and the same paradigm, we could see that it had a very high sensitivity and specificity for predicting endometriosis in this receiver-operator characteristic curve. So we have a very good test that can predict endometriosis. This has been licensed to a company who's developing this for commercial use. But of course, those microRNAs aren't sitting there in the circulation waiting for us to develop a biomarker test. They're doing something. We looked at these microRNAs to see what else they might be doing in the body. And here, when we looked at their effect on inflammation, we treated macrophages with microRNAs that are either increased or decreased in endometriosis. And the black bars show mimicking the conditions of endometriosis, either increasing microRNA 125 or decreasing microRNA LET7. And what do we see with the black bars where we mimic the conditions of endometriosis? Well, we see these macrophages start making more TNF-alpha, more IL-1 beta, more IL-6, more IL-8, all of the inflammatory cytokines that we know are associated with endometriosis. So these microRNAs might be one of the mechanisms by which endometriosis results in systemic inflammation. We also know women with endometriosis tend to have a lower BMI. They're thinner and have less body fat. Here we show in an animal model that we can recapitulate that by creating endometriosis in mice. It's not that endometriosis is caused by low body weight. It's just the opposite. That's not a risk factor. The endometriosis itself leads to a lowering of the body weight. We take mice, we do a sham surgery versus create endometriosis. Those with endometriosis have a lower weight, lower body fat. We trace this back to an effect on the liver. There is a metabolic phenotype in endometriosis. And here, I won't go through all the details, but we looked at a lot of genes that were differentially expressed in the liver. I don't show you here either that much of this is driven by microRNAs, but these changes in gene expression in the liver will be expected to lead to a different metabolism that results in a lower body weight. So endometriosis affects the liver, which then leads to a lowering of body weight. It also affects fat tissue. This metabolic phenotype is manifest in part through an effect on fat. Here we show what happens when we mimic microRNAs seen in endometriosis to fat cells. It changes leptin, adiponectin, IL-6, hormone-sensitive lipase, genes that are known to mediate fat accumulation. It also changes the stem cell content of fat. I won't go through all the details, but suffice it to say that changes in stem cells and microRNAs lead to this metabolic phenotype in endometriosis that causes weight loss. There's an effect on the brain and behavior. Again, we use our mouse model to show this is cause and effect. That when we create endometriosis, we see changes in gene expression in the brain, as shown in the upper left. We see changes in electrophysiology, synaptic connections based on creating endometriosis. And we see those result in changes in behavior. In mice, we measure anxiety by seeing how much they stay in the corners of a box rather than traverse across the middle. And in mice with endometriosis, they're more likely to huddle in the corners. The center of this box is lighter than the center of the box where mice only had sham surgery. Again, time in the center of the box is decreased. They're more anxious, and this is manifest, becomes statistically significant within about 6 weeks of creating endometriosis and persists as long as we measure it. We also look at pain sensitization. Here we take the paw of a mouse and we put it on a warm surface and see how long it takes before that mouse realizes it's a warm surface and removes the paw. The mice with endometriosis, shown in red, remove the paw faster than those without endometriosis. They are more sensitized. We also look at depression. To measure depression, we hold a mouse by its tail and we wait to see how long that mouse will struggle to get away. The depressed mouse is more listless, lies there without struggling to get away. And you can see this so-called immobility time is increased in mice with endometriosis. And some of this is, again, through effects of microRNAs on brain gene expression, which changes the electrophysiology, which changes the behavior. We know women with endometriosis are more likely to be anxious and depressed. This is a result, it is a direct manifestation of the disease. Finally, I want to show you some new data. This was just accepted in the American Journal of OBGYN, as in press right now. We looked at the effect of endometriosis on the development of cardiovascular disease. There's been some epidemiologic data that suggests that women with endometriosis are at higher risk for cardiovascular disease. Is that our surgeries and our treatments and our medications we use, or is it the endometriosis itself, the inflammation and other damage caused by endometriosis? Well, in the mouse model, we can prove that. There's nothing different about these mice, except some we gave endometriosis and some we didn't. If we look at oil red O staining, that measures lipids in the vessel wall, it's increased in endometriosis mice in the aorta. If we look at blood vessel size, you can see that in the endometriosis mice, this is again the aorta, the aortic root thickness is quite a bit larger. The plaque builds up in these vessels and makes the lumen smaller. So lumen size is decreased, aortic root wall thickness is increased. There's more atherosclerosis restricting these vessels. So indeed, endometriosis actually causes atherosclerosis. So I think when we look in the pelvis and the endometriosis we remove in the pelvis is important, and it causes pain and it triggers this cascade of events, but it is the tip of the iceberg. There are all these whole body manifestations that, at least in part, are mediated by stem cells and epigenetically through microRNAs. The whole body is affected. It truly is a systemic disease. Now, I want to spend the last couple minutes just talking to you about something we've just explored recently in a paper that just came out within the last few weeks from our group, getting at why would cells leave the uterus and survive? What is it about the uterus that leads it to form endometriosis? Is it just simply that we menstruate? Well, other tissues shed some cells that don't thrive and continue to survive elsewhere in the body. We suspect that there's a unique role of the uterus as a stem cell source, that stem cells travel from bone marrow to the uterus and out of the uterus to perhaps have a beneficial effect in some ways, not in endometriosis where it's a negative effect, but maybe bone marrow uterus have a special relationship, a unique propensity for for these cells to travel. We used a kidney injury model. The first thing we did was looked at survival after acute kidney injury. Here we used ischemia reperfusion injury of the kidney, clamp the vessels that go to the kidney. Here's a sham surgery. The mice, all of them survive. If we cause kidney injury, you see we drop off, that we lose some. The survival curve shows that we lose many, usually within the first few days, with an intact uterus. If we do a hysterectomy, though, and they have no uterus, the survival's worse. More of them die. Now, is that just that we've made it harder on the kidney by doing the hysterectomy? Have we somehow damaged blood supply to the kidney? I don't think so. The other experiment we did was look at whether bone marrow cells travel from the, uterine stem cells travel from the uterus to the kidney. Here we used DS red labeled uterine stem cells, and we looked at the kidney, their uptake and incorporation in the kidney in a sham surgery after kidney injury. After kidney injury, many more of these cells are attracted to the kidney, uterine stem cells. We also looked when we did unilateral versus bilateral kidney injury. And the unilateral injury, the stem cells preferentially migrate to the injured kidney. These, again, are uterine stem cells migrating to the kidney. And when we do a bilateral injury, we see actually more taken up by males than by females. When we put uterine stem cells into the circulation after kidney injury, the males take up more in their kidneys. And we think that's because the females that have a uterus already are supplying some of these cells. The males don't have that supply of uterine stem cells, so they even take up more. The bottom in E, we show that when we look at the whole body after injecting these uterine stem cells, they home to that site of injury in the kidney where they engraft. And here this measures on F and G. We see the control versus the injury model. Those cells engraft much more. On the top of that shows many more of these uterine stem cells migrating to the kidney. Here the red labeled uterine stem cells are shown in the second column. Various markers of kidney tubule structure are shown in green, and we merge those. You can see these uterine stem cells are actually incorporating into the kidney and helping to repair and regenerate the damaged kidney tubule. And finally, does it change creatinine levels and survival? Well, the creatinine levels were the same at day 0, the day of injury, but within 2 days, those that got the uterine-derived cells had better, lower creatinine levels than those that didn't get the uterine-derived cells, and their survival's better. You can see after this kidney injury with hysterectomy, the survival, as I showed you earlier, if we do kidney injury, hysterectomy, and give them uterine-derived stem cells back, the survival is much better. So it looks like uterine stem cells are there to help promote healing in other organs. Here we look at kidney. It's embryologically related. It's close by. It was a good place to start, but I suspect that this occurs in other organs as well. There's a special relationship between the bone marrow, the uterus, where bone marrow cells, stem cells go to support pregnancy and uterine remodeling, and then the stem cells from the uterus can travel to other places. It may be another stem cell store that helps repair other models or other tissues, such as the kidney. So are humans predisposed to endometriosis due to what's really a normal stem cell flux in and out of the uterus? That special relationship between bone marrow and uterus. I showed you earlier, the bone marrow and the uterus are the key places where stem cells go when we transplant bone marrow, and cells from the uterus can come out and repair other organs. Is that predisposition for these cells to come out of the uterus and contribute to other organs, does that make humans more prone to develop endometriosis? I leave you to consider this. This is a theory we're working on today. It may explain why, of all things, stem cells from the uterus may predispose humans to endometriosis. It's because of this natural stem cell flux. So I'll conclude with this side. Endometriosis is a systemic disease. the systemic nature of the disease may explain these extensive symptoms that we see with endometriosis affecting multiple organ systems. The depression, the anxiety, the weight loss, the inflammation, the bowel and bladder symptoms. And it's stem cells and non-coding RNAs, including microRNAs and inflammation, that are the mechanisms that mediate these long-range effects. Stem cells play an important role in endometriosis, as do microRNAs, and I think explain some of the intricacies that we see in this very complex disease. Thank you again for letting me share my data with this group and share some of the exciting new findings we've had just being published this year. It's been my honor to present to the Endometriosis Foundation. Thank you.
Dr. Taylor, I think everybody was very interested to see how mice reacted, how they measured the stress levels and the anxiety level of the mice. Of course, the stem cells have technology, and this perception has replaced our metaplastic issues that we are referring. Our next speaker will complement some of the issues that was brought by Dr. Taylor. He is going to focus on the role in the clinical aspect of stem cells to the patients. Dr. Ray Gary, a very respected surgeon from England, professor at the University of Western Australia, Perth, for the last 6 years. He has over 100 peer-reviewed papers published, including most respected 6 randomized controlled studies and multiple contribution to Cochrane reviews. Ray Gary, you have the floor. Thank you for being with us again.
Okay, thank you very much, Tamir. Actually, not quite 1,000. I've done 180 peer reviews. 100 would be amazing.
Oh, I'm sorry.
Anyway, gosh, what a series of absolutely brilliant talks. But I confess, I also had a heart-sink feeling about the complexity and the difficulty of all this. It's not at all easy. I'm, as a humble clinician, I hope to present a little something which might help amplify a little bit of what Hugh Taylor was telling us in such dramatic and sound scientific form. I was a clinician and went to Australia very late after having spent my time doing a lot of clinical work, to find that I had to modify what I did when I went to Australia, funnily enough in the same town as John Jokovic. And my idea was that I would look at menstruation, and I hope you'll see the relevance of this shortly, but I wanted to look at the physical changes of menstruation. And I'd done a few papers about this. And I used 3 different techniques: hysteroscopy, ordinary histology and immunohistology, and electron microscopy, to look at what was happening during menstruation. I mean, there's so much been written about this, but strangely enough, nobody, as far as I know, has actually looked in this way with hysteroscopy. Anyway, the first thing, and a very simple thing, an obvious thing, was that the endometrium is shed in little pieces. It doesn't come off in a great big sheet during menstruation. Pieces fall off, and some of this falling off coalesces. And here you can see very obviously some areas have fallen off and some areas still intact. And this is obviously a good thing, the minimizing the area that's exposed at any given time. And if you look carefully, you will see here's a non-shed area, and in the shed area, the material from the endometrium is shed differentially. And you can see on both the electron microscopy and hysteroscopy that there are the glands. It's as if the glands were degloved and they stand proud and are left above the endometrium. And of course, the most self-evident phenomenon in menstruation is bleeding. And this bleeding is not, as so many cultures around the world, to rid the woman of evil humors or anything like that. It is obviously just occurs because during the shedding, the blood vessels supplying the endometrium are torn, and therefore you clearly get bleeding, which is self-evidently the most common symptom of endometriosis. Now, if you look at the electron microscopy at the moment of bleeding, you can see this same phenomenon. Here's a blood vessel with lots of red blood cells. But almost as soon as the exposed surface of the endometrium, almost immediately, it becomes covered with a fibrin matrix. And as you can see, this matrix actually traps many cells within it. And it's not just red blood cells, it's virtually every cell. I think these are macrophages, but there are many different cell types in the blood, and these obviously escape during menstruation, and a proportion of those will be held up, will be stored in this area. Now, as Hugh was telling about, if you going to repair a wound or repair any injury, mostly in the adult, we assume that cells are going to be replaced by mitotic cell division, where a single cell, the chromosomes line up, paired, and then reproduce, and you get two identical daughter cells. You start off with one cell, you finish up with two cells, both of which would have the same identical chromosome constitution. And this is the normal way we anticipate healing. This other way of producing new cells is from stem cells, cells that have not differentiated and have the potential to go in a variety of different ways. And clearly, one of those ways is to produce epithelial cells, another one to produce muscle cells, fibrous cells, whatever, these pluripotent cells. Now, we thought for a very long time that this stem cell activity was almost confined to the growing fetus and early infancy and in the bone marrow. But as much work, particularly that done by Hugh and his co-workers, have shown that there are lots of stem cell activity throughout the body, particularly in the endometrium. Now, when we're thinking about repair of the endometrial surface once it's shed, we have paid a lot of attention to these residual glands, and the anatomy of these glands has perhaps not been remembered properly, because these are big columnar cells relatively. They're highly differentiated. Some of them have microvilli and some of them are these fibril things. And these cells are what we call terminally differentiated. If they were going to produce another cell, it would be another cell that looked like this. They can't really go backwards to a more primitive shape. So every gland that is there looks like this to start with. Now, the accepted theory of endometrial repair goes back as far as 1924. And Novak and Tallinn, two very prestigious American gynecologist pathologists, stated that the source of the new epithelium is chiefly from the epithelium of the basal stumps of the uterine glands. And the basic idea is that those glands, like I've shown you, the cells just divide and spread out across the surface of it. And that has been the basic theory, which was certainly what I was taught. I think it's still in textbooks, but it's certainly the basic idea of how endometrial repair. And the importance of this is there are therapeutic things, particularly endometrial resection or ablation, where the aim of these techniques is to get rid of the whole of the basal gland, and therefore the endometrium will not regrow, and therefore you will not get menstruation. So that has clinical as well as theoretical consequences. Anyway, this was their basic paper in 1924. But bizarrely, even in that paper, strange to say, Novak and Telind reported that mitosis was not a very frequent occurrence and appeared much more often when the epithelial layer is already complete. Ferenczi, who did electron microscopy, also claimed that the surface was due to division of cells, but again, couldn't find any evidence of mitosis. So basically, although this theory persisted for 80 or getting on, well, I suppose it was almost exactly 100 years, it couldn't have been true. Even from the original paper, they actually dispute their whole thing. Now, what we found on hysteroscopy is that on day one, you can find areas that are obviously in the process of shedding. And this is looking at the glands, which are semi-translucent from end on. This area up here hasn't begun to shed, but importantly, this area is already healing. So this concept that we found that not only do the endometrium share in patches, but some patches are healed long before other patches are shed. Now, this teleologically is a great idea. It means that there's a minimal area actually exposed to bleeding and potential infection. It minimizes. But I think it's been grossly underestimated how quickly this response happens. And here on day one, we have a patient with that fibrous matrix with already a new layer of surface epithelium. But that surface epithelium doesn't look anything like this. This couldn't become this. And I'll point out, we'll look at this in a moment or two. And if you take a proliferation marker, this is Ki67, and every little brown spot here indicates a cell that is in active division. And in early proliferative phase, the first half of the menstrual cycle, many, many cells are actively dividing. In this phase, stained with the same stain, you can see one cell there and possibly one there, but none of these cells are a result of proliferation, are a result of cell division. So the question is, how do these new cells get there very rapidly within hours, possibly even within minutes, without any cell division? And this was a little bit of the science. We did formal cell counts of proliferation, obviously in the proliferative phase, lots, secretory phase, lots, day 28 still, but in menstruation, there was virtually no cell division. So it wasn't just me that had noticed that this theory was perhaps wrong, because this guy, Papanikolaou, wrote in most of you will know this chap not through this work, but through the fact that he developed pap smears. So he was obviously infinitely famous eventually, and this work probably got put on the back burner. But from his paper, what he showed was in an experimental animal model made to menstruate, the cells lining the epithelial glands all shed into the cavity. And then a bit later, new cells differentiated, lining this from superficial cells on the surface. So this isn't by cell division. This is differentiation. So my question is, could we show any evidence of this happening in humans? And here's this case. This is obviously day one. Here is part of the endometrium, and here's bit that's fallen off. This rather resembles the findings that Papanicolaou found. Here's another gland on day one, again, with cells being shed off, being low, very small cells, and then bigger cells. And if you're ever allowed to base a theory on one image, which clearly good scientists aren't and bad clinicians do, I think my theory that this is encapsulated in this one picture. Here, cells have been shed. Here, some very narrow new cells, and it looks as if they're being pumped up. It looks as if within a very short period of time, a new layer of apparently similar epithelium is produced. And I suspect that mostly this sort of change has been totally missed, because you can only find it if you do hysterectomy specimens during the first and second day of menstruation. And for any number of reasons, which I'm sure you're very able to work out, very few hysterectomies are done at this time. And I was only able to do this study because of the stoicism and the willingness of a number of Western Australian ladies to say, oh, whatever, you can do it when you like, and didn't mind. So we were able to get these fairly difficult to obtain specimens. Now then, how do these cells come? This is a composite image that we took, obviously at the time of menstruation. And on the left of the screen, you can see the still unshed secretory endometrium. It's gone here, and a bit's going in the middle. Now, what this side is stained with is CD34 antigen. And that's used mostly to show small blood vessels in tissues like the endometrium, and all these are small blood vessels. But this isn't. You can see there's a zone in the stroma of these cells expressing the CD34 antigen. And here's another one again. This is day one, the epithelium's just shed. And around there's the zone in the stroma, and here's the blood vessels, coiled blood vessels cut multiple, but here's the glands surrounded by this antigen CD34. And here is an immediately premenstrual case of, again, the glands totally surrounded by these cells. Now, then, the question is, what is CD34? And this was where my lack of good science, and we could really do with Hugh here to tell me, but what I know is that CD34 is one of the most used markers of stem cells. And so it's possible, although the functions of CD34, there are many other functions, and I don't know what they're doing there, but the fact that they are consistently there during menstruation, immediately prior to menstruation, suggest that it may be a stem cell type function. And I then asked myself, could the same thing be happening in endometriosis? And here is a gland in an endometriotic deposit, and here epithelium is clearly being shed, and here it's getting ready to be shed, and bits of it are coming off here. We wondered whether that could just be a duff processing thing. We might not have handled the tissue well. Here's a better one. Here's somebody with a uterosacral ligament deposit, which I excised. And here, this is on day 2. And here again, you can see that the endothelial cells are fallen away into the cavity. And if we look under higher power, we can see that underneath there are these flattened cells, just like flattened cells we saw on the surface, ready to replace these shed endometrial cells. Now, this is a superficial implant on a uterosacral ligament, and you can see it's surrounded by densely staining CD34. Again, this might be poor quality, but here's one we did. This is non-menstrual, but this was a stage 4 endo, which we excised and took out the rectum. In the middle of the rectum, there was this implant, again, completely surrounded by CD34 expressing cells. Now, those are the blood vessels, but these aren't blood vessels going all the way around. So the question is there. So I'm not producing, Hugh and others have produced very scientific ways of suggesting that stem cells have a role in the etiology of endometrial repair and of endometriosis. So what we can say for sure is epithelial cells of the glands in the endometrium are shed. They are not retained, and they are not the source of the new surface epithelium. Epithelial cells making the endometrial implants mirror this change and are also shed and regenerated. They are replaced by a very rapid process, by a process that did not involve any mitosis, cell division. The process involves differentiation from precursor cells. These may already be in the tissues adjacent to healing areas, or as you said, they may also arise in the bone marrow and the very act of menstruation, bringing these cells to the area which they're immediately needed. So the stem cell bit of it, CD34 antigen, is a marker for bone marrow derived stem cell progenitors. And glands in both the endometrium and endometriosis are surrounded by these cells. The question, therefore, and the suggestion, therefore, is that new epithelial cells may arise from stem cells. The bone marrow may be the primary source of endometriosis throughout the body, but endometriosis may not be, the conclusion is that even our clinical efforts to completely excise endometriosis may not be successful for etiological reasons, not just that we're not very good surgeons and we can't get rid of it all. That obviously may happen as well. So, in conclusion, I am suggesting that endometriosis may result, in part at least, from homing of stem or progenitor cells from the bone marrow to sites in the pelvis and throughout the body. Thank you very much.
Thank you so much, Ray. For the audience, there were almost 2,000 registrants to this conference. For those who couldn't make it to be with us, these two presentations, particularly, are so complimentary. It really tickles even the most skeptical brain. I propose you can go back and watch these again from our site. I'm very excited to hear these two presentations. Thank you, Ray. My next presenter is Dr. Togas Twandi from the Department of OBGYN at McGill University. He is the professor and the vice chair. He is internationally known endoscopic surgeon, specializing in reproductive endocrinology and infertility. Dr. Tolande has way over 300 articles and 60 book chapters. It's a pleasure to have him today. He is going to teach us his lessons from extrapelvic endometriosis. Thank you, Togas.
Thank you very much, Tamer. And I'm pleased to see all my friends on the small boxes on the computer. So this is a clinical talk. Is lesson from extrapelvic endometriosis. So this is my conflict of interest. I'm the editor-in-chief for Journal of Obstetrics and Gynecology of Canada. We have talked about pathophysiology of endometriosis. To simplify it, the first on the left side is the in women with no endometriosis. So retrograde menstruation of Samson. So the cells from the blood and cells, endometrial cells, and maybe stem cells, it go inside the pelvic cavity. In women with no endometriosis, they will clear it by a process of apoptosis. In women with endometriosis, the endometrial cells and stem cells will stay and grow. Will undergo a process of angiogenesis, neurogenesis, and causing inflammation. The retrograde menstruation, so the theories, there are several theories, of course: retrograde menstruation, hematogenic spread, lymphatic spread, coelomic metaplasia. Coelom is the embryologic cells from the peritoneum or pleura or pericardium. So if that's true, why we don't see too many endometriosis in the pericardium or in pleura? And immunologic theory and multifactorial. If we do laparoscopy during period, we will see blood in the pelvic cavity, small amount, large amount, but we always see it. So far, I haven't failed to see blood if you do it during the menstrual period. The question is, why these cells, the blood and the endometrial cells, maybe stem cells, in some women, they don't have endometriosis, and others, they do have endometriosis. Must be something else. So we'll talk about two cases, actually, of a patient with extrapelvic endometriosis. The first one is 29-year-old African-American woman. She had cyclic abdominal pelvic pain, and she had a tender umbilical mass. You see on the right-hand side, this is the umbilicus. There is a tender umbilical mass, and it became bigger during the period and more painful during the period. So what are the possible causes? The first one is, the most common is keloid, especially in African-American women. It could be keloid. But she has never had any injury to the navel, to the umbilicus. No belly ring, no surgery, nothing. So it's unlikely. Number two is Sister Mary Joseph nodule. Now, Sister Mary Joseph is a nun, a Catholic nun in Rochester, Minnesota. She was the assistant of Dr. Mayo. And she realized that women and men with abdominal or pelvic cancers, they tend to have a nodule at the umbilicus. So after a while, Dr. Mayo called it Sister Mary Joseph nodule. This is due to metastasis of the cancer from intra-abdominal cavity. Our patient is a young female, healthy. It's unlikely to have Sister Mary Joseph nodule. The other possibility is umbilical endometriosis. The most common cause of umbilical endometriosis is when the surgeon removed endometriosis tissue from the abdominal cavity by laparoscopy through the umbilical trocar without using a laparoscopic bag. So the tissue will have a contact with the umbilicus, and the contamination of the endometriosis cells will make her to have umbilical endometriosis. Again, our patient never had laparoscopy, so most likely she had primary endometriosis. And sure enough, when we did when we look at the pelvic cavity, she had bilateral endometriomas. So it just didn't happen to have umbilical endometriosis without pelvic endometriosis. We did surgery, and this nodule is just the tip of the iceberg. The nodule is much bigger under the abdominal wall. We excise it, and it shows endometriosis on the right-hand side. And she also had stage 4 endometriosis, including endometriomas. So the extrapelvic lesions of endometriosis, in this case, umbilical endometriosis, suggest the presence of pelvic endometriosis. On the other hand, we can also say that the pelvic endometriosis is responsible of her to have umbilical endometriosis. So we go back to the possible etiology. Retrograde menstruation, yeah, it's a common phenomenon. I think every women have retrograde menstruation. So the question is, why in women with no endometriosis, the cells disappeared? Hematogenic spread, lymphatic spread, possible. Coelomic metaplasia, in this case, possible. Immunologic theory, stem cell theory, possible. All multifactorial. So most likely retrograde menstruation, this is not the etiology, plus something else. Talking about keloid, we did a study a while back looking at all women with keloid, and we did surgery by laparoscopy. And we found that women with keloid tend to have more adhesions, intra-abdominal adhesions. We also found that keloid is more common in African American women, in this case women, of course, because I'm a gynecologist, and Asians than whites. The theory is related to tumor growth factor and other growth factors. We also look at the lateralization of endometriosis. Actually, it started with Paolo Fercialini from Italy, and he reported that endometriosis tend to be found more common on the left side. And then in 2000, he also published that urethral endometriosis tend to be more common on the left side. We did the same study. We published several papers. This is one of them. Also, we found that endometriosis tend to be more common on the left side. And we thought this is due to the presence of sigmoid colon on the left side. So the peritoneal fluid movement on the left side is more stagnant. There is a delay in movement of the peritoneal fluid. Let's go to the second case. This second case is 34-year-old woman, again, with dysmenorrhea, dyspareunia. In the past 12 months, she had right chest pain with each period. And then she ended up in the emergency room with a full-blown pneumothorax, and she was treated with a chest tube. This is just to illustrate a pneumothorax. In this case, is on the left side. She underwent thoracoscopic surgery, and the thoracic surgeon found lesions that he biopsied and pathologists say consistent with endometriosis. So this is thoracic endometriosis. We did laparoscopy and we found stage 3 endometriosis. And luckily she conceived 6 months after laparoscopic surgery. In this case, because the pneumothorax kept coming back during period, we call it catamenial pneumothorax. So we can have catamenial epilepsy, that means epilepsy attack during the period, catamenial migraine during period. So this is catamenial pneumothorax and suggests the presence of pelvic endometriosis. This is the pathology of the pleural biopsy. So we look at the relationship between catamenial pneumothorax and non-catamenial pneumothorax and endometriosis. It was a case control study. At that time, we found 21 women with catamenial pneumothorax, and at that time, this was the largest series in the world. We also compared it to 21 women with pneumothorax, but not catamenial. And we found right pneumothorax in 95% of patients in the study group. That means the catamenial pneumothorax, and 57% in the control group. Pneumothorax without related to menses. Found complete collapse of the lung in 2 cases. And most cases had apical pneumothorax. In the control group, so no catamenial pneumothorax, just pneumothorax, none of them had thoracic endometriosis. In the study group, 60% had thoracic endometriosis and 94% had pelvic endometriosis. So again, you don't have just endometriosis in the thorax without pelvic endometriosis. Again, just to show you, in women with catamenial pneumothorax, mainly on the right side, and non-catamenial pneumothorax half-half. This is the biopsy suggesting endometriosis, 60% in catamenial pneumothorax and 0% in non-catamenial pneumothorax. So right pneumothorax is predominant in women with catamenial pneumothorax, and over a half of women with catamenial pneumothorax have thoracic endometriosis. So endometriosis plays an important role in the pathophysiology of catamenial pneumothorax. We also did a systematic review, and we found that over 3/4 of women with catamenial pneumothorax have diaphragmatic endometriosis. This is a white lesion under the diaphragm. This is another image of diaphragm with endometriosis. And 95% of endometriosis on the diaphragm is on the right side. The reason is because the surface of diaphragm on the right side is much more than the left side. And also, if you look histopathologically, the right diaphragm contains more lacunae, small holes. So the cells might also go into the pleura and to the thorax. That's also explain why right pneumothorax is more common. Right pneumothorax is more common than left pneumothorax. This is back to the same questions. Look at the peritoneal fluid movement. This was published a while back by others in women with cancer. The peritoneal fluid movement, it starts from the left side. So, and the fluid goes up under the diaphragm and back to the right hemipelvis. The peritoneal fluid will bring cells, endometrial cells, maybe stem cells, all the way up. So that might explain why you have endometriosis under the diaphragm, and might also go to the thorax. Endometriosis on the appendix is, we can argue that the endometriosis, the appendix is pelvic organs. So that's why endometriosis tend to occur on the appendix. In this case, the appendix is attached to an ovary with endometrioma. That's why we can see the chocolate colored material here. So if we look at the pathophysiology of endometriosis, we take the lesson from extrapelvic endometriosis, we come up with the same thing. So retrograde menstruation is true, but I think this is a normal occurrence in all women. So all women have retrograde menstruation. The question is why they have endometriosis, in women with endometriosis and no endometriosis in women with no endometriosis. Must be something else. Coelomic metaplasia, unlikely because it's more common on the right side. I think is immunologic theory, maybe stem cell theory as well. Or could be multifactorial. So retrograde menstruation and something else is the possible etiology of endometriosis. It is still unclear, and further research like what Hugh Taylor is doing and Ray Gary is still needed. I'm going to stop right here, and thank you for your attention.
Thank you so much, Dr. Tolandi. I guess the next speaker on the schedule is myself. As I checked, we are a little bit late, but my talk is going to be on the thoracic endometriosis. Just give me a second, please. Do you see my slides? I hope you do.
Yes.
Okay, thank you so much. Yeah. It's mind-boggling. I am learning, and I hope you are too. Again, for further reference, these talks will be available in our video library. Please come back. I do come back and see some of these talks again. Again, to stick to the conference theme here, there, and everywhere, thoracic endometriosis, even though it's rare, probably it's more common than we know. That's why I mark this subject as a next frontier and connect it to peritoneal pores, to diaphragmatic holes. And you're going to see why I'm doing this. As you know, I have a conflict of interest. I'm the founder of this organization and one of the founders, let's say. We initiated 2006, and I do listen to my patient and I give them the microphone. Many times, if we made progress, it's the patients that talked, not us, because when we talk among ourselves. When patient talks, the public talks, especially when you encourage people with public face. I think they become instrumental of why this foundation became so efficient and effective to create awareness. My talk, my objective is walk you through the background history on thoracic endometriosis. I will connect it to peritoneal disease to a degree, and then our dual compartment approach at Lennox-Hill. This is not a new concept. It's been, obviously, the history goes back to the first man who really defined thoracic endometriosis. I will come to that. So this is a trivia question for you. I have two pictures. Why does this beautiful buffalo go down with single arrow? And where does this Indian really shoot at? What's he aiming? The eye, the back, the where? This is one. I'm going to answer this at my last slide. And the second is, why does this 6 to 8 ton elephant swim? You guys can think about this. So, as you know, Dr. Jovic from Western Australia went through these picturesque review of the people who affected us. I came to a saying just yesterday. I like to share it with you. When you think you know, you stop learning. I put this slide that we all learn from others, and we put something to the pot, and others learn from us. And I salute Dr. Gomel, Dr. Martin, Dr. Rich, Dr. Nezat, whose writings have affected me. Certainly, Samson, who nailed the word endometriosis that you've been hearing all today. I won't go further on that. My affiliation goes that I'm sure you know all these characters. There's, with the best smile, Ray Gary, Chris Sutton, and certainly Frank Lofer is here, Arnaud Wattier, myself. At that time, I was not all white. Certainly Dr. Rich and Dr. Liz and Donet, and to add Dr. Redwine. Their writings have tremendously affected me. That was 25 years ago in Brussels. And certainly, obviously, Kurt Sam, Jordan Phillips, and Bruja over there. Thoracic endometriosis was described as early as 1912, during the time of Sampson. By heart, he documented pulmonary lesions consisting of endometrial glands and stroma. That was it. Only 25 years later or so, Schwartz described a woman with inguinal node endometriosis with hemoptysis, spitting blood, lung tumor that bled every menstrual cycle. Well, it was Elmer, though, in 1958, almost 50 years later, described the entity of recurring spontaneous pneumothorax in women concurrent with onset of menstruation. Elmer was an army surgeon from Ohio who was General MacArthur's surgeon in Korea War, and later in Vietnam, he was very instrumental advising the infamous TV series MASH. For those who remember those, everybody knows MASH, and Elmer was one of the advisors to that show. He presented this 35-year-old who had experienced 15 episodes of spontaneous pneumothorax, always occurring at menstruation. And thoracotomy revealed 2 centimeter hole in the right diaphragm at the site of endometrial implant. Subsequent laparotomy disclosed pelvic endometriosis. Later, Maurer postulated that recurrent pneumothoraces resulted in the passage of air through the genital tract into the peritoneal cavity via diaphragmatic defect into thorax. The recurrent nature of the condition, some patients had up to 40 episodes. But it was Lillington who really, I'm not going to go to Sampson. We heard too much about Sampson. We respect, we hats are off to him. It was Lillington who really used the term first time, catamenial pneumothorax, in 1972. It's almost 80 years later from the first time Elmer described. And he postulated a valve mechanism. You see this is pleural view from the thorax. You see a bleb here and 2 other locations. This is endo. This is my patient. There's no hole here, guys. And this is a membranous, very thin layer, most likely serve as a valve. It opens up during the pressure differences in the pelvis and then immediately closes. As you saw from Dr. Gary's presentation, how quickly stem cells come to the rescue of repairing, whether it is endometrium or anywhere else. So this slide really depicts the pressure in the endometrium during period, peritoneal cavity -1, and thorax is minus intrapleural area -3.7. The dynamics is like a suction pump when the pressure changes happen. This is very physical reality. So let's come to up to date. This is just published January 2022 from Annals of Thoracic Surgery. It's not coming from gynecology or from our publications. So they reviewed thoracic endometriosis. They meta-analytically reviewed 452 studies they have identified. Only 46 of them they picked, and they included they excluded studies less than 25. Only 25 studies popped out, which had more than 25 25 studies included 732 patients. The issue here was the people who really wrote that only 7 of these 25 studies were gynecologists. And out of these 25 studies, only 7 had patient population more than 25. So only 2 of them was from North America. One was Dr. Tulandi, like you just heard his beautiful talk, and the other was Dr. Nezat. Good thing about them is they both suggested combined laparoscopy with video thoracic approach. So no being gynecologists and endometriosis specialists. And these are the studies. Only 7 of the studies had 25 patients or more. Fukuda from Japan, in 2 publications, he published almost 190 patients. And these publications were 7 from Japan, 3 from Korea, 3 from Italy, 4 from France. And only 4 of them suggested dual compartment combined approach for thoracic endometriosis. That's the reason we're presenting this, because this is an area that needs to be explored in detail. There's so much to be gained by looking at the problems that thoracic surgeons are having, recognizing endometriosis. Also, the reason is, if you look at these recurrence rates, for 40%, 20, 30%, 35%, there's a high recurrence rate on these patients. And even though what was the preferred surgical technique, diaphragmatic anomalies were almost 85%, concomitant stage laparoscopy was 52%, and up to 80% of the women with thoracic endometriosis syndrome present with concomitant pelvic endometriosis. In our series, this is almost 100%. There's problem in the pelvis. So the symptoms of the patients were almost 90% of the patients had catamenial components, some with hemoptysis, some with other, but more of them with catamenial pneumothorax. And only 19% was non-catamenial, as Dr. Tolandi's touched to this issue, them being on both sides, but catamenial pneumothorax in our series of almost 50 now, close to 50, everything was always on the right side. So
my husband wanted to take
listen
the kids
to this
out
now.
for a
This
walk,
is
and it was a beautiful day out.
I'm putting this video because this woman became very effective in spreading the word on catamenial pneumothorax by her experience. She's articulate, and she really went full throttle for awareness campaign. That's Zara Albach.
My husband wanted to take the kids out for a walk, and it was a beautiful day out. And I remember walking down, I'm like, I can't even walk after a few steps. Like, it was really hard for me to walk. This is the only way I can explain it. I feel just a shift happen in my chest. Pressuring, pushing down on the actual lung, the balloon that's being pushed down.
We treated her for that, and she initially did very well.
So she cannot walk. She feels a shift. It is like, patients describe their symptoms very differently. Some typically, but they really use the right word. Some feels rice crackers, like a paper bag popping, or tire blasting, losing air, sudden sharp pain going to our right shoulder and scapular region to their ear, and shortness of breath, anxiety, hyperventilation. So this is a figure that was drawn by this particular patient who was a gymnast and having this problem. And as you see, the lung has collapsed. She's feeling pain. It's her scapula. You hear it. and that's her little heart there. But this is what she did. She was doing cartwheeling. She would be turning upside down because she's a gymnast, and she feels significant relief of air back, pushing the air back to her peritoneum, and then she would be relieved and until next period. This was an interesting patient for me. I will always remember, and I'm sharing with you. And this is the rest of her story. This is why this disease is really delayed, and recurrent hospitalization and other complication always happens. This is the rest of her story.
And she initially did very.
Dr. Patton is my thoracic surgeon. He didn't know much about endometriosis, but he learned in a very right way, and he's been very instrumental treating with me many patients together.
Well, what made her case a little bit unusual was that she came back with another one that only happens less than 5% of the time.
Trying to understand what it is in my life that's different that could have caused this. You know, I went through many rounds of IVF. I pumped myself up with hormones. Is there some kind of connection with that? And that's when he brought up catamenial pneumothorax.
She did not have a diagnosis of endometriosis at the time, but it was really the only disease that linked the two.
So it is not really, it's not really 5% like he says. The recurrence is very high in catamenial pneumothorax. Recurrence almost 30 to 50, 60% if it's not treated and not recognized. Many thoracic surgeons are not familiar with this. And this is where everything starts. So basically, Zara Albach did fine, and I'm not going to go over all this video, but the thing is, she's doing fantastic. What she did was extraordinary. She went to, somehow, she connected to New York Times. I have nothing to do with it. And famous writer Lisa Sanders, who does in New York Times Weekend magazine, she published her case. The woman was fit and healthy. Why did her lung mysteriously collapse? Then it was over then. She was picked by major news channels, and it was all about thoracic pneumothorax, which significant awareness was created. And we get so many questions about, people are connecting throughout the world for us for this condition right now. So I am putting this because endometriosis, whether it's in pelvis or in thorax, it's about recognition of the disease. Unfortunately, the present sharp, very high, bright laparoscopic light with red and yellow hues underneath does not let the surgeon understand the pathology here. What you see is glands here and the fibrosis around. You may suspect all these additional stains, but you do not know what the surrounding peritoneum looked like. This is under blue water. You look at these tissues, you may really see wider association of white that you may not see under bright light. This is underwater, under blue water examination that I typically use in every case with retroperitoneal, also blue water, which I call aqua blue contrast technique. So I put these slides because you have to respect the beautifulness of the peritoneum, translucent, transparent, plain texture, no fibrosis, and underneath this retroperitoneal tissue, connective tissue, so beautiful, retracted, it is flexible, protecting the rest, but there are nerves around these vessels. There are nerves on the peritoneum that you do not see. So this is a disease that you see. This is retroperitoneum underneath, how the peritoneum is patched with endometriosis when you put the blue dye. Underneath, you see these holes and thickened peritoneum. This is the pathology we see. And this is how we're going to connect things. So I just put this because all these peritoneum is like a neural network of peritoneal nociceptor nerve receptors. There are sensory receptors that detect signals from damaged tissue. In case of endometriosis, these travel in a trunk to the brain. Obviously, we perceive that as pain. So as clinicians, this is what we see. This is a case we just did last week with ascites, massive endometriosis implants, really, all over. This is the right side with massive hemoperitoneum. Pericardium is involved and left side is involved. Similarly, the right side. I put this because of the Sampson stuff that we are already talking. This is how her pelvis looks also. I mean, it's all over. You just have to recognize all forms of endometriosis is there. Vesicular implants, fibrosis, deep appendix is involved, together with fibroid uterus. And again, this is, you know, I am a retrograde menstruation theory believer to a degree, certainly with stem cell component of it. I do my laparoscopies during the time of periods, and this is what we see. And we're going to come to these holes around the lesion now. So our experience at Lennoxville, until last year, July, we had 37 patients who went combined video-assisted thoracolaparoscopic procedures. This is like 2% of our surgical referral practice at that time, from 2013 to 2021. Now we have more coming, like every week, one case almost. So these patients had profiled, typically it's 36 years old. Incredible. This shows that endometriosis is a progressive disease. This doesn't start at the age of 20, never. It's always throughout the literature, something magic after 35 and between 35 and 40, this pneumothorax issue happens. 13 patients had one pneumothorax, 18 have multiple pneumothoraxes, 2 with hemothorax. One patient had 17 chest tube placed before she came to us. So 90% of the patients had prior pneumothorax because we were a referral center, most likely. No, only 4 patients had primary pneumothorax when they came to us. All had pelvic endometriosis. From these 37 cases, we collected 502 specimens. The way I operate, every lesion is taken out and subjected separately to the point of less than 5 millimeters. So due to our almost one or two borderline cancer every year out of 250 or 300 cases we see, I think this is the right way to do because final diagnosis has to be by pathology. Out of these 502 specimens, thorax represented 10%, abdominal diaphragm represented 16%. The rest was all from pelvis. So the head of the snake is in the pelvis. So again, out of these specimens, 60%, as usual, was positive with inflammation. The rest of the specimen exhausted. My pathologists do not like me because every time I don't see an endometriosis, I ask them to exhaust the specimen. There were 40% almost inflammation fiber, but always there was inflammation. So positivity was 60%. When we look at their pelvis, these patients have 65% of the time they had advanced endometriosis, stage 4 involving pelvis, retroperitoneum, bowel disease, along with umbilical and inguinal. Significant. And 10 of them recurrent endometriomas. These patients later received extensive hysterectomy along with 3 bowel resection and 1 large bladder resection. Only 35% of them had peritoneal excision, peritoneal endometriosis. In other words, catamenial pneumothorax or thoracic endometriosis, 1/3 of it being peritoneal says something to us that there is something else really working with this peritoneal necrotic debris that causes destruction and leads to defects in the diaphragm and leading to holes. And in pelvis, these patients, 64% of these patients had hysterectomy, and you see the rates of bladder and bowel resection. So we see with this group, we see inguinal mass, bladder mass, all these things that you can imagine, advanced endometriosis, and this is the peritoneal endometriosis. So very shortly, I'm just showing you this blue dye technique underwater, how you see these buds float, which otherwise you can't see them due to the pressure of the gas. They will be flattened to the peritoneal surface. But these little buds later bleed. And this is one of my fantastic pictures. This probably represents the stem cell activity of metaplastic activity. We thought it's all stem cell orchestrated inflammatory lesion coming out. And many pictures like that, I have series of them. I love to take photograph. And this is exactly what I do. I put the blue dye underneath and examine, but you see the lesion and multiple peritoneal inflammation. 50% of the time, there is lesion. These are CD10 positive, this area, according to our, not published, but my impression, hope to publish one day when I retire, I hope. But this peritoneum hole disease, not only this, the rest, these holes may lead to thoracic endometriosis. This is, again, look at this. Normal, you don't recognize the peritoneal defects is, oops. And you see the same peritoneum. I hope you appreciate. And there are holes. When you put the pressure, these holes are real holes. And I like to say that it is likely to anticipate these process make holes and be responsible for the diaphragmatic holes. So that was pelvis. By laparoscopy, when we look, what do we see? All 37 patients had liver dome lesions. Most of them were fenestrations and implants. There were also adhesions. And by looking at this, basically, they were all at the central tendon and coronal ligament and right triangular ligament. I'll tell you more about these. And this is an example of adhesions. You don't see any hole, but you see lesions. When you lyse these, you're going to see the holes. Similarly, first you lyse these, the same patient, you see the holes behind. You just have to use special 30-degree angle. And this is a patient we just did recently. As you see, you don't see much. You have to depress the liver with proper retraction and retract the peritoneum diaphragm high above. And this is the central tendon. You bang, you see, usually the lesions are right where the central tendon meets the muscle tissue. And this is not only one lesion, there are three of them here, but you do not know what else is behind this because you can never see the coronal ligament completely, even with the 30-degree angle. So that's why combined approach is ultimately necessary. Another example of the same things that you see, you have to depress, you see large fenestration, almost complete erosion of the diaphragm at the central tendon. So you wonder, you see these fusiform defects of the peritoneum underneath, and then what happens here? Here, again, from below, you cannot tell much. From above, it's the same valve effect that you see. It's the same patient. It's her diaphragmatic view. This is diaphragmatic view from thorax. You can't see much. So that's why it's imperative to look from each side in order not to miss the disease. So these are the holes again. It's the same thing I want to show you, that the same patient that you saw with how these defects I want to represent continues to be perforation at the diaphragm level. More of the same tissues, yeah. So initially, I was courageous enough to remove all these things as much as I can. With my cooperative thoracic surgeon being around, I removed these. In my first 10 cases, liberally. I can't say I was able to remove all of them. That would not be true. But also I repaired them from below. It was not easy. Technically, it's difficult to reach. You need a lot of retraction and very fine needle handling because liver is right underneath. And also don't forget this on the falciform ligament meeting the coronal ligament. There's vena cava is right before. Sometimes lesions are right above that. You have to be, you cannot go wild on these excisions. But it's the typical needle handling with our, extracorporeal tying. These can be secured, and we may see these from above later. Yeah. Obviously, later my practice really changed because as we did more thoracic version of these, the robotic used by thoracic surgeons become a major tool for them. But I will tell you the short thing of the inconvenience of robotics also, even though suturing is regular. So when we look at the thoracic area, we remove 48 specimens, and all of them, of these 48 specimens, most of them really came from the central tendon. 25 patients of 37 all had dome lesions. It could be parenchymal, pleural, and obviously diaphragma. You see the holes and a typical version of it. This is the position we give. There was a tattoo here. I didn't want to be personal with the patients for ethical consideration, but it says life can only be understood backwards, but must be lived forwards, it says. But these are the incisions we make. In one sense, this is the position we give, semifolded. Sometimes we don't disturb this position. According to, I have different thoracic surgeons work with me. They prefer repositioning the patient completely semipolar position rather than this adopted semipolar. So if you look at the figure on the left, most of the lesions are at the central tendon. It really represents this much of the area of the thorax. And if thoracic surgeons don't recognize them, they will miss. They will the pleurodesis, put talc or tetracycline that we used to do, and they will leave the case. And they may be doing it 3, 4, 5, 6, 7, 8 times, and these patients come back. This is the distribution of the lesions. Usually, again, from diaphragma side, it's fusiform, all on central tendon. Again, the same patient. So if you look at this case, it is, again, very occult, hideous anomaly that you see here. This is something, if the thoracic surgeon don't recognize this and the atypical vascularity around this patient will never be treated and will be coming back. These are all cases I assisted them to recognize these because they said there's no hole, but I said, this is the hole. You don't realize it's going to open up like a valve with the period. We just did this case last week. I wasn't there. Actually, when we say we did, I got a call. He said, he has this case taken to OR, and it was okay. I said, why don't you record it? So he saw this, and he really resected this area very nicely. But pay attention to this area on the opposite side of the same lesion, what happens next. So he basically cut this longitudinally, repaired this with the robot. What happened was the patient was feeling very well. She had a chest tube. Please note the end of this area. You see my arrow here? So this patient, 2 days later, bang, another pneumothorax. So pneumothorax came back, the chest X-ray shows, we basically missed this. So we should have taken this. I wasn't there, but this patient did not have dual compartments. But she will be taken to surgery in the future if this chest tube does not help. There's disease here, as you see. More the lesions may be from thorax, it may be more identifiable, like that definite holes. There could be a typicality and vascularity like that. In this case, you see the blebs here. In the other side, we do lobectomy, and it's her thoracic appearance. You don't see much. Similarly, another patient with a bleb here, with pleural implant in the back, and they could all be treated. This patient was published on the AAGL journal as a case presentation. So in some cases, I end up doing the resection from above. I think it is a pleasure that thoracic surgeons trust, because his stapler may not be, there will be problems stapling this after excising, or the robot may not be available. So this is one of the cases I have performed and interruptedly closed the whole diaphragm from above with interrupted ethicbound sutures. It's a great pleasure when thoracic surgeon trusts the gynecologist, and it gives me special pleasure to assist them if they don't help them to recognize the lesions. So we could use stapler like this along with robotic closure. I mean, you have to appreciate how beautiful sometimes robot does. We cannot really blame robot for everything and be against robotic use. In thoracic closures, I think it's much more efficient and helpful than laparoscopic closure of the diaphragm. You see how nimble it moves, and it's just that thoracic surgeon should be able to recognize the lesions. The problem is with these chest tubes on and on. This patient came with 18 months of monthly drainage of blood from her chest. This is the tube, and this is what we saw, pleurodesis. It looks like a mess inside, and it's very inconvenient to do this. And this is the pleurodesis they do. Probably if you fix the hole, there is no place, even though it's recommended for pleurodesis, if you really recognize the lesion and take everything out. I kind of am against this procedure. So this is the end of my procedure, almost a presentation. The buffalo goes down because the Indian shoots the buffalo right on the chest. Buffaloes have only one pleural cavity. We have two. With one piercing, they're down. So that's buffalo. The elephant is born with slippery interpleural space. Right after they're born, they go through natural pleurodesis. So the two leaves of the pleura get stuck, and that's why elephants swim, because their lungs never are empty. They always have air in the expiration phase. So I'm closing. I just want to say there is so much more to endometriosis that we see. You saw from stem cell, it's getting really into the DNA of the stem cells and RNA of the stem cells. And we will be probably discussing these in the next decade. But overall, the peritoneal pores from the clinical aspect are the key visual basics of inflammation. And they're best recognized creating contrast retroperitoneally. And excision must include the porous, sick portion of the peritoneum, because they could be transmitting the old growth factors retroperitoneally and innervating the nerves too. I'm not the only one that believes this, but I do. There are others that agrees with me. And diaphragmatic holes are probably secondary to these inflammatory process throughout the peritoneum that takes place. And as final words, thoracic endometriosis is an underdiagnosed condition. Many types, I think, escaped because there are many pneumothoraces that happens, goes undiagnosed until they really blast full picture. And pneumothorax catamenial is 70% of the time is there. I think combined approach is the best way with the right team. And the principal goal is excise and recognize, and also pelvic component has to be treated accordingly with the right team, with the skill and experience of the team. I appreciate your attention. Please, my little advice, my favorite slide lately, always find time for the things that make you feel happy to be alive. I enjoy my granddaughter, Lara, and sharing that with you. Thank you. Have a nice day. And we're going to follow with let me get out of this. Okay, are we still on? Yes, okay. So I think we should take some questions. We're coming to the noon section of the program. We never had questions. Since I was presenting, I so far have some questions. I have Ray Gary here, Dr. Rich. Harry, can you unmute yourself with Togas also? I have Dr. Malzoni, Dr. Jovic, oh, still with us. It must be 3 o'clock in the morning.
Yes.
It is.
Denmark.
Okay, this is for question number 1. We didn't come to this, but I think I like to answer. Somebody has to answer this. How do you determine what surgical approach is best for each case, especially for more extensive cases, robotic or non-robotic? I know Harry likes this subject. Harry, do you want to address this? You answered this before, but go for it again, please.
Well, I have very little experience with the robot, but I would not like to have to maneuver with a robot, and especially with endometriosis, because you see the white fibrosis and you have the feel of the white fibrosis versus normal tissue when you cut with the scissors. And you don't get that at all with the robot. It's a total lack of tactile sensation. But again, I have very little experience with the robot. I certainly
I'll put my 2 cents there. I have Mario Malzoni, I think, is also watching. You're going to see how he does surgery, how quickly he changes instruments, how quickly it was. First of all, robot is excellent to show people how things are done in that way. However, in endosurgery, there is so much instrument change. It delays the procedure. You need assistance. It takes longer time. Most of it, you don't have haptic feedback. You don't feel the tissue. In endosurgery, it's so crucial to feel the tissue. Many times, the surgeon, experienced surgeon, has a 3D in his brain anyways. So in my opinion, I think extensive surgeries, even I don't use and promote robot for in my practice. My junior attendings like it. So I guess we'll see. But it never addresses the meticulousness that Dr. Gomel underlined. It really, still the forceps tips are very crude and very thick, and there's some issues with it, in my opinion. This is where I stand. Anybody want to address this? Dr. Martin? Okay, all right. Oh, Dr. Tolandi.
Yeah, I used a robot for 2 years, mainly for hysterectomies. And I learned quickly that I was wasting my time. I could do more big cases in a day without robot. Mm-hmm. robot is good in suturing. It's nice, but we are suturing by laparoscopy anyway, and it's good for obese women, real obese women. I think robotic is helpful. I don't use robot anymore, and I'm happy with it.
There's one more question. This is interesting because it's a general question. We know why the answer to this. Let's see who's going to answer. Why is there almost a taboo culture around endometriosis at major teaching hospitals? What is holding them back from adopting excision surgical techniques and endometriosis specialists? Why is there an emphasis on babies and obstetrics over real gynecological care? Department chiefs, Dr. Tolandi, you start. And I'll put my 2 cents in it. Anyone who wants to join this, Harry.
There is no taboo in our place, actually. At McGill, we excise all the endometriosis. In fact, we have a new staff now who is now in France with Dr. Roman. He would be doing bowel surgery in terms of endometriosis. We don't have to call the surgeon. He will do everything for endometriosis. Another one is going to Clermont-Ferrand. Learning urethral dissection, this and that. So we will have 2 gynecologists doing surgical cases without calling surgeon, doing urologic cases without calling urologist.
For that person who asked this question, I'll take the question another way. That's Canada. So when you come to United States, we have an OB department where all OB-GYNs are retiring early with huge malpractice suits and everything. Hospitals can get up to $60 million lawsuits for brain damaged babies and everything. So there's a huge pressure on obstetrical perfection. And these residents are emphasized to follow and protect the interest of the hospital also, the way it's all set up. I have to be honest with you. I think in general, though, that really puts general education of the GYN residents to be really excel in GYN surgery. In my opinion, that's the main question. That's the main reason that I see. The endometriosis specialists are difficult to train. I mean, it takes 5 to 10 years for somebody focusing on endo to be good at it, in my opinion. So it comes just by the individual interest and passion. Certain people are going for it. It will change eventually. In our foundation, we have a fellowship program. I have a fellow right now, and who is basically be training with us 2 years before she is competent to do her own cases. Any other, Harry, go ahead.
2 factors. In the United States, OB and GYN should be separate specialties, number 1. And number 2, in the United States, people who work with endometriosis should spend 3 to 6 months of bowel surgery with the general surgeon. The concept that you have to call a bowel surgeon or another surgeon should be obsolete in our future for endometriosis surgery. Because we're dealing with a rectovaginal disease. Both are included.
Thank you. We have to move on due to our schedule. We are behind a little bit, so we're coming to our next presenter, who's going to be talking about the place of imaging. Alexandra Di Giovanni, who is part of Malzoni Surgical Center from Avellino, Italy. She's an exceptional sonographer. I have seen her clip. You will see a wonderful presentation from Dr. Di Giovanni. It's nice meeting you, ma'am. So this will be on tape, so you are going to be answering questions. There are special questions coming to you. Thank you for joining us.
Thank you so much. Good afternoon to all. It's my great pleasure to join this amazing and exciting event by Endometriosis Foundation of America. So thank you, Dr. Skin, for your more than kind invitation. So let's explore together how reliable can be imaging in endometriosis. Nowadays, it's not more time for diagnostic laparoscopy because ultrasound and MRI are universally recognized as the gold standard for diagnosis of endometriosis. And of course, we all recognize that imaging can guide therapeutic approaches, enabling patient counseling before surgery to set the most appropriate surgical strategies and to follow up, of course, patients in case of conservative management. But let's start from the lesion we are most familiar with, the endometrioma. Endometriotic cysts used to be an easy diagnosis, so that we can speak about sonohistology. I mean, I'm so confident about my diagnosis that I can give an histological hypothesis. And it happens because usually endometrioma show very recognizable ultrasonographic features. They are usually unilocular cysts, or when multilocular with a low number of locules, with irregular walls, with a really poor vascularization and ground glass typical content. Sometimes we can observe some heterogeneity of the content of the cysts, like these hyperechoic parts inside of the cyst itself. They are usually clots, and they are invariably Doppler negative. Of course, when we face with an endometrioma, we should not just make the diagnosis, but we should count the number of lesions, the position inside the ovary, because it can change from a surgical point of view. We should give information about the antral follicle count, so I mean the residual ovarian reserve of the patients, and we should always take into account the association with adenomyosis, adhesions, and deep infiltrating endometriosis that we can, of course, detect by ultrasonography as well. When we approach a patient affected by ovarian endometriosis, we should use all our instruments. So by ultrasound, we can push on cysts in order to observe hyperechoic content moving. We should put our Doppler on, and above all, we should not be in a hurry and be careful. Because if it's true that the diagnosis is usually easy, and that the majority of endometriotic cysts are benign, sometimes we can observe this kind of situation with solid components inside that can show also some vascularization. And in this case, we should be careful, because we should take into account that even if in a low percentage of cases there is an association between endometriosis and ovarian cancer. In the majority of cases, cancer arising from endometriosis are endometrioid or clear cells border ovarian tumors. So when in the endometrioma evaluation, we should take clear in mind some key points. They are unilocular or multilocular ovarian cysts with the ground glass content and regular walls with poor vascularization, no solid component inside. When we find solid component, of course, not all the endometrioma with solid component are cancers, but we should take into account the possibility of a typical endometrioma with a low risk of malignancy, usually borderline ovarian tumors. And always please remember that endometrioma is not alone. In the majority of cases, up to 80% of cases, that can be associated with adenomyosis, adhesion, and deep infiltrating endometriosis that should be observed and detected. But let's move now to the hardest part of the disease, hardest from a clinical, diagnostic, and surgical point of view. Endometriosis is rightfully considered the most difficult surgery to be done in gynecologists, and the disease is sometimes considered as an enigmatic disease, but confusion is an opportunity to change if it's recognized for what it is. That is just lack of accurate information. So we can do it better, definitely. It's just a matter of knowledge of, first of all, of pelvic anatomy. So we should know how to look for, what to look for, and where to look for. So the typical deep infiltrating lesion is a solid hypoechoic with no or poor vascularization. And we should look for it in all these pelvic compartments. So it's all about anatomy. First of all, we should suspect the presence of deep infiltrating endometriosis. We should know how to look beneath the surface, because ultrasound for a patient with suspicion of the disease cannot be limited to the evaluation of the uterus and ovaries. We should be able to explore all the pelvic compartment in which lesion can be, and while scanning we should make any effort to be in our surgeon mind in order to provide all that information that can be useful to set a proper surgical strategy. So our brain should act such in a fusion manner, putting together all that information that come from our anatomic knowledge, our surgical knowledge, and it should be translated in the scale of grade that we are used to see on the screen of our ultrasound machine. Of course, a systematic approach can be very helpful in order to explore the pelvis of patients with suspicion of endometriosis. This is our stepwise combined transabdominal and transvaginal approach. Of course, transrectal when needed in patients that cannot undergo a transvaginal exploration. We usually start from the bladder. Then we move to uterus and annexa, of course, and then we move to the posterolateral compartment, exploring the rectocervical and parametrial area, vaginal, rectovaginal septum, and bowel. Always the endocavitary approach is combined with transabdominal exploration for upper bowel segment, kidneys, and diaphragm evaluation. So let's see this kind of lesion step by step. For bladder disease, we should consider that the advice is to look at the bladder not completely empty, because sometimes nodules with a plaque morphology, when they don't protrude so much into the lumen, can be missed if the bladder is completely empty. Bladder nodule can be distinguished, of course, from bladder neoplasm, because usually the lesion shows poor vascularization, and above all, it develops into the muscularis. Sometimes it can protrude into the lumen, and also the mucosal appearance can be irregular, but we should take into account that in bladder neoplasm is just the opposite, so that the majority of the lesion is into the lumen with the hard irregularity of the mucosal layer, and sometimes it can invade the muscularis. Once identified the lesion, the 3 orthogonal diameters should be taken. Distance from urethra and urethral meata should be measured. We should observe if present any cleavage with anterior adenomyosis, and the advice is because that lesion usually are more likely to be found in patients with the previous C-section, to have a look at the anterior abdomen wall parietal infiltration. Then we move to a vaginal and rectovaginal septum. Please note that not all the lesion that we can find in the posterolateral compartment should be defined as a rectovaginal endometriosis, because rectovaginal septum is a specific anatomic candidate. This is this thin layer that divides the posterior vaginal wall from the anterior bowel wall, and it can be easily recognized by ultrasound as a thin hyperechoic connective tissue. This small area, it's really rare that it can be affected by deep endometriotic lesion, because in the majority of cases we find retrocervical deep infiltrating lesions that are most common ones that go down and that can infiltrate also the vaginal wall and rectovaginal septum. But the pure infiltration of rectovaginal septum, as you can see here with this typical endometriotic tissue that invades and disrupts the normal hyperechoic appearance of the rectovaginal septum, are really rare. And here you have an example of the isolated posterior vaginal wall nodule. Then we can move to the evaluation of retrocervical and parametrial disease. Again, we should not just speak about uterosacral ligaments nodule. I agree that uterosacral ligaments lesions are most common we can face with, but we should also consider that uterosacral ligament is all this entire structure that run from the posterior border of the cervix to the posterior pelvic wall. So the most common lesions are ones that we can find at retrocervical insertion of the ligament, but we should take into consideration that deep infiltrating endo can also extend beyond the retrocervical insertion of the ligament. So along the uterosacral ligament posteriorly, and this is the so-called area of the dorsal parametrium, and beyond laterally into the so-called lateral parametrium, that is this tissue that extends beyond the lateral border of the uterosacral ligament itself. We can, in order to detect this kind of lesion, we should get suited to observe the normal appearance of these anatomical structures. So the retrocervical area can be observed both in the oblique parasagittal section and in transversal section. Here you can observe the normal appearance of the uterosacral ligament insertion in transversal section on the retrocervical area, and the area in between that is so-called torus. And here you can observe a normal entire uterosacral ligament running from the cervical posterior border to the pararectal space up to the pelvic wall. The normal appearance is hyperechoic, because here you can see the peritoneum covering this area. Unfortunately, the concept of parameter was taken into in consideration in the classification system from the IDEA group, but we think it's of utmost importance because probably it's the hardest area for surgeons to deal with. So here you have some examples of nodules extending into the parametrium. So this is the cervix, this is the retrocervical area, this is the typical deep infiltrating lesion affecting the insertion of the left uterosacral ligament. As you can see, it extends laterally beyond the border of the cervix. So in this case, we can put the diagnosis of partial extension to the lateral parameter. In this case, here we have a parasagittal section. This was a transversal section, of course. In an oblique parasagittal section, we can observe the lesion extending along the uterosacral ligament, so beyond the posterior border of the cervix. In this case, we can make a diagnosis of extension of the lesion to the dorsal parameter. But why it's so important? Because in the lateral parameter, first of all, we know that ureter runs. So we can explore by ultrasound the relationship between the lesion. Here you can observe the plaque with the red arrow and the ureter. We can measure the distance that of the lateral margins of the plaque to the ureter. We can observe when the plaque is in contact with the ureter, very close to the ureter, and so we can give this kind of information to surgeons. Of course, we can also observe when the ureter is completely surrounded by endometriosis, and in that cases we have stenosis, and usually we have also enlargement of the ureter above the stenosis. In that cases in which the plaque is really close to the ureter, it could be important to measure the distance between the involved segment and the intramural ureter tract in order to provide this kind of information, because in that specific cases sometimes ureteral implantation can be needed if ureterolysis fail. Just to underline how we should not always trust the ureter, because sometimes the distal tract of the ureter can be completely normal, even in cases like this one. So, and it happens when the stricture is very, very high in the pelvis. Here you can see this was the distal ureter, completely normal. This was an enlarged ureter above the stenosis. This stenosis was clearly above the left ovary and the proximal sigmoid. So very hard to be detected, but in such cases it's of utmost importance to put a probe in the kidneys of the patient to prevent the so-called silent kidney loss. And why it's so important to evaluate the extension of lesion to the dorsal parameter? Because this area, the area that lies posterior to the cervix, and so along the posterior part of the uterosacral ligament, it's the area in which the majority of narrow fibers of the pelvis run. So in these cases, we can inform surgeons about the possibility of really hard surgical intervention with the need of nerve sparing technique. Of course, in these cases, it's very, very, very important to counsel patients about the major risks of this kind of complex surgeries. This was our paper of 2019 on almost 5,000 patients undergoing surgery for deep infiltrating endometriosis, and just to show you how reliable can be this kind of ultrasonographic approach for the detection of lesion in retrocervical area and the parametrial area. And more recently, we joined other authors in evaluating the ultrasonographic application of the revised Einstein score, and we found very similar diagnostic accuracy. But let's move to the evaluation of bowel disease. This is how we can evaluate all the layers of the bowel wall by ultrasound. You can see the typical hypoechogenicity of the muscularis, the hyperechoic submucosa, and we can also distinguish the two layers of mucosa and submucosa, mucosa and muscularis mucosas. But however, even if we can obtain these wonderful pictures, the only layer on which we should be interested in is the muscularis. We can recognize the muscularis of the bowel in any kind of setting, and we should be focused on it, because it's in this layer that deep infiltrating endometriosis can be found. It's really rare that inner layers are infiltrated, because the disease starts here and can go deeply in the inner layers, but when we find some endometriosis in mucosa or submucosa, we just are looking at the tip of the iceberg. And this is also the reason why we usually not ask for colonoscopy, because colonoscopy cannot see the extension of nodule, and it can also misses the nodule, because as I told you, in the majority of cases inner layers are not infiltrated. Of course, you can ask for colonoscopy for that patient complaining for rectal bleeding, but just in order to make a differential diagnosis with primitive bowel disease. This is the area that can we explore by ultrasound. As you can see, it's the area in which the majority of bowel nodules are located, almost 80% in rectum, rectosigmoid junction and sigmoid colon, and of course we can explore also the right iliac fossa. This is also the reason why in the majority of cases we don't ask for MRI, because we can cover all this area by ultrasound. Of course, MRI can be useful in order to detect small bowel extension in the upper segments, especially in that case of multifocal deep infiltrating bowel endometriosis. This is the typical appearance of a deep infiltrating nodule of the bowel. As I told you before, it arises from the infiltration of the muscularis. Normal appearance of muscularis is like this. The normal thickness is more or less 1.5 to 2 millimeters. When it's so enlarged and we so enlarged, it's because of endometriotic infiltration. Please note that it's invariably Doppler negative or with a very, very poor vascularization. So this is the nodule. This is the typical appearance of the nodule infiltrating the muscularis. We can find, of course, some fibrosis also in the outer segments, so such as serosal fibrosis. Sometimes we can observe this kind of irregularity of the hyperechogenicity of the submucosal layer, but as I told you before, as you can see, the majority of the extension of disease is into the muscularis layer. Of course, we can observe also some irregularity of the shape of the nodule, especially when we face with nodules of the right iliac fossa, because in that cases it's more likely that more segments of the bowel are infiltrated and fused to each other. Let's take in mind that also appendix can be infiltrated and it can be seen by ultrasound. And let's also always think about the adhesion that in the majority of cases are associated with this kind of infiltrating disease. Rectal wall retraction and deformation should be considered and taken into account, especially when we measure the distance between the nodule and the anal verge. That is another important information for surgeon. Probably the most important information for surgeon when we are facing with infiltrating with deep endometriosis of the bowel are nodule measurements, nodule diameters. As for all the other lesion in the posterolateral compartment, we should take 3 orthogonal measurements, but in this case, our advice is to take the measurement of the length of the nodule following the axis of the wall in the mid-sagittal plane, because if we measure with a straight line and not with a curved line, the risk is to give an underestimation of the nodule itself. With the same curved line, we can measure the transversal diameter of the lesion. We can also, of course, calculate the percentage of the involved circumference. And last but not least, we can measure the depth of infiltration. I mean, the anteroposterior diameter of the lesion, that together with length is probably the parameter that most affect the decision about the type of surgery to perform. In order to do this, we should be able to distinguish the different component of a deep infiltrating disease. As you can see, here we have a typical bowel nodule, and we have also endometriosis infiltrating the posterior vaginal wall. So this is the rectum, this is the vaginal. This is deep infiltrating tissue infiltrating the posterior vaginal fornix and the upper part of the rectovaginal septum, and this more hypoechoic component is the lesion in the bowel, in the muscularis of the bowel. So if we measure all these entire lesion, the risk is to give surgeon false information about the depth of infiltration. While we should be able to distinguish these two components, you can observe they can be distinguished in terms of icogenicity, that for the bowel is slightly more hypoechoic than the outer component in the rest of posterolateral compartment. So if we can give this kind of information, it will be appreciated. And when we use this criteria in order to approach patients by ultrasound, as you can see, we can obtain, this is our paper from 2020, we can obtain very reliable measurements of a bowel nodule that don't differ when compared with the fresh specimen. And of course, also the accuracy in terms of lesion detection is very, very high in all the explored compartments. So just to resume, if we consider the most common and valuable guidelines that we have about the approach, diagnostic approach to patients affected by endometriosis, they said that if transvaginal scan is not appropriate, consider a transabdominal ultrasound. I would add that transabdominal ultrasound should be always performed, and when transvaginal scan it's not appropriate, transrectal scan should be proposed, because transabdominal ultrasound alone doesn't allow us to collect all that information that I just showed you. Serum markers are not useful in order to diagnose endometriosis. The rate of false positive, false negative rate is too high in order to use it as a diagnostic tool. MRI is very useful, can be very, very useful in experienced hands, but it should not be the primary investigation. Ultrasound is cheaper, and as you saw in expert hands, can give us many useful information and allow us to make a complete evaluation of pelvic endometriosis in the majority of cases. Diagnostic laparoscopy should not be performed if diagnosis from an experienced sonographer or radiology is available, but in that cases of high clinical suspicion with negative imaging can be proposed, but again it's crucial that is performed by an experienced surgeon. So which are the key points for advanced evaluation of deep pelvic endometriosis? Of course, an optimal knowledge of pelvic anatomy, optimal knowledge of the disease, high-level expertise in pelvic ultrasonographic technique or MRI in case of radiologists with specific training for deep infiltrating endometriosis, and most of all, strict cooperation with expert dedicated pelvic surgeon and centralization centralization of patients management in referral centers. So thank you so much, and please let me thank all my team of surgeons, because without them, for sure, I wouldn't be what I am now with my ultrasonographic machine. Thank you very much.
Thank you so much for very beautiful present. I wish we had sonographers like you in States committed to GYN sonogram techniques like you have advanced. I know he wouldn't mind because he's next, but there is a ongoing question. We're going to come to questions and answer, but the times are going fast. Since you just freshly connected to us with your presentation, there's one question you answered a little bit, but can you answer this? Is adenomyosis also difficult to diagnose through imaging? Does presence of adenomyosis indicate presence of endo since they overlap? This is simple. I know you answered the best for this. Thank you.
Yes, of course. The association between adenomyosis is just a part of endometriosis disease, and it's not so hard to be recognized because we have some specific features that we can observe by 2D ultrasound. I mean, enlarged uterus with asymmetrical thickening of uterine walls with a hyperechoic and hypoechoic striation, some small foci of endometriosis, avascular myometrial lacuna. So it's not so hard to be recognized. And of course, 3D volume acquisition also help us in order to recognize that soft markers in terms of irregularity of the junctional zone. So it, of course, increase our diagnostic accuracy even in that not so severe forms of adenomyosis. And as I told before, adenomyosis can be associated with other features, other locations of endometriosis, up to 80% of cases. So always when we face a patient with suspicion of or evidence of pelvic endometriosis, we should be really careful in the examination of uterus and or the other possible location, because this is the disease can be invariably located in all that pelvic spaces and compartments that we saw. So when we observe one sign of endometriosis, we should be able to detect all other possible location the patient may be affected by.
Thank you. I have a follow-up question. How do you have a technique of looking into patient groups who are difficult to be examined vaginally? Like it could be adolescent, non-sexual, not active, for other considerations, who doesn't want to be examined vaginally. How do you utilize your ultrasonographic approach on these, and what difference does it make as far as your diagnostic ability?
Okay, in that cases, the advice is to go by a transrectal approach, especially in patients that with a really high clinical suspicion of endometriosis. It's advisable because transabdominal ultrasound scan is not enough in order to detect that small foci, especially in adolescent patients that can have a really subtle form of the disease that cannot be detected by just by transabdominal scan.
Thank you so much. I'm hoping that you'll be staying later for
of course
oncoming questions after Mario's presentation.
Of course.
Certainly our keynote speaker is next. He is Mario Malzoni, the director of National Center for Endometriosis, the Malzoni Group. He's a world-renowned endometriosis specialist, recognized for his extraordinary skill and multi-organ surgical work. I met Mario with Harry when we visited Avigliano years ago, maybe more than 10 years ago, met his wonderful father, who's also a surgeon. Lucky for him being a son of a very gifted surgeon. And it's such a nice pleasure to have him here today. He utilized an innovative three-dimensional laparoscopic technique to increase surgical precision and accelerate recovery time. Mario serves as the director of National Center for Endometriosis and chief of Center for Advanced Pelvic Surgery. He's also honorary professor emeritus at the University and Research Center in Moscow. I'm going to pause here because what goes on around there. Scientific director of Malzoni Group and the past president of Italian Society for Gynecological Endoscopy. It's my great pleasure to have Mario Falzoni. Thank you, Mario, coming here.
Hi, Tamir. It's a great pleasure for me, and good afternoon to all the people connected. And it's a really pleasure and a great honor for me to be part of this amazing event held by the Endometriosis Foundation of America. We are all aware that endometriosis is probably the most challenging among gynecological benign disease in terms of epidemiologic spread and impact on the woman's quality of life. And the management of the patients is still characterized by several clinical points. So I share my presentation. Let me know if it's okay.
Yep.
Okay, so how to get out of the labyrinth of the pelvis that's starting from the accurate diagnosis to appropriate surgical strategies. So,
Mario, we're not seeing your screen.
No.
We're seeing it.
Now?
No.
No.
We're seeing without the play mode. We're seeing the screen now.
Okay.
I would go to Zoom, go to share screen and.
Sure.
Okay.
Try again,
share
sorry.
Screen.
Share screen, optimize,
and
yes.
And go to advanced share screen and then go advanced option, select the window there. Go to advanced option.
Mm-hmm.
And select screen to share there. There's a area that says select screen there. Do you see it? Here we go. We have it.
Go.
Yep.
It's okay.
Yep.
It's good, the imaging?
Very good.
Okay, so is it an invisible disease or disease very complex for the diagnosis? So sometimes we mistake the diagnosis not only before the surgery, but even during the surgery. So in my opinion, this is the best strategy in order to reduce the mistake during the surgery. So starting from a correct anamnesis and a clinical evaluation based on a skilled imaging, so ultrasound or MRI, in order to have all the characteristics of the disease, and in order to put a correct surgical indication, preoperative, and then in order to complete counseling with the patients about the kind of surgery and about the complication that can occur during the surgery. So surgical experience and knowledge of anatomy and neuroanatomy, adequate postoperative evaluation, and skilled management of postoperative complication too. And we have to start from probably a new classification that we need to evaluate not only during the surgery, but preoperative evaluation with the same classification in order to speak the same language between the radiologist, the sonographer, and the surgeon. So the proposal of a new classification, comes from the Nuance classification that 1 year ago we published with the group of Keckstein, and based on evaluation of the peritoneum, the ovary, the tubes, and the 3 compartment A, B, and C. It's at the level of the recto-vaginal space, retrocervical area.
Mario, I'm
Yes.
going to interrupt you. I think you should go back to your share screen and pick the slide screen. I think you mistakenly did not pick the screen well enough, because we are not seeing your slides, because this is an important presentation. I don't want you to be missed. Yeah, go back to share screen and pick the whole slide. I think by mistake it's too enlarged, it's coming, or decrease the size of the, yeah. Share screen, yeah, that's good, yeah.
This is okay.
It's the same thing. We are seeing, yep, this is better. This is better, yeah.
Let me see.
Yep, yep, this is good. I think this is it, yep.
This is okay?
Well, I guess still happening. Let me just...
like this?
Yeah, there you go. Getting closer, that's closer.
Click next, click next, next. This is better though, this is much better. Yeah, this is good. This is better, yes. I see the whole slide here, right?
No, I don't.
Like this?
This is better. I see the whole slide, guys.
No. Probably now.
You go basic, advanced, you go to basic now and select select desktop. Go to basic this time. Select
Okay.
share basic and select desktop.
Now?
Yep, this is good. Excellent, excellent. Done.
Okay.
Go ahead.
I'm so sorry.
Roll
Okay,
back.
so-
Roll back a couple slides though.
Perfect. So about the new classification from ancient score, this is the score. So peritoneum localization, ovary tubes, and deep end at the level of the compartment A, B, and C. A is a retrocervical area, rectovaginal space, and vagina, and B are all the ligaments at the area of the pelvic side wall and the cardiac ligaments, and C is the rectum, and then U is the ureter, and so different lesions at the level of the lung, at the level of the diaphragm. So this is a topographic evaluation, and this is the new AGL endoclassification that was proposed a few months ago from the American Society of different localization, a different score with a specific app in order to classify the disease is classified compared to the difficulty of the surgery. So at the end, this is the final stage with the score, with the number in 4 stages. What about the preoperative diagnosis? It's very important, the preoperative workup for this kind of patients based on ultrasound and MRI. And we use cystoscopy in case of bladder involvement. We use CT, MRI, urography, or renal scintigraphy in case of upper urinary tract damage. And it's important to consider the urodynamic tests in order to evaluate the neural plexus involvement in the dorsal and lateral parametria involvement. So what do we need before to arrive in operative room? It's very important to have some information, specific information from MRI or from ultrasound on the bladder, on the retro and paracervical area, on the fornix and retrovaginal septum, on the bowel. For example, on the bowel, it's very important to know how big is the nodule, what's the craniocaudal size, what is the muscularis infiltration, what is the transversal size of the nodule, what is the distance from the anal verge, and the percentage of stenosis. This is important in order to plan a very good strategy and correct surgery. So the aim of the surgery is, of course, to improve the symptoms, to restore the function in case of infiltration of the organs, to restore the anatomy, to restore and preserve the fertility, preserving the neurological damage, and try to improve the quality of life of the patients. So, starting from the bladder endometriosis, it's very important. I want to show you just a few videos. This is a very small nodule, very deep. So here is very important to know from ultrasound or from MRI, what's the size of the nodules, what's the distance from the intramural tract of the ureter, because the difficulty of the surgery depends from these characteristics of the disease. So in this case, we know that the nodule is very small, very far from the ureter and from the intramural tract of the ureter. So this kind of surgery is not so difficult. We can plan with the patients, talking with the patients about the risk of this surgery, and it's not so difficult, the reconstruction of the bladder wall. In this case, the situation, it's another bladder nodule, but the situation is totally different, because we have a very big nodule that arrives at the level of the trigono, and on the left side, the nodule arrives at the level of the adventitia of the intramural tract of the left ureter. So in this case, we have to put the stents before, in order to avoid problem during the surgery and the risk of stenosis of the ureter, and we have to inform the patients about the risk of this very difficult reconstruction of the bladder, the use of the stent, the risk of resecting the ureter, and the risk of reimplantation during the surgery. So this kind of surgery is totally different compared with the previous case. And if we consider the parametral infiltration, this is probably the most challenging surgeries. The parametral extension of the disease, it means that we have to consider the surgery at the level of the ureter. So conservative treatment in case of extrinsic lesions on the ureter, so ureterolysis, so called. In case of failed ureterolysis, or in case of intrinsic lesions distant from the bladder, usually more than 2 centimeters from the entry of the ureter inside the muscularis of the bladder. And in case of small lesions, 1.5 centimeters, we can consider the resection of the ureter and the end-to-end reanastomosis. But in case of infiltration, of intrinsic infiltration at the level of the intramural tract of the ureter, or less than 2 centimeters from the intramural entry in the bladder, we have to consider the ureteral resection and the reimplantation. And then, in case of failure of the function of the kidney, we have to consider the nephroureterectomy. So, ureterolysis and parametrectomy. I want to show you just for example, the end of this surgery. This is the initial part of the preparation, starting from the left side of the ureterolysis at the level of the left ureter, arriving in the area of the left parametria that is totally infiltrated by the disease. So this kind of surgery, so-called ureterolysis with parametrectomy, extended parametrectomy, is probably the most challenging surgery, because we have to preserve all the vascularization of the parametria for young women, and we have to preserve all the neural parts. So when we arrive at the level of the fibrotic tissue between this area, the bowel wall and the ureter that are totally attached, we have to separate, preserving the nerves, the neural part of the dorsal and the lateral parametria. So I will show you the final results after this extended parametrectomy. So we arrive at this is the picture at the end of the left parametrectomy with the ureter, and you see all the neural part here, the hypogastric nerves and all the branches that from this area go to the bladder, and then the uterine branch medially. Then this is the final results. And in order to evaluate the perfusion of the mesoureter, the perfusion at the level of the ureter and at the level of the neural part of the dorsal parametria, the technology can help us consider the use of indocyanine green evaluation of the small vessel, so microvascularization with injection of indocyanine green intravenous, and then we go with the new scope. This is the new 3D 4K camera in order to evaluate the small vessel on the ureter and decide what kind of surgery we have to do now. If we stop the surgery with the ureterolysis, or we have to reinforce the ureter wall, or to cut the ureter and do an end-to-end reanastomosis. In this case, the fluorescence imaging with monochromatic mode can help us to understand better the microvascularization. So this is the indocyanine green and Rubina system. The possibility that we have is monochromatic intensity map with overlay in green or in blue. Sometimes for infiltration, inner infiltration of the ureter, so in this case we have any really intrinsic lesions in the ureter, it's mandatory to cut the ureter to remove the part of infiltration of the ureter. And if we have the good tension between the two parts of the ureter, we can restart with an end-to-end reanastomosis with the classical technique of the reanastomosis. Sometimes we have to cut the ureter and start with the ureter reimplantation. So in that case, it's very important to mobilize the bladder. Sometimes you have to put this kind of stitch at the level of the psoas muscle on one side, like this, in order to put more cranially this part of the bladder and have a good tension between the bladder and the ureter. After this kind of fixation at the level of the psoas muscle, we have to free all the ureter, opening this part of the bladder and consider to put inside the ureter using cystoscopy here, cystoscope, and going with the catheter and with the stent in the cranial part of the ureter. And then we start with the reconstruction and with the classical technique of suturing between the muscular part of the bladder, the mucosa, and the muscularis, and the muscularis and the adventitia of the ureter. Then we cover and we close this part of the hole at the level of the bladder. At the end, we can use the same indocyanine green evaluation to consider the vascularization of this part of reconstruction after ureter reimplantation. Sometimes the lesions are bilateral. This was a very hard case with a total infiltration of anterior parameter both sides. So we have to cut both ureter and consider that the final results after double resection of the ureter and double bilateral, so reimplantation. This is the final results after the bilateral reimplantation of the both ureters. You see the two ureters arrive at the level of the middle line of the bladder, and this is the final results after bilateral reimplantation. But sometimes the delay of the diagnosis are many years. So we arrived with some kidney without function. So sometimes we have to consider the nephrectomy like surgery that we have to do, probably in association with, in this case, with the hysterectomy and parametrectomy. So this is the visions that consider the ovarian vessel here, the ovarian vein at the origin from the renal vein on the left side. And this is the left nephrectomy. After cutting the vessel here, the ovarian vessel at the origin, we arrive at the renal vein, and we have to prepare the renal vein like here and put the clips, the hemlock clips, the vascular clips at the level of the renal vein. Usually we put 2 medially, 1 laterally, and then we cut in between. After this kind of preparation at the level of the renal vein, we go dorsally and we arrive at the level of the renal artery that we check just dorsally. And then this is the renal artery, and we can put another 3 hemlock on the artery, and then we go laterally and remove all the kidney in the lateral and dorsal avascular part. And after, we have to remove all the ureter, in this case with the left parametria, like a radical hysterectomy, because all the extension of the disease arrived at the level of the pelvic side wall. So we need the radical hysterectomy, like a type C2 or D radical hysterectomy, like for oncological case of cervical cancer. This is the final results after cutting of the renal artery. And this is the picture of the kidney totally free, and removing the left ureter through the vagina with the uterus, with the parametria. This is the uterus go out. You see on the right side, the ureter rises with a type B radical hysterectomy on the right side and type D radical hysterectomy on the left side. We remove all together, uterus, parametria, ureter, and kidney through the vagina. And then I can show you the area of stenosis of the parametrium. Just here, there was the stenosis of the ureter and the total loss of function on the kidney. At scintigraphy, the patients had a function less than 10%. So we decided to remove the kidney. For bowel endometriosis, it's very important to consider some preoperative evaluation, like the size of the nodule, the distance from anal verge, the inner of infiltration. You know from literature that in case of inner involvement, multiple nodules, more than 3 centimeters, we consider the segmental bowel resection in alternative to conservative treatment. We published in 2020 our so-called M rule, that means the rule of infiltration of muscularis. So our clear indication for different kinds of surgery in bowel surgery are for all the nodule bigger than 3 centimeters with infiltration in the muscularis more than 7 millimeters, we consider directly the segmental bowel resection. All the nodule more than 3 centimeters with infiltration less than 7 millimeters, we consider conservative treatment like a shaving technique. And all the nodule smaller than 3 centimeters but with infiltration more than 7 millimeters, we consider the discoid resection. So about the surgical technique for different shaving, discoid resection, and segmental bowel resection, we published our data on our technique of discoid resection in 2021. We published in 2020 the surgical technique of classical bowel resection with reanastomosis. And then last year we published our proposal of nose transanal natural orifice specimen extraction in order to avoid the small laparotomy suprapubic and do all the procedure by laparoscopy. So this is the video presentation, a few minutes about the case of bowel nodule. These are the characteristics of the patients, and this is the initial picture. And consider the nodule here that we evaluated by preoperative ultrasound. The nodule was bigger than 3 centimeters with the grid stenosis more than 60% and with the infiltration at least at 1 centimeter inside the muscularis. So the preparation of the bowel starts from the left side, so the descendant colon, we free from the pelvic side wall on the left side, and then we arrive at the level of the retroperitoneal area in order to see the direction of the ureter, and then in order to evaluate the hypogastric nerves. It's important to avoid to push or to pull on the nerves, but it's very important to understand the direction of the hypogastric nerves, because we have to open this area laterally to the rectum, medially to the left hypogastric nerves, in order to open the medial parectal space, the so-called Okabayashi space, and then we go down dorsally to the rectum in the retrorectal area, this avascular plane. This avascular plane, I think, is very important to prepare this kind of surgery, to free the rectum and to arrive at the level of the nodule involved the bowel, starting from the lateral side and going to the middle. So in order to avoid mistake and problems during the surgery, the correct strategy is always this, in my opinion: arrive from the lateral side to the middle one, and then we prepare on the right side with the same preparation. So we pull up on the bowel and we go to open the right side of the peritoneum. So we arrive in this gray avascular plane, and we reconnect the right preparation with the left one. We see the left uterus, the left hypogastric nerves from the right side, and then we see the right hypogastric nerves, and we separate and we go medially to the right hypogastric nerves and open again better, and pushing the bowel up, we open the retrorectal space, the avascular space. And this kind of preparation is very important in order to put more cranially the rectum and arrive then in the central area, arriving inside the nodule. Inside the nodule, because we have to separate in two parts the nodule, arrive in the rectovaginal septum and separate a part of the nodule infiltrating inside the muscularis of the bowel from the rest of the nodule that infiltrates and that starts from the retrocervical area and from the origin of the uterosacral ligaments. So we arrive in this point, and here we have the vagina fixed to the bowel in this part. So we open the rectovaginal space medially, we pull up the vagina and down the rectum. This is vagina and the rectum, and we go in the right plane in between vagina and rectum, pulling up the vagina, down the rectum, and arriving in the correct avascular, not infiltrated area of the rectovaginal space. Then we understand the area and we start the resection. The difference with the traditional technique of bowel resection is to avoid the suprapubic mini laparotomy, evaluate the resection line, and then after very good bowel preparation that we do the day before with the mechanical preparation of the bowel starting 24 hours before, we complete the preparation of the bowel at the time of the surgery, at the beginning of the surgery, under laparoscopic evaluation. We clean inside the bowel, and then we go directly to open with, in this case with harmonic, we open totally the rectum and we resect the caudal part of the rectum, the distal rectum, and then we evaluate the cranial part and resect again directly inside the rectum. Then, opening completely the rectum, all the specimen, the part of the rectum resected, go away from the cavity through the bowel, to the anus. So outside, and then we put inside the cavity through the rectum the anvil with the spike. And then the technique is to put the spike inside the cranial part of the rectum, remove the spike, and then we close with the linear stapler using a 12mm port through the right part. We remove this part. We close the rectum again with another stapler, and then we can perform the end-to-end reanastomosis with the classical transanal circular stapler. At the end, of course, we go to evaluate the perfusion, the iron leak test with the blue dimethylene 2. We cover this part, the so-called dog hair, with a single stitch in order to reduce the tension at this level. And then again, we go to evaluate with indocyanine green the vascularization at this level, injecting intravenous the indocyanine green, and with the monochromatic evaluation, sometimes it's better to consider the good vascularization. This is the surgical specimen after removal. So in conclusion, we can say these was our complication on 600 segmental barrel resection with the classical technique. We had rectal bleeding 3.2%, anastomotic leakage 1.6%, rectovaginal fistula 1.4%, and bowel dysfunction like constipation, frequent movements, and defecation pains around 19%. These are our preliminary published data from the first group of patients. It's important to consider that we had for the moment no protective ileostomy. All the patients received the complete removal of all visible endometriotic lesions, and this was the time of the surgery, the blood loss. No, for the moment, intraoperative complication and postoperative complication, and passing gas after surgery, median 1 day, passing fishes after surgery 4 days, and hospital stay 5 days. So at the end, in conclusion, we can say that it's very important, starting from the correct evaluation of the patients and anamnesis, skilled imaging with ultrasound or MRI, correct surgical indication in order to reduce the risk of mistake or complication, complete counseling and informed consent with the patient, surgical experience and knowledge of anatomy and neuroanatomy, and surveillance in the postoperative evaluation. So whoever enters in the labyrinth know that there is how to get out. Full understanding of the disease based on accurate information and correct surgical strategies is the only way out. Thank you so much.
Thank you. What a beautiful presentation. Well, this is exactly why you are doing the keynote today. And this is exactly why there is a recognition of your wonderful surgical work. Particularly, the foundation is established to advance the science and surgery of endometriosis, because endometriosis is a disease. Can be treated. Do I have a problem with the audio? Okay, it's better now. All right. So endometriosis can be treated essentially by surgery. So we have established, Harry, on behalf of celebrated and endometriosis surgeon, Dr. Harry Rich, we have established a recognition of the wonderful surgeons to be a sample to others. This is called the Harry Rich Award, and we've been doing this for the last 13 years. It's been established by me. The annual Harry Rich Award recognizes endometriosis specialists and scientists who are making a difference in women's lives through their practices, research, and advocacy effort. It is named in honor of Harry, who is a member of the Endometriosis Scientific Advisory Council and lifelong endometriosis surgeon that's been recognized by so many. In the past, we have honored our fellow Cameron the First. We only didn't honor Harry. Linda Griffith, Hugh Taylor, Charles Coe. These are familiar names. Our own Serdar Bulun, our own Dan Martin, of course, females, Lilo Metril, Linda Giddis, Robert Taylor, of course, Ronald Batt, Farnezat, Lone, and Ray Gary and Passover, who's going to be with us. And last year, we recognized Arno due to COVID. We delayed his recognition 2021. And today is the day for Mario Malzoni. Congratulations, Mario. And Harry will give you virtually this award. I want him to take the microphone and talk. Go ahead, Harry.
Okay, thank you. Thank you very much. First of all, I'm very honored to have you name the award in my honor. And I'm more than honored. In fact, the most honored I've ever been to be able to present it to Mario Malzoni, who I've known for a long time. I first met him when I was doing some work in this very south of Italy in Calabria. And the next time we flew into Naples, and Mario and his father took us on a little trip in a boat along the Amalfi Coast. So that cemented our friendship, I think. But Mario came over to spend time with me in probably, I guess it was around 96, 97. And at that time I lived in Pennsylvania, and I did work in both Pennsylvania and at Columbia University in New York. So Mario would come back and forth with me, and he'd see the surgery in New York, and we'd operate on Monday and Friday in Pennsylvania. And after that, I started coming over to Mario's hospital in Avellino. Now, let me tell you a little bit about Avellino. There's no hospital in the United States that has the equipment and the facility that Mario and his father have assembled in Avellino. Mario's father's a well-known, respected gynecological oncologist. And I have to say that Mario doesn't do just endometriosis surgery. He does probably the best cancer surgery that I've seen by laparoscopy. In fact, one year at one of his meetings, I had Mario in one room and a robotic surgeon in another room, and nobody could tell which was a robot. So he's at that level. And I also like to say, you know, Mario's accomplished with two hands what many of us did with one hand in those days with difficulty. But he's truly the first of the two-handed surgeons who can do almost every operation. He doesn't need a general surgeon or a urologist for some of these procedures. He does it all himself, and that's the true endometriosis surgeon. So it's just it's so fulfilling for me to be able to give him this award. Should have somebody else's name on it. It'll probably be Mario's name on it sometime in the future. But thank you so much, Mario, for all that you've done. And lastly, I have to say that a few years ago, I needed a angiogram, a heart angiogram. I went over to Avellino, and they did it with their radiological techniques where you could see everything that they could see in a regular angiogram. So the hospital is super well connected. Everything's there. And to me, it's the best place. Well, I'm sorry, Tamir, but you don't do the bowel and the urological stuff without the bowel surgeon, the urologist. In my day, when I was doing bowel cases in the late 80s, the general surgeon would be outside looking in the window. And I say, come on in, see if I'm doing it right. And they'd say, no, we don't want your name on the chart because we'll get sued. So Mario's shown you how far we could progress in this day and age. So thank you very, very much for being here with us today and accepting this award, Mario.
Thank you, Harry. Thank you, Samir. I really dedicated all my life to endoscopic surgery, especially focused on oncology and endometriosis disease. For me, it's a really great satisfaction to get this award from the Endometriosis Foundation of America. And most of all, I am particularly proud to get this award given in name of my personal teacher, like a second father for me, Harry. Harry is the person that more than 20 years ago, in 1996, when I was only 27 years old, accepted me in his hospital, in his department, in his home, and in his family. So for that moment, he pushed like a father me in the endoscopic surgery world. So all the people consider him, Harry, like a pioneer in laparoscopy. Of course, he is the pioneer. But all the people that really know Harry, love Harry for his great personality and for his heart. So if I have to describe Harry with one word, I have to say absolutely, he is a genius. So thank you, Tamir. Thank you, Harry. And I'm so really, really proud for this award. Thank you so much.
Thank you. Hopefully we'll see you next year when this COVID thing is over, hopefully. And this is not going to be virtual. And you will be recognized again on the podium for your next ball. I'm hoping to get all the honorees. I see Sardar Balloon is here. Great to see his face too. We're looking for a wonderful afternoon to go on. Due to time constraint, we will continue and take the questions in the end. Please hang in, guys. We got a wonderful lineup of genius presenters coming in. And if you allow me, I will move on. Alessandra, I hope you stay another hour. It's late. You can have your wine or whatever you do in Rome, in Avellano, Italy. And I'm looking forward right now. We're going to watch Philip Connick's. Many times I assign these talks, and whether they like it or not, I gave Philip Connick his favorite topic. The topic is, I have to say, now I'm getting a block. It is the what is his topic? Hold on a second. I gave the topic. So unbelievable evidence, of course, the evidence and the ethics. So it's Philip's, it's a beautiful topic, it's a very difficult topic. I have to tell you, very few people can dig into this topic as good as Philip. He's going to be on tape. Please accept he'll be on tape, but it's a great topic. I listened already. Thank you.
Hello, everybody. It's really a pleasure to talk about evidence and ethics in patient surgery for endometriosis. My credentials are listed here below. And Dan Martin, I should not introduce, but what I'm presenting resulted from a lot of discussions which I had together with him. When we say evidence, ethics, patient-centered surgery, it's about evidence, guidelines, how to lie with statistics, ethics in acquiring evidence, in presenting evidence, patient-centered, and the surgery, and surgery is something specific in medicine. I have to introduce 2 words of statistics. Most values are Gaussian distributed, which means that most individuals are around the mean. And the standard deviation is the distribution, the distance from the mean. The important thing here to remember is that mean plus minus 2 standard deviation will say 95% of populations. And this is the definition of normality, what we normally use in medicine. A mean and 2 standard deviation. Remember with this, that 5%, those extremes, 5% is abnormal by definition, although they are very normal. The second thing I have to introduce is the accuracy of a measured mean. So what we measure of a mean, the accuracy increases with the number of observations, increases with the square root of the number of the observation, which means that if you have 25 observations, the standard error of the mean is 5 times bigger, or with 100 observations, 10 times smaller than the standard deviation. The consequence of this is that if you have enough observations, very small difference become significantly different. Often forgotten, this is the last slide about statistics, is that to estimate a probability is the only thing that statistic does. What is the probability that an effect is not due to chance? If we say P equals 0.05, which means that 5% can be explained by chance. And the second important aspect is that all the assumptions should be okay, which means that we have a normally distributed population. And you see that if the base is very often logarithmic for most of the hormone assays, which means this is a nice standard deviation. But if you put this on a normal scale, then you see how skewed it is. But it means that if you take a mean and 3 standard deviations, you go below 0. And when you see this in the publication, think there's something wrong with the statistics. Second problem of statistics is it should be a homogeneous population. An homogeneous population, this is depicted here. If 20% gets worse, while 80% get better, a hidden small population of 20%. You will never see this with mean and standard deviation because it's hidden in statistics. So this is the basics of statistics. Now, all evidence-based medicine is a probability. For treatment, it means a significant effect is a minimum, but a significant effect says only something about difference and the number of observations. Clinically, what is important is the magnitude of the effect. And the second what is very important is for diagnosis. It's just a probability. A test is defined by the sensitivity, how much of those with the disease are detected, and the specificity, how many false positives do we have. Now, the clinician is not interested in sensitivity and specificity. He wants to know, if you make a diagnosis, what is the probability that this patient really has the disease? And there you have to remember that the positive predictive value vary with the prevalence. And it's an example I like to give. If you have a rare disease occurring in 1%, think deep endometriosis in a normal gynecologic practice, 1%. If you have 100 with the disease, you have 99% detected, 99% sensitivity. But you have 10,000 women without the disease, and this is 100.
which means we have a predictive value of 50%. And therefore, you better can toss a coin because it's no longer correct. Diagnosis and treatment, therefore, needs clinical judgment. How important is the effect without the side effects? The diagnosis is based on age, symptoms, clinical exam, and then the clinician has a probability of diagnosis, what's likely, what's possible, what is rare, and then he makes tests, but not for this age and for all the symptoms, the combination of tests and so on. And that's why it remains a clinical decision. For therapy, it's a clinical judgment of magnitude and absent effects. And the statistical significance is just a minimum, but it's not sufficient. For the diagnosis, the clinical judgment should combine for one person all the probabilities of antecedents, symptoms, all the tests for all possible diagnoses. This is mathematically not possible. Maybe in the future with the Bayesian approach, I have no time to dwell on this because this is a clinical approach. If we know it, what is the probability thereafter? Conclusion, it is an experience-based decision-making which is far beyond statistics and the clinical diagnosis. Today, I think, is something like artificial intelligence, which integrates also the rare events as accidents with an open mind for the open subgroups. These are the pyramids of evidence. Pyramids of evidence, most of the time used for guidelines. It's very statistical based, and these should be mathematically correct, but the clinical judgment is missing. We have no experience in rare events. And I would say, as a rule of thumb, we should move from not to accept until proven to not to disprove until proven wrong. This is something, I think, where the mentality has to change. Ethics and evidence diagnosis, there are a lot of biases. I told already the sensitivity and specificity. The positive predictive value decreases very rapidly for rare diseases. And you see for a disease in 1%, even with a 99% sensitive test, you only have a 50% positive predictive value. I'm not going to dwell, but remember that there's also this kind of precision of estimated, that also these values have confidence limits. Second bias, most of the time tests are not well defined. For deep endometriosis, when they say diagnosis of deep endometriosis, do we have only the ultrasound, or do we diagnose the symptoms and the clinical exam and the ultrasound? And this is recently being explored by Bayesian analysis, and then you see that the imaging has little proven added value. Third bias, absence of clinical endpoint and absence of stratification. Diagnosis of endometriosis, 95% plus sensitivity and specificity. But what is the accuracy of a diagnosis of a nodule of a half centimeter, the smaller one? This is something we cannot say today. And then you have the bias of all the potential diagnoses and the heterogeneous, non-normally distributed population. And then I think it becomes very obvious that is for the diagnosis is not that clear. This is something which we summarized in one of our recent papers. I'm not going to read it all. I think what is mainly important is that imaging today should not be used as the only indication for surgery. It's a clinical decision in order to do surgery. For the therapy, there are also a lot of biases. The first bias is the randomized controlled trial. The randomized control trial balances between two extremes. We know it's done because of no inclusion, no patient bias, no observer bias. Theoretically, it's perfect. But if the expected effect is so little that it's clinically anyway not important, why to do the trial? And if there's already a lot of evidence, then you can ask yourself if it's still ethical, acceptable to do the trial. Anyway, you have the inclusion and exclusion criteria. And the question remains, what is the value of extrapolation? What about the very young and the very old, the very obese with hypertension and diabetes and so on? Finally, the large randomized controlled trials are very expensive and are very slow to perform, and they only are going to evaluate one aspect. And then finally, how to interpret the non-perfect randomized controlled trial. Personally, with this, most of the trials, there's something wrong. I'm going to explain this in a second. Bias 2 is the publication, the cost, and the industry bias. We come back to surgery in a second. The drug industry is doing very nice, almost perfect trials. But these adequate trials mean that for a lot of drugs for which there's no patent and no registration drive, we do not have data. The numbers required to detect rare effects is rarely taken into account. Chloramphenicol, the old antibiotics. It means that 1 in 10,000. You need a randomized controlled trial of 300,000 to detect this. This was the problem with COVID. And then you have the multimorbidity. Very difficult to insert is a randomized trial. Medical therapy, to be more specific, of endometriosis, the trials were not blinded because they cannot be blinded. The patient knows whether she's taking active drug. In women with proven endometriosis, it means they had a laparoscopy. So if I have done the laparoscopy, the endometriosis is gone, has been destroyed, for instance, with a CO2 laser. And then you have the blind eye for difficult data. And I give there two examples, the peritoneal fluid and the variability of lesions. This is a very recent publication. Let's say it's a republishing of data of 1980. After long discussions with Dan Martin, we republished in these days of progesterone resistance, the huge concentration of progesterone and estrogens in peritoneal fluid. And the conclusion is that what we think about medical therapy of endometriosis probably is not true and should be reconsidered. Variability of lesions are already explained this, where some lesions have aromatase activity and some progesterone resistance. 10 to 30% are non-responders. You have growth during medical therapy, deep endometriosis after menopause. Statistically, it's inappropriate to do the normal statistic. And I think this is the most important conclusion here. The variability of lesions means our normal statistics are not appropriate. We should look at the individual data. Conclusion, for diagnosis, positive predictive value in a specific woman, this is still an experience-based clinical judgment, including all what we know, all the so-called evidence-based elements. For therapy, we have to look at the magnitude of effects and the absence of side effects. Sorry. Especially also for multimorbidity. And then you have the multivariate evidence, including rare events, disease, everything is not available because it would require a huge, large trial. Conclusions. Important is the consensus opinion of experts, like we published. Inclusion of all evidence-based knowledge, plus clinical interpretation, other clinical information, experience guide, extension to the individual patient. And this consensus of opinion director should ranking much higher in the pyramid of evidence than it is today, and should not be very low or just opinion. And that's the reason why I think we need new guidelines for endometriosis diagnosis and therapy. Patient-centered information. Patient-centered surgery requires informed consent. You should explain the diagnosis, the proposed therapy, and the risk as viewed by the majority. How to accurately transmit probabilities. Clinical interpretation may vary. Which complications should we give? 1% or also 0.1%? Which information is needed besides the literature? Surgical skills, personal experience, personal complication. Should you say to the patient, I'm going to do this, but do my best, but it will be the first time I do this. Video registration is something I think should be mandatory for reimbursement, but it's still not widely acceptable. Accept that are rarely discussed, that are discussed between experts and new techniques. Can we discuss this, transmit this to the patient? I call this the singer and the song. If we do not agree, how can you transmit to the patient? What should we transmit? And the informed consent should also include what the patient does not want. I do not want a hysterectomy. I did not want the ovary take out. Give an example for a hysterectomy. Should you explain laparoscopy versus laparotomy? And I cannot imagine that any patient is going to accept a laparotomy for hysterectomy today if it's well explained. Should you explain the conversion rate of variectomy? Certainly that. What will happen if accidentally deep endometriosis is found? Which means, at least in Europe, the informed consent is not yet that very clear. And for the endometriosis, the delayed diagnosis, who is responsible? The misdiagnosis, the medical therapy, which is given for years, while the nodule is still growing slowly. And then you have all these explorations of nerves when there is pain of endometriosis at distance. Recent paper together with Dan and Vilos of Canada. And there you see that it's up to 3 centimeters that endometriosis causes pain. Surgery is a very specific problem. It's not only a problem of diagnosis and therapy, but in addition, for surgery, you have the surgical skill, the experience, and the quality, the circumstances, and the quality of the team. The number of surgeries for each surgeon rarely permit large trials and multivariate analysis. If you have surgeries, you take 2 hours deep endometriosis surgery, you are not going to have a series of, it took me 20 years to have a series of 2000. Endometriosis is a variable disease. Moreover, all data reflect indication and clinical opinion, which means it's very nice that the data which we have today is an honest report of what has been seen, but with this, we cannot do trials. And there are many aspects in the OR which are used to do. Let's say if somebody is fallen over a cable somewhere and then you change your setting, this will never be reflected in randomized controlled trial. So we come to evidence in surgery. Randomized controlled trial, it's only realistic for rather simple procedures. Otherwise, the variability requires too large series. Take, for instance, superficial endometriosis, the EndoCan study. It was not blinded. And still, I think that the only thing it shows is that if you say to the patient, you have endometriosis, and it's still there, she gets nervous and she increases infertility. It's one of the reasons why the Cochrane review was withdrawn. The alternative is video registration can assess close to everything, but is poorly accepted for reasons, many reasons, although together it begins to be used for trials in adhesion prevention. The large single center permitting multivariate analysis and logistic regression. This is, let's say, where we demonstrated that endometriosis does not increase in volume over time, but it requires 20 years of database maintenance in order to have a series of 2000. Evidence in surgery, I would say, in addition, consider the consensus opinion of experts. Consensus opinion of experts, because they know each other. They have seen each other operating during live surgery. And then the techniques change over time, slowly but progressively, by going to meetings, by discussing, by assisting live surgery. In this, we also include the rare events, multimorbidity, and incorporation of literature and new understanding. It's something which is dynamic and changing. And I would say a few words, new trends in surgery. It's clear that or you go for excision, or you have a short bowel resection. These are data from Arnaud Wattier. In fact, instead of having very large resections of bowel, it's no longer necessary. This is the reason why I would say we should not have extensive excisions. The discoid excision with circular staple is the way to go because we can leave the fibrosis. We should destroy all subtle lesions. And you see the authors who I think were the first to discuss this. And we treat peritoneal pockets. This is very recent. And then personally, I think that even the surrounding cells of deep endometriosis is metaplasia, not real endometriosis. And this is the reason why after conservative excision, we do not have more recurrences than after bowel resection. So considering the genetic pathophysiology, and I'm going to sum up, it's a genetic epigenetic variable lesion, benign tumor, fibrosis and self-limiting growth, high steroid concentration peritoneal fluid, and so on. I would say medical therapy today do not continue medical therapy if the response is insufficient. And during medical therapy, response potential growth by ultrasound. Surgery, we have arguments today that the most susceptible moment of developing endometriosis is during adolescence. And I think therefore we can be a little bit more aggressive and an earlier treatment, maybe by transidural laparoscopy, complete excision, but we should not treat the fibrosis. Superficial endometriosis, you see all the different aspects here. The diagnosis, it can only be made by laparoscopy. Maybe you can try medical therapy and continue if this is 100% effective. The indication for laparoscopy is a clinical judgment, and during laparoscopy, focal destruction of all lesions, postoperative prevention of new lesions. This is the important aspect, and what's changing us is that we can decrease peritoneal oxidative stress and maybe in the future manipulate the intestinal microbiota. But anyway, I think we have good arguments that we can prevent recurrences. Cystic ovarian and endometriosis. Diagnosis ultrasound. The indication is pain, infertility, and size. But which type of surgery? Theoretically, superficial therapy should be performed because the capsula is fibrosis, but it is difficult to be complete when the cysts are larger than 2-3 centimeters. The reason why today we still think that excision is the technique of choice. deep endometriosis. I'm not going to dwell on the definition, but the diagnosis, we already criticized the predictive value of imaging and clinical exam. It's limited for the smaller lesions. The indication for surgery is clinical and not imaging. And then it should be clear what we are talking about. If we define deep endometriosis by 2 dimensions or by 3 dimensions, you see the 4 by 4 by 4 is very different than a 4 by 4 by half centimeter deep. The very large lesions, there you should better do a short excision. Everything was less than 4 centimeters in all dimensions of the rectum can be done conservatively. And for the sigmoid, I would be much more aggressive. And everything what's bigger than 1 centimeter, it should be better to do a bowel resection. In conclusion, medicine is an art of dealing with probabilities, uncertainties, and the risk of mistakes. It's a probability-based medicine, not evidence-based medicine. Experience and consensus opinion of experts should rank high in the pyramid of evidence. The randomized controlled trial and other trials are mathematically correct, but few of them are really perfect trials. And the clinical medicine and experience is something what we should focus on in the future. It's something which for me looks like artificial-like intelligence, improving with experience. Thank you. Thank you for your attention.
Hi everyone again. I'm on now, right? We have an echo coming. Okay, fine. I would like to say thank you, Dr. Philip Konix. I told you this was a tough subject to talk, but basically what he said, the way I understood, among everything else, seeing donut rectum and everything, evidence-based medicine and the evidence triangle should be reversed. Patients should be on the top in patient-centered medicine, and the surgeon comes next, and they make decision based on research and the meta-analysis of everything else. We are already delayed. That means things are going very well. I appreciate for people being patient. Next topic is going to be endometriosis, how genetics informs treatment. Our speaker is the John Scaria Professor of Obstetrics and Gynecology. He is the chair of Department of Obstetrics and Gynecology at Northwestern University and the chief at Prentice Women's Hospital at Northwestern Memorial Hospital. He's an exceptional physician, an incredible researcher whose research team has introduced aromatase inhibitors as a new class of drugs to treat endometriosis and pelvic pain. Dr. Serdar Bulun have been awarded over $60 million of research funding in the areas of uterine, breast, and placental disorders. His achievements are exceptional, have earned many notable recognitions, including his election to the National Academy of Medicine in 2015. It's my special pleasure, my friend Serdar. Thank you for being patient. Next time I'll make it up. Thank you. Go ahead.
Can you all hear me?
Yes.
Great. Thank you, Tamer, and thank you, everybody. It's great to be. I think I identified a lot of legendary surgeons. I just want to acknowledge that without having formed some of the most productive collaborations with some of you, we couldn't have achieved what we know in endometriosis right now. And I just want to make sure that we all recognize this. The recent evidence have shown that the top picture is, I received this from Tamer, have shown that almost all ovulating women, they experience retrograde menstruation. And retrograde menstruation, I will demonstrate to you in a second, is the most important cause, probably more than 90% of the cases, for pelvic endometriosis. The biggest question is, while like all ovulatory women with open tubes, they do experience retrograde menstruation, why is it that only 10% of them develop the symptoms of endometriosis? I think that's the real question. And all forms of endometriosis, including ovarian endometrioma or deep infiltrating endometriosis, most possibly occur over the years because of repeated episodes of retrograde menstruation of these stromal cells, immune cells, epithelial cells, and blood. This is a typical history of a patient with endometriosis. During the teenage years, almost all my patients, they reveal a history of severe dysmenorrhea. This is usually dismissed by dysmenorrhea. A lot of, unfortunately, the clinician or patient or parent community, they do not recognize that this is an early form of endometriosis. In fact, a lot of investigators, including Dr. Gargett from Australia and her group, and a number of clinicians, we think that early retrograde menstruation right after or during the time of delivery of a female fetus might be the first start of endometriosis. And then again, I mean, then we see different segments of these patients' lives in their 20s. They develop chronic pelvic pain. Finally, they are not dependent on their parents. They get a job. They get their own insurance. They find one of you or one of the OBGYNs. First laparoscopy is done, and endometriosis is diagnosed in these patients. And in their 30s or 40s, these symptoms continue, and most of the time they are treated with oral contraceptives, depo-progestins, GnRH analogs. There are a lot of repeats, and quite a number of these patients. Probably we do about like 100,000 hysterectomies in the US for endometriosis, for hysterectomy MBS, or just hysterectomy. I would like to reiterate this, that in the absence of a rectovaginal nodule or endometrioma, the response rates to laparoscopic surgery or medical treatment in treatment-naive patients who just presented to you are very similar. I mean, it's almost like 100%. It doesn't matter if these patients undergo surgery, resection, medical treatment, the results are spectacular. The real problem is the pain recurs in 90% of these patients within 6 months to 5 years. Then what do you do with them? This is the real patient population that is challenging to all of us. And repeated treatments, just like in any other chronic disease, is associated with now response rates much lower, less than 50%, and the recurrence time becomes much shorter. And again, I think it's important to recognize the big picture. Why does endometriosis happen? Endometriosis is a function of ovulation. No ovulation no endometriosis. The species that do not menstruate do not develop endometriosis experimentally. Women who never menstruated, they're not going to get endometriosis. And the important thing is part of the ovulation is the release of this egg and also release of these hormones around the egg to send signals to the endometrium for it to develop. But as we discussed, both the intrauterine endometrium and endometriosis is abnormal in these patients through a number of molecular abnormalities that feed onto pain, the most important symptom that we all deal with. Again, thanks to some of you through this research that is done by a lot of molecular researchers, including Tamer's group and his collaboration with Yimeng Shi. We now know that the cells that go through the tubes into the abdominal cavity are abnormal probably in this like 10% of the women who develop endometriosis. And these cells can be a normal stromal cell or a normal epithelial cell, but they could be an epigenetically abnormal stromal cell or a mutated epithelial cell that can, for example, end up in these inclusion cysts or corpus luteal cysts in the ovary. In fact, now we know that more than 60–70% of all ovarian cancers originate from the cells that go all the way down there or into there through retrograde menstruation, and some of them may include the tubal cells, which is really interesting. So we will come to this in a little bit. I just want to highlight what Tamer and his friends have demonstrated, and I think that was the most important game changer in endometriosis during the past 5 years. They demonstrated that first, there are mutations. There is a mutation burden that's accumulated over life in any woman. Like this starts at the age of 10, and they keep increasing in the epithelial cells of the endometrium. What is really interesting is, although there are mutations in more than 200 genes that they and different groups identified, these mutations, including KRAS, is the one that's accumulated in the endometriotic lesions, and for example, clear cell carcinomas of the ovary, which is really, really interesting. We all know that there is a link, at least an epidemiologic link between ovarian cancer and endometriosis. To complement this, there are not mutations, but there are DNA programming abnormalities that my group mostly revealed over the past 30 years. And aromatase is one of them, because these transcription factors are abnormally expressed in these stromal cells. So these two problems, I think they complement each other. So, in tune with the title of my talk, I would propose to you that there are KRAS inhibitors that are currently used in the clinical medicine. So these will be really important, maybe if they come up with the ones with lesser side effects in the treatment of endometriosis and ovarian cancer. So we again, over the past 30 years, came up with this elaborate mechanism, a vicious cycle, whereby cyclooxygenase and their product prostaglandins and the steroid cascade, including aromatase, making estradiol, are in a very intricate collaboration, if you will, to make more estrogen and also to make more prostaglandins. We know that these things are clinically important because we treat pain with cyclooxygenase inhibitors or aromatase inhibitors. They also decrease pain. And again, I think these epigenetic mechanisms also informed us to come up with new treatments to address pain in endometriosis. We introduced aromatase inhibitors in like late 1990s, early 2000s, and the principle is that in a premenopausal woman, it's problematic to treat this woman with an aromatase inhibitor because it also induces ovulation and ovarian cyst formation. To circumvent this, we combine them with oral contraceptives, and we came up with a treatment modality whereby we can treat, for example, postmenopausal recurrent endometriosis that was resistant to recurrent efforts of resection. And also we published this data about letrozole and norethindrone acetate combination in premenopausal women. And again, all of these studies originated from some of the observations that there are epigenetic defects, specific epigenetic defects that could be targeted in endometriosis. And again, this is another study that was conducted by a group in Turkey, not related to me, but they also show that if you add an aromatase inhibitor to a GnRH agonist, then the pain recurrence in these patients undergoing laparoscopic surgery is delayed. In 1998, again, we came up with this idea that there is a specific progesterone resistance in endometriosis. This is normal endometrium. This enzyme 17-beta-HSD type 2 is very important to metabolize and decrease the levels of estradiol at the time of implantation window. But when we biopsy endometriosis of the same patient that's exposed to similar hormonal milieu, we found out that this enzyme is not expressed. Therefore, we came up with this idea that this must be a form of progesterone resistance. And then we elaborated on this concept and demonstrated that, in fact, decreased levels of progesterone receptor in endometriosis or in the endometrial tissues of women with endometriosis is responsible for this. And the mediators of progesterone action that originate from stroma and act on epithelium to suppress epithelial proliferation, we identified as retinoic acid. Back to the clinical considerations. Because like progesterone receptor is important in the etiology or pathophysiology of endometriosis, we wanted to explore this further. The good thing is, like antiprogestins like ulipristal acetate or RU46, they achieve amenorrhea in the majority of the patients. This is a wonderful thing, as you could imagine, for endometriosis patients. Pain relief is way better than progestins, probably because these compounds can interact with progesterone receptor at a much higher affinity. But it comes with problems. There is this cystic glandular dilatation of the endometrial tissue that's mixed with like estrogen and progestin epithelial effects, kind of like give a chest pain to clinicians to treat these patients. And in fact, we started a trial for 10 patients, but after the first patient, I mean, my heart couldn't take it anymore, and we stopped it. The endometrial thickness in this patient after 2 months of treatment was about 16 millimeters. And I was like really anxious to stop the treatment and biopsy that endometrium to make sure that it's okay. Although, you know, there is some evidence that these lesions almost never progress to cancer. We tried to publish this case. We had a hard time because it was a single case, but we still could. This is a typical patient with endometriosis with refractory pain. In other words, this patient went through a number of laparoscopic resections, GnRH analog treatments, other treatments, and she did not respond. She did respond to ulipristal acetate. As you can see, her pain score was 3.5, and during the treatment of 74 days, it went down to almost 0. And then during the follow-up time, it went back up again. I mean, we wish that we could continue the treatment, but again, these compounds have not been approved for this indication, number one. Number two, they were approved by Jacques Donnay's efforts in Europe for fibroid treatment, but then there were very few cases of hepatic failure, which is a drug reaction, and they were not exactly pulled, but you know, very few people, there's a warning, very few people are using it. So like these were the biopsies. This was before treatment, normal proliferative endometrium. And you can see during the treatment, the endometrial histology, there are back-to-back glands. But when you look at the, you know, the architecture of these epithelial cells, there is no atypia. And once we stopped the treatment, it kind of like went back to this like proliferative histology. So there were no issues, but it kind of like makes you nervous. It makes drug companies nervous. It makes IRBs nervous. So it's moving very, very slowly at a snail pace. Couple of last slides. I just want to like reiterate that, to me at least, it makes much more sense to diagnose endometriosis during the teenage years based on its symptoms. And you don't even have to perform a laparoscopy because a lot of patients, we all know that, with pelvic implants may not even have pelvic pain. It's important to rule out using our methods, ultrasound methods now, to deep infiltrating endometriosis or an endometrioma. But it's totally fine to treat these patients by a medication that disrupts, suppresses ovulation, which is the culprit of endometriosis. What I do in my clinic is usually treat them with a continuous oral contraceptive. If they don't respond, I add an aromatase inhibitor. Now I use GnRH antagonists, which are oral, more often. And in fact, the the approach in a previously diagnosed patient is not all that different. And I think it's important to introduce these concepts. And the most important thing is, again, the laparoscopic resection should be done by an experienced surgeon, not by anybody, which is a huge problem in this disease. So I'm going to stop here, and I thank all of you for listening to me, and happy Sunday.
Thank you, Sardar. Thank you for this great presentation. We are watching you. You're doing wonderful things. I really appreciate to follow your work. Our next speaker is a very special one. He is the recipient of our one of our Harry Rich Award recipients 2 years ago. He's connecting us from Zurich. His topic will be the sciatic endometriosis, the real deep endo, real debilitating endo. And Dr. Mark Passover is the director of the Passover International Medical Center in Zurich. He is the creator of the branch of neuropelvology, professor of neuropelvology at the University of Aarhus, Denmark, and associate professor at the University of Cologne, Germany. He is also the honorary and founding president of the International Society of Neuropelvology, the pioneer of minimally invasive surgical techniques for treating pelvic gynecological tumors and deep infiltrating endometriosis. He is the world's leading expert in treating patients with pelvic nerve disease. I am so happy and honored to have Dr. Mark Passover joining us live from Zurich, Switzerland.
Dear Tama, thank you very much for the kind invitation. I'm very, very happy to see Harry again. And then to all of you, big kiss to the US. So in order to not lose too much time, please, I will try directly to move to my lecture. You see my screen now?
Yes.
Yes. So let's talk a little bit about very, very special kind of endometriosis of the somatic nerve. I will try to keep in time with a lecture of 20 minutes. So let's go on. One of the first things I have to mention is that endometriosis always involves pelvic nerves. Otherwise, endometriosis would not be painfully. But usually endometriosis involve the autonomous nerve system, which are located in the middle of the pelvis and responsible for visceral pelvic pain. We know all this kind of pain, typical pain of endometriosis. My talk will focus on other nerves, not the small autonomous nerve of the pelvic, but the somatic nerve, which are the big highway in the pelvis, like the sciatic nerve, the obturator nerve, the femoral nerve, and of course, the sacral nerve roots. And that will be my topic. We are talking about completely different kind of pain. And by the pain induced by such kind of endometriosis are completely have nothing to do with the classical gynecological symptom. We're not talking about low abdominal pain, dyspareunia. We are talking about low back pain. We are talking about bottom pain and pain always radiating down to the legs. That is the main difference with the pathology of the endometriosis of the visceral pelvic nerves, which always radiate upwards by following the back, but up to the plexus solar. This kind of pain is what orthopedists, neurosurgeons know, the typical sciatic pain. And that is incredible by the truth that most of patients with sciatic pain are referred to orthopedists and maybe neurosurgeon, but orthopedists in order to check the back. We have to keep in mind that the sciatic nerve is not located in the back, but in the pelvis. And that's the reason why endometriosis is able to affect the sciatic nerve. So when we are talking about the endometriosis of the sciatic nerve, there is actually a big mistake. There are two different kinds of endometriosis. One affects what we call the sacral nerve roots, which emerge from the spinal cord through the sacral foramina. These nerves are very close to the bowel, dorsally, laterally to the bowel. So patients affected by deep endometriosis of the bowel or endometriosis of the ureter are supposed to get such kind of endometriosis. And it's incredible by the truth to see how many surgeons are doing surgery for endometriosis of the ureter and don't mention endometriosis of the sacral nerve root, because for example, the second sacral nerve root is just few millimeters laterally to the ureter. So it's not possible to see so much ureter endometriosis in the world and not so less endometriosis of the sacral plexus. The other kind of endometriosis is endometriosis of the sciatic nerve, which of course emerges from the fusion of the sacral nerve root, but is located on the other side of the pelvis, more or less 10 centimeters away from the sacral plexus. And the symptom and the disease, endometriosis of the sciatic nerve, is completely different. Endometriosis of the sacral nerve root is an endometriosis of the pelvic organ that grows very slowly. Endometriosis of the sciatic nerve is a completely different disease. In many patients, not linked at all with the pelvic organ. So today we have more or less 500 cases. I'm talking about my experience over the last 20 years. It's not 500 cases from the last 2-3 years, but 20 years of experience. And endometriosis of the sciatic nerve is always located or always started in a special situation at the distal portion of the sciatic nerve just before it's passing through the great sciatic foramen. And at that special location, that is the upper part of the sciatic nerve, where mainly the superior gluteal nerve, the sacral or lumbar nerve called L5, and S1. So endometriosis of the sciatic nerve will induce a typical sciatic pain without really affecting the pelvic organ, because the innervation of the pelvic organ emerges from the lower part of the sciatic nerve. Just by the way, a small comment about what I heard over the last few years to preserve the inferior hypoglossal nerves in endometriosis. We have to be aware that the inferior hypoglossal nerve is not involved in the voiding function of the bladder. So to say you preserve the hypoglossal nerve in order to preserve the voiding bladder function, it's a mistake. The pelvic splanchnic nerves, which emerge from the sacral nerve root S3, S4, and a little bit S2, these nerves are in charge of the bladder voiding function, not the inferior hypoglossal nerves. So in a typical endometriosis of the sciatic nerve, the patient presents with a sciatic pain, maybe some endometriosis of the pelvis as well. So we cannot exclude some adenomyosis or even a deep endometriosis, but the main symptom of endometriosis of the sciatic nerve will be a sacral radiculopathy L5S1. That means a lower back pain with a buttock pain and a pain radiating on the dorsal aspect of the thigh, never in the front of the thigh on the lumbar root that is linked to the back, not to the sciatic nerve, which is located deep within the pelvis. And when your patient have an endometriosis and involvement of L5, then the pain will below the knee, will go in the front, down to the leg on both sides. But when you have no lesion of the sacral nerve root, S2, S3, S4, and that is always the case in the first 1-2 years of an endometriosis of the sciatic nerve, then the patient will have no trouble with the pelvic visceral function, no any vulvodynia or any pudental pain. One thing very important, over the last 20 years, I got 267 patients without any endometriosis within the pelvis. So they are patients with what we call an isolated endometriosis of the sciatic nerve. I repeat, by the gynecological examination, by sonography, MRI, and even by the laparoscopy. Maybe we found a little bit peritoneal endometriosis, an endometrioma, but no deep endometriosis involving the pelvic side wall. So they were isolated endometriosis. And we make a correlation between the onset of the pain, when the pain developed, and the time of our surgery. And we built 3 groups, 1, 2, 3. The first group was patients who underwent a surgery, a laparoscopy, until 1 year after she developed the sciatic pain. Group 2 was 2 years, 1 and 2 years, and group 3 was more than 2 years. And what you see is that in the first group, only 5% of the patient develop a foot drop. Foot drop is a typical destruction of the root L5. 1 or 2% had a Tredelenburg gait. Tredelenburg gait means lesion, damage, destruction of the superior gluteal nerve. And when you see just 2 years later, nearly 85% of the patients have developed a foot drop and 30% a Tredelenburg gait. So we are far away from the classical deep endometriosis of the rectum, which require years and years to develop. Endometriosis of the sciatic nerve, when it starts to touch the sciatic nerve, it grows very fast and it destroys the nerve. There is no time to lose. There is, in my opinion, in my experience over the last 20 years, there is no place for any hormonal treatment that place. According with what Koenig said, we have to preserve the fibrosis. No, in endometriosis of the sciatic nerve, you have to remove the fibrosis because fibrosis is not part of the sciatic nerve and fibrosis induces pain as well. When you have a strong tying of the nerve because of the fibrosis and you just remove the endometriosis, you will not cure the patient. You have to remove the active endometriosis. You have some time to reset part of the sciatic nerve, but you have also to release the full sciatic nerve and to remove the fibrosis surrounding and tying the nerve. Just so when you do examination, I'm a neuropelviologist, so I'm away from the gynecology. You will have to check the Achilles reflex, and you will find a loss or some fasciculation. If you see this patient, she have an atrophy of the gluteal muscles. Here you will see she have a typical foot drop. And if nothing happened, and if you try with some hormonal treatment, that will happen. That is a man, but woman is exactly the same. After 1.5 to 2 years, maybe she will develop a Tredelenburg gait, or even will lose part of the function of her legs. So we are not in the same kind of, we are not talking about the same kind of endometriosis. And we mentioned several times in the previous lecture, but yes, the diagnosis is essential. And I completely agree with Koenig when he said, you cannot just suspect an endometriosis and go somewhere in the pelvis and to try to dissect some nerve. You have to have a clear neurological diagnosis, or better said, a neuropelviological diagnosis. You have to know exactly where you have to go. You have to know which nerve you will dissect. You have to know if there is just an irritation or a lesion of the nerve, if you will have to make a resection. You see here, a colleague performed a previous surgery 1 year ago before, and he tried to dissect the sacral plexus. but he was missing the endometriosis. The patient had a typical foot drop. The endometriosis was 5 centimeters away. Here we are on the right side. You see the right sciatic nerve, a lot of fibrotic tissue. You have to remove this one. You have to release the nerve, otherwise the patient will have the same pain after. We are not talking from the same kind of endometriosis, even when we found a big endometrioma within the nerve in this patient. And you have to cure, you have to reset some part of the pelvic side wall. That is a deep place for an endometriosis, and that is one of the most difficult surgery in the pelvis, and now for sure, one of the most dangerous, because you have a lot of big vessels there, and you can kill a patient. It was a patient with an endometrioma, but sometimes you will find here a lot of fibrotic tissue and endometriosis involving the nerve. That is extremely painful. You are talking from allodynia, neuropathic pain from 10 by 10. And when we are talking about cyclical pain, it's just the first years. After several months, the patient will get more and more pain every day. Maybe for 1-2 years, even more during men's bleeding, but after a while, she will have pain every day. And that there is no place here for coagulation or for laser. It's just a surgery for cold scissor by a very experienced surgeon, and at best a surgeon trained in vascular surgery or vascular injury, because that is the main issue. And this patient, what I mentioned before, if you see, she had also this nodule was infiltrating the ureter, but it was not an endometriosis for the rectum growing laterally to the sciatic nerve. It was an endometriosis from the sciatic nerve developing medially to the ureter. And of course, you have to be able to make a reimplantation of the ureter. And that is exactly what I mentioned. How much ureter endometriosis without endometriosis of the pelvic side wall? I cannot believe. So, and keep in mind, there is one differential diagnosis. They are enlarged atypical vein that may tie the sciatic nerve as well. That was a superior gluteal vein. This vein induced pressure on the nerve. In all situations of life, they increase the blood pressure during men's bleeding, standing, sitting, coughing, all these situations, but with one main difference with endometriosis, the pain release or decrease over the night and reappear in the morning. And this situation, you have to be a vascular surgeon by laparoscopy, and you have to release the nerve. That is neuropelviology. And if when we perform surgery on the nerve, it takes very long time, 6 months, 1 year, until the pain decreases. In endometriosis of the sciatic nerve, we're very lucky, because the patient experienced very quickly after the surgery a significant pain relief, but you have to remove the endometriosis. Endometriosis of the sciatic nerve is a single shot surgery. You cannot do 2-3 times exploration of the sciatic nerve, one single shot. So that is not the field of the colleague or gynecologist who will try to do it. It's the field of colleagues who know and have the experience to do that. And of course, in very large endometriosis, you will have to resect, like in this patient, you will have to resect part of the sciatic nerve, which is already dead and be destroyed by the endometriosis. We are not cutting a healthy part of the sciatic nerve. We are cutting a damaged part of the sciatic nerve, and you can resect until 80% of the sciatic nerve, but as long as you preserve a part of the sciatic nerve and you send your patient after to the physiotherapy, she will recover, but it will take time. I show you that the pain will decrease very soon after the surgery. But when a patient is coming with a foot drop or a Trendelenburg gait, it will take 3 to 5 years until the patient recovers a normal function, a normal gait, by providing a good physiotherapy. But we have to do that. Now let's come back to this endometriosis. I mentioned 267 patients with isolated endometriosis. And that was the case I showed you before. But look, this case, that was a patient, no any endometriosis in the pelvic cavity, but a very, very small spot from 2-3 millimeters at the level of the sciatic nerve. And this location of the sciatic nerve is not linked with the uterus, the parameter, the ovary, or whatever. We are pretty far away from the peritoneum. There is no vascular or lymph metastasis there. There is no peritoneal fluid. And that's the reason why, in one of my last papers, I made the hypothesis of maybe this kind of endometriosis may develop some mature pluripotent stem cell. It would be very, very nice to send such kind of tissue of endometriosis to our colleague, Professor Boulogne, to check which kind of endometriosis is this endometriosis. So we have to do something. Let's come in short a few words on the endometriosis of the sacral nerve root, which is a completely different one, because this endometriosis develop usually from a parametrium endometriosis or an endometriosis of the pelvis. And then the patient will experience an infiltration of S2, S3, and S4. And all three nerves together are building the pudendal nerve, are building here the splanchnic nerve involved in the bladder function and a small part of the sciatic nerve. That means this patient will not just present a sacral radiculo-sciatic pain, not an L5-S11, but an S2, poorly dorsal part of the legs with pudendal pain, mean what we call vulvodynia. I prefer to say vulvar pain or burning pain, allodynia, coccygodynia, perianal pain, all this kind of pain are part of the endometriosis of the sacral plexus. And of course, because of the involvement of the splanchnic nerve, at the beginning of the disease, the patient will present an hypersensitivity of the bladder. She will have to go quite often of the toilet, but after a while, the endometriosis will start to destroy the splanchnic nerve. Then the patient will have to go very often on the toilet as well, but not because of an hypersensitivity of the nerve, but because she is not able to empty the bladder. And for this reason, she will have to go very often. So by suspicion of endometriosis of the pelvic nerve or in any deep endometriosis of the parametrium, please check the bladder function with a urodynamic testing and 2 sonography, one before the patient went on the toilet to check if there is an endometriosis of the bladder, and one after she went off the toilet in order to check if she was really able to empty her bladder. So, and I think I am in time because I had 20 minutes of time for my lecture, and I thank you very much for your attention. And once again, thank you very, very much for the kind invitation to take part to this beautiful event. Tamer, it's yours. The stage is yours.
Thank you so much. Thank you so much. This was obviously, we're always happy to have you, and you represent the utmost and the real issue with endometriosis, that's about pain. And I totally agree with your discontent with Philip Koenig's position on fibrosis. This is not a time to counter-attack him, but we'll have to discuss this later. It's a subject of future conferences. Mark, thank you so much. Our next presenter is connecting us from Bordeaux. Bordeaux has a special place in my life, not because of its wine and everything, but I have to be honest. I ran 3 marathons. I wasn't, I don't run for time, but after my last marathon, I had some cardiac issues. That was almost 27 years ago. And I went to Bordeaux to be fixed by a French doctor who is the father of electrophysiology. Electrophysiology and endometriosis really override because it's all about microcircuits of pain and conduction. It's that threshold of electronics that happens at the cell level. So that's my connection to Bordeaux. That was 27 years ago. It's really my great pleasure to introduce Horace Roman, who is a surgeon at the Endometriosis Center Clinic in Bordeaux, France. Horace is known for his bowel work, in my opinion, and he is really very active on many boards, including American Association of Art, GYN Laparoscopy, and World Endometriosis Society. He's authored more than 300 scientific abstracts and original articles. It's with great pleasure, we have Horace Roman. Thank you, Horace.
Dear colleagues and friends, ladies and gentlemen, it is my absolute pleasure to participate to the 13th annual Endometriosis Symposium of the Endometriosis Foundation of America, and to speak about one of my favorite topics, which is the management of colorectal endometriosis. So as you know, the colorectal deep endometriosis is probably the most frequent type of deep severe endometriosis. I think we have three types of nodule. We have the large nodules, macroscopically visible, easy to see in laparoscopy and using imaging techniques. Then we may have small satellite nodules, meaning that they are spread around the big nodules. These nodules may be difficult to see, but they can be palpated if we touch the colon with our fingers. And then we have the microscopic foci, which are impossible to see and to palpate. We can see them only with the microscope. And their role in the recurrence and the symptoms is not established. Now, speaking about the surgery of colorectal endometriosis, you know that there are two main approaches. The first one is conservative, meaning that the surgeon tried to remove the nodule but to conservate the bowel. And the second is the radical, meaning that it removes the bowel along with the nodule. The use of the shaving, disc excision, and colorectal resection, in my experience, is somehow balanced, meaning that in 60% of cases, I could perform a conservative procedure. So I try to propose an individualized approach depending on nodules feature and patient features. And I think it is maybe the good approach, not having one technique suitable for everybody, but various techniques and using one or one of them depending on the patient. Now, these three techniques, or the shaving, the disc excision, and the segmental resection. And now let's have a look at each one. So the shaving, everybody knows, means excision of the nodule without opening the rectum. The goal is the complete excision, but the complete bowel conservation. Now, the problem with the shaving is that the excision of microscopic but also macroscopic lesions is, in majority of cases, is incomplete. However, it does not mean that the shaving is not a technique, is not a valuable technique, because it is related to a very low rate of complication. And also, the patients are never go worse from a functional point of view. So you will never have a patient with worse functional outcomes after shaving. However, when you perform a shaving, you have to keep in mind that maybe the risk of recurrences is a bit higher. So in my opinion, the shaving is the first line technique, particularly in elderly women. The disc excision is probably my favorite technique. So the disc excision starts by performing a shaving, then the shaved area is removed using transanal staplers or performing excision and the suture by hand. The goal is a more complete excision than that provided by the shaving, but also the bowel conservation. So you do not cut a whole piece of bowel, but only a patch. The advantages is the lack of bowel denervation, so you do not need to turn around the bowel, not to cut the mesorectum. And there are not variations, significant variations in the length or the volume of the bowel, meaning that when you perform a disc excision instead of radical surgery, you try to preserve the bowel function. Now, the resection of the microscopic foci is probably incomplete with the disc excision because, as I told you, there are satellite lesions, maybe satellite lesions around the macroscopic nodule which is removed. However, after disc excision, we have never observed a stenosis of the bowel, and there is a low risk to denervate the bowel, but this technique. You have also to understand that if you remove a patch from the anterior rectal wall and you keep the posterior rectal wall, it is logical to have a kind of posterior pouch, but this is probably not related to the rectal function because we assessed the rectal function after shaving in several papers, and we always had very satisfactory results. Now, the colorectal resection is the radical management, and it is probably the most standardized technique, meaning that all the surgeons around the world are doing more or less the same procedure. They cut the mesorectum, they cut the bowel, and then they perform anastomosis. So, in my opinion, this technique is suitable when you have huge subocclusive nodules or nodules responsible for a long bowel infiltration, which is not suitable for a disc excision because the patch is too large. In lesions which are circumferential and the lesions which are multifocal, but with very short distance between two macroscopic nodules. In this technique, also you can have microscopic foci left behind, but less than with the other previous two techniques. The recurrence rate is very low, 1 to 2%, 5 to 10 years after the procedure. But you may observe stenosis of the anastomosis in 8, 10, even 15% of cases. And maybe this stenosis is more likely to occur after the resection in colorectal endometriosis than in other benign or malignant colorectal diseases. It is logical to inquire whether or not the complications are similar between the three techniques. So here is a paper published in Fertility and Sterility comparing the complications following shaving, disc excision, segmental resection in my series in Rouen. So the rate of complications progressively increased from shaving to disc excision and to colorectal resection. But of course, the patients are not similar. It is logical that the patients with segmental colorectal resection were baseline more severe than the patients with shaving. We also observed that stenosis was exclusively recorded in the group of segmental resection. But the most severe disease, the most severe complication we may expect in colorectal surgery is the bowel fistula. And we recently reported a series of 1,102 cases, and this paper is in open access, so you can access it for free in human reproduction. So among these patients, we observed 3.4% of bowel fistula, among which 2/3 were rectovaginal fistula, meaning that the stool and the gas were going through the vagina, while in 1/3 of cases, there was only a bowel leakage, so there was not suture, not opening of the vagina, so the patients had stools into the abdomen and peritonitis. And when we look for the predictive factors for the bowel fistula, we found that the most the strongest factor is the technique, meaning that each time you perform a disc excision or a colorectal resection instead of shaving in the patient, you will increase the risk of fistula 5 to 6-fold. The major concern when you perform a colorectal surgery is not the immediate complications, because immediate complication may be solved after 1 year, the stoma is closed, so everything is okay. They are much more challenging, the functional outcomes, because they will run at the long, they will impair the quality of life on the long run. So speaking about the functional outcomes, require to have a look at the rectal function. And the rectal function, in my opinion, is related to 3 factors. To the rectal shape. So you remove a piece of rectum, you have a shorter rectum and a smaller rectum. So the rectal shape is determined by the technique, the surgical technique you use. But also it depends on the rectal innervation and the possibility to carry out nerve sparing. And sometimes it is impossible and you have big infiltration of both parametrium. So in this case, you may perform just a shaving, but if you denervate the rectum, the function will be not conserved. And the third factor would be the hidden preoperative functional troubles, such as irritable bowel syndrome or chronic constipation, which may persist after your surgery. So the functional outcomes, the rectal function is multifactorial, so it is difficult, however, to manage. Each surgeon who try to treat the colorectal endometriosis should be aware about the risk of low anterior rectal resection syndrome. So this syndrome is determined by the rectal denervation, by the rectal sigmoid stenosis, by the reduction of the rectal reservoir following the colorectal resection, by the risk of fecal incontinence and urgency related to a low rectal resection, and it may result in constipation and incontinence and dyschezia and very frequent bowel movements. When I say frequent, you may understand 10 to 15 stools a day, and urgency. So this low anterior resection syndrome should absolutely be avoided, because if it occurs, the patient will be worse after the surgery than prior to the surgery. The question was if performing the conservative surgery of the colon and rectum will better preserve the rectal function than performing the radical surgery. And for years, I have been convinced that the answer is yes. That's why I carried out the Endo randomized trial, where I compared 60 patients randomized between radical surgery versus conservative surgery in nodules involving the rectum up to 15 centimeters above the anus. And I was disappointed and surprised to observe that 2 years after the procedures, there were similar rectal functions in both arms, excepting the risk of bowel stenosis, which was much more frequent after the colorectal resection. It means that the rectal shape is not the unique factor conditioning the rectal function, because it is very likely that some patients with disc excision or shaving had a problem of innervation of the rectum because of the infiltration of the parametrium, and this could impair the rectal function. But this randomized trial allows me to follow up the patients at long run. And we published last year the 5-year follow-up, where you observe that the surgery of the colorectal endometriosis is valuable because it allows a constant improvement in pain, gastrointestinal scores, quality of life, 5 years after the surgery. So it warrants to perform the surgery in order to improve the patients. And far from more, you observe that 4 years after the surgery, more than 80% of patients were pregnant, and even 75% of patients who were infertile before the surgery. meaning that the surgery of colorectal endometriosis, of the wall endometriosis, but also involving the colorectum, it's a very good tool to treat the infertility. Now, the question is, if performing the same randomized trial, but in only low rectal nodule, would allow the same results? And probably not, because I told you that in the Endo randomized trial, I enrolled patients with low, mid, and upper rectal nodules. And maybe the upper rectal nodules, this patient with upper rectal nodules confused our results, because when I look retrospectively to patients with, in my wall cohort, patients with nodule lower than 8 centimeters above the annus, I clearly observe a higher risk of low anterior rectal resection syndrome in patients managed by colorectal resection, low colorectal resection, versus patients managed by disc excision. Now, the last point is recurrences risk. So I told you that performing the shaving leaves microscopic endometriosis and even macroscopic endometriosis on the bowel. So the risk of recurrences, I estimated it, is about 8% at 5 to 10 years. So this woman treated by shaving should take a medical treatment in order to stay without recurrences. In patients managed by disc excision, the recurrences risk is lower, 3% at 5 to 10 years. While in patients with colorectal resection, the rate of recurrence is very low, but it does not mean that the colorectal resection completely remove all the microscopic foci, because as I told you, we identified microscopic foci far from the macroscopic nodules, meaning that if you try to perform a short colorectal resection, as it is recommended, you may leave this small satellite microscopic nodule behind. And that's why I think that microscopic complete removal of endometriosis in colorectal resection is not a realistic goal from a functional point of view. So we have just published a paper in Human Reproduction. It is in open access too, with the Professor Dan Martin. And we checked these satellite small lesions that cannot be seen in laparoscopy, but can be palpated when you touch the bowel with your fingers. Meaning that we specifically looked at this nodule on the specimen of the colorectal resection, where we removed the bowel in order to cut it. And you observe that in 25% of cases, these small satellite nodules exist. Meaning that if we perform a disc excision or a shaving, which are the technique exclusively laparoscopically, we may leave this kind of small lesions in 25% of patients. However, as the rate of recurrences is much lower than 25%, it means that in a large majority of cases, this nodule probably does not, develop. Now, what is the choice of these three techniques? So I can tell what I'm doing, me. This is not a rule, it's just my experience. So when you have a nodule of the upper rectum and sigmoid colon, you can do a shaving, but only when the nodules are very superficial. You can do a disc excision if the nodule is very small. But you can do a segmental resection in the majority of cases because you won't have functional unfavorable outcomes. This is very different when you treat a mid or low rectal nodule below 10 centimeter or 8 centimeter, because here you should be conservative as much as possible. So you can perform the shaving in superficial nodules, but you try to do as much as possible a disc excision instead of the segmental resection, because it is my belief that you improve the functional outcomes. So in conclusion, the surgery of endometriosis for me is a new specialty. It is challenging, complex, but very, very exciting. The surgery of colorectal endometriosis may be done laparoscopically in more than 99% of cases. The preservation of the quality of life must be the major goal, because we are performing this surgery in women as old as 30 years, and they will live 50 or 60 years after our surgery with our sequela. So you should take care about the risk of sequela after the surgery. The conservative rectal surgery is feasible in the majority of cases. Immediate complications risk is lower with the shaving. The functional outcomes are multifactorial, but probably in the low rectum, they are less with the shaving and the disc excision. The recurrences risk is lower after segmental resection. However, there is no demonstrated benefit to perform colorectal resection in everybody. And I think that a balanced use of three techniques, a custom-made management, is the best way to treat these patients correctly.
Thank you, Horace. I hope you're going to be able to stay. You're going to be able to questions for and everything. Well, we're coming to the end. Thank you for sticking with us. I'll be honest with you. My IT manager just informed me. There are 2,022 registrants to the conference at this moment in 2022. So there is something interesting happening. The stars are aligning, and I think this has been the most wonderful that's going on. My next, Horace, thank you very much. Horace, so special, and I have to admit, I followed you for a long time, but I have to stick to you more. You say some nice stuff, and I appreciate that.
Thank you very much. Thank you very much.
From your bowel, you're going back to as a scientist, a young star coming out from Yale. It's her choice of subject. Endometriosis is a systemic disease. I told her to stick the word adolescence because it starts with the symptoms starts with adolescence, and how that's important, because I believe early intervention and detection with timely intervention. We're not jumping on surgery, but jumping on birth control, medical management, not medical treatment, medical management, and then timely intervention prevents the disease. This is a progressive disease. Everywhere. So her name is Valerie Flores. She's an assistant professor of obstetrics and gynecology sciences at Yale School of Medicine, working with Dr. Hugh Taylor. Many of the things that Hugh Taylor talked today is mind-blowing. It is really exciting. That's why we started stem cells. First conference we ever did for almost 13 years ago. So Valerie is going to talk about the systemic effects of all that happens with endometriosis. I have so much things to tell her about her, but she's a graduate of Brown University of residency program there. Then she joined Yale, and she's a true promising scientist and physician. I welcome Valerie. Thank you for joining us.
Thank you, Dr. Sutkin. Thank you to everyone who's here as well for the conference. I'm just going to be sharing my screen.
Valerie, you have to go back to your share screen and select basic and select this thing, because it's not your slides are not showing well.
Okay, one sec. How about now?
You got it.
Okay, perfect. So thank you so much for that introduction. I'm really looking forward to speaking with everyone today. So endometriosis is a systemic disease including adolescents. The one disclosure that I have is that I do receive a CQ honorarium from AbbVie. There is one class of medications that I'm going to be discussing as a whole, not specific to one particular group. So as we all know, endometriosis is defined as endometrial-like tissue outside of the uterus. And I don't have to harp this point with this group in particular, but I will say it anyway. We know that it affects up to 1 in 10 reproductive age women, up to 50% of women with pelvic pain and infertility. Over 107 million women suffer from this disease worldwide, and in the US alone, the annual healthcare costs exceed $22 billion. And it's really challenging to even diagnose this disease. There still exists up to an 11-year delay from symptom onset to diagnosis and treatment. Many PCPs are unaware to even think about endometriosis on the differential. And what can be hard is that sometimes the symptoms really are nonspecific or can be associated with other disorders. Pain in and of itself can be considered subjective, and social norms really inhibit the conversation. There are some patients who their moms probably had endo, but they just thought they had painful periods, and then the daughters then believe that that's just how their periods are supposed to be. But in a survey of over 7,000 women, it was found that over 65% of them were initially misdiagnosed, and almost 50% saw over 5 providers before getting the diagnosis. And as Dr. Sechkin mentioned, really early diagnosis and treatment can really reduce the uncertainty, the discomfort, the disease progression, and later complications. And it's probably particularly challenging in adolescents. And the reason why is because it's even less on the differential for providers to even think about it in this age group. Although most cases probably do present in adolescence, unfortunately, given that delay, a lot of women aren't presenting until they're in their 30s. But in studies looking at adolescents who then became adults and looking at what their symptoms were, about 20 to 40% of adolescents with chronic pelvic pain are ultimately found to have endometriosis. And it's found in up to 75% of adolescents who ultimately undergo a laparoscopy where they see the endometriosis. And over 2/3 of women actually note that their pain symptoms really began prior to 20 years. And so it's for that reason that I really wanted to bring back risk factors associated with endo. These are the same risk factors that we would talk about with our 30-year-old patients. But I think it's relevant to bring up here just because since the presentation can be a little more varied in adolescents, thinking about risk factors for endometriosis in and of itself will hopefully help in terms of sooner diagnosis. So family history, if there's a first-degree relative with endometriosis, then that patient is 7 times more likely to have the disease herself. Early menarche, shorter menstrual cycles, and menorrhagia. And in terms of how adolescents present, so yes, they can present with pelvic pain, but they can also present with non-menstrual pelvic pain, as well as bowel and bladder symptoms. And what's unique to this group as well is that it is secondary dysmenorrhea, so we think about progressively worsening menses. But these adolescents also tend to present with nausea and headaches, which is not something that we typically think about going along with endo, especially in our reproductive or 30-year-old age women. So the question really becomes, there's a varied presentation in adolescents. There's also a varied presentation in adult women, but really the question becomes, why are the symptoms of endometriosis nonspecific, and why is endometriosis still very challenging to diagnose? And the answer really is the complex and systemic nature of the disease. So we and others have looked at the role of stem cells in endometriosis. I know we typically quote Sampson's theory of retrograde menstruation as the cause, but there are likely other etiologies, and work has really demonstrated that stem cells from the bone marrow can not only go and implant and become endometrial cells, normal endometrial cells, but they can also ultimately implant in other locations and become endometriosis. In the same regard, the endometriotic lesions in and of themselves will preferentially have stem cells go towards them rather than going to the uterus. And these stem cells that actually the endometriosis can create as well can ultimately end up being reincorporated into the endometrium, which they do so incorrectly. And so this may also play a role in why there's infertility in women with endometriosis. There's also been increasing work looking at circulating factors involved in the pathogenesis, so aberrant expression of several inflammatory cytokines and also altered expression of several microRNAs. And it's really shown that they can impact various organ systems, the liver, the brain, the spleen, the lung, adipose tissue. And so when we think about systemic effects, or when we think about some symptoms that may not be the classic pelvic pain symptoms, it's really helpful to think about it with respect to what is the endometriosis doing in distant sites away from our typical thinking of the endometriosis being confined to the pelvis. So one way to think about that is just even looking at the low BMI in women with endometriosis. It was a common misconception that being thin predisposed you to having endometriosis, but it's actually the opposite. So the endometriosis in and of itself can lead to a lower body mass index, and it's really due to altered metabolism. There's induction of hepatic gene expression, so anorexogenic genes, and there are also microRNA mediated changes in adipocyte metabolism and gene expression. There's also systemic inflammation, which we all know about. There's estradiol-mediated increased prostaglandids. There's altered microRNA expression, several of which can actually lead to a pro-inflammatory environment. There's altered immune cell function, and there's increased production of inflammatory cytokines, in part probably due to the altered microRNA expression. And mood disorders. Unfortunately, a lot of patients with endometriosis are misclassified as being quote unquote crazy, but it's the disease process in and of itself that is really affecting mood, especially if you just think about it from the perspective of pain or just not being heard. There's altered gene expression in regions of the brain associated with anxiety and depression. There's even decreased volume in areas of the brain associated with emotional and sensory nerve processing. So really, we have to think that the lesions in the pelvis are a small component of the disease, and the systemic nature of the disease may explain the extensive symptoms that we see, the ones that go beyond the pelvic pain symptoms. And stem cells, microRNAs, and inflammation are some of the mechanisms that mediate these long-range effects. So once we get to the diagnosis of endometriosis, now we have to think about treatment, and I'll be discussing both medical and surgical treatment options. First line still remains progestin-based therapy. However, as Dr. Balloon had also mentioned, there is a concept known as progesterone resistance, both clinically and molecularly. And that really kind of limits then what our next steps are going to be in terms of second line therapy, which consists of aromatase inhibitors, GnRH analogs, and also androgen derivatives. But before we go into these other treatment options, I wanted to talk a little bit about how can we better identify who is going to be progesterone resistant? How can we better utilize what we see molecularly with how that translates into patient care? And so one of the projects that I had actually worked on in the lab was looking at progesterone receptor expression levels in women with endometriosis. We typically describe endometriosis as having lowered expression of the progesterone receptor. But I wanted to look and see if we could actually use, if the levels were altered between women who did respond to progestin-based therapy in the past and women who did not. So this was a retrospective cohort study where I looked at lesions. I collected lesions from women who had undergone surgery for endometriosis and defined them as responders or non-responders to progestin-based therapy, whether or not they had actually done well on progestin-based therapy in the past, or whether or not they were having surgery because they were failing progestin-based therapy or other therapies. I used immunohistochemistry and utilized the H-score to quantify PR expression, and found that actually non-responders to progestin-based therapy had lower PR expression in their lesions compared to responders, and this was statistically significant. What was also interesting is that I was actually able to categorize lesions as having either high, medium, or low PR expression. This was defined as an H-score over 80, just given its 100% specificity and positive predictive value. And then also defined lesions as having low PR, which was an H-score of less than or equal to 5, given its 93% sensitivity and 94% positive predictive value. And then anything in between was categorized as medium. And what was great was that in lesions with high PR expression, there was a 100% response rate to progestin-based therapy. And this was in sharp contrast to lesions with low PR expression, where there was only a 6% response rate, meaning that over 94% of women who have low PR expression are not going to respond to progestin-based therapy. So this was a retrospective study. So we next wanted to utilize a murine avatar to see if we could again show that treatment with that PR expression really can be used to tailor therapy in women. So to do this, I utilized 8-week-old non-skid mice. So they were immunosuppressed mice, and placed portions of human endometrioma specimens into the mice. Before doing this, I used a portion of the tissue actually to determine PR expression again and defined that as either being high or low PR expression. These mice were not overrectomized, and following the 2-week transplantation period, ultimately treated mice with vehicle or medroxyprogesterone acetate. And 1 month after treatment, the mice were sacrificed and then lesions were collected. These are just representative images showing the differences in size for a low PR lesion compared to that of a high PR. And really what you can see is that the high PR lesion is smaller. Looking specifically now at treatment response, so perhaps not surprisingly, the lesions with high PR responded almost completely to progestin-based therapy, whereas the lesions with low PR did not. So how I think this translates really to patient care. So one is, when we think about how there can still be a recurrence rate even after surgery, it may be beneficial to look at PR expression in lesions so that, let's say a patient had been on progestin-based therapy before, maybe progestin-based therapy won't be ideal post-surgery just because the lesions had low PR expression, for example. So this is probably will take a while. I think a prospective study will be next, but until then, I did want to talk about another class of medications, which are GnRH antagonists for the treatment of endometriosis-associated pain. So these are different from Lupron or GnRH analogs, where initially you can have a flare effect and ultimately the GnRH receptor becomes desensitized. With the antagonists, because they're antagonists, once they bind to the receptor, they almost immediately lead to decreased production of FSH and LH, and ultimately decreased production of estradiol. And this occurs actually within 24 hours. So you have a hormone suppression that is rapid. It's also reversible. The half-life is about 6 hours. And so if patients for some reason don't like this medication, within 24 hours of stopping, it's completely out of their system. The other nice thing is that you can tailor your estradiol decrease to a given patient, given that there's both a low and high dose of the medication. So these are a good second line option. One, it's a pill, so unlike Lupron, which is an injection. And two, when progestin-based therapy is failing, it's another agent that we can use. The other medication that I know most of us think of as a menopause medication is Duavi, which is based doxepin and conjugated equine estrogen. So this medication is actually approved for treating menopausal symptoms. It's a tissue-selective estrogen receptor modulator, so it consists of conjugated estrogen and a selective estrogen receptor modulator, BZ8-based doxepin. But its mechanism of action is really what lends it to be used as a potential endometriosis treatment. So it's an endometrial receptor antagonist at the level of the endometrium. But more than that, it actually has the ability to degrade the receptor. And so if we think about endometriosis being an estrogen-dependent condition, if you block the estrogen receptor, which is essentially that last point that you need to block, then even if there is estrogen still circulating, this medication really serves to basically not even allow estrogen to carry out its normal function. So we had actually used this in a patient who had actually been on Lupron, had done well from a pain perspective, but had persistent hot flashes despite trialing different forms of AdVac therapy. And she had essentially complete relief in her endometriosis-associated pain. She felt that it was equivalent to the Lupron minus the hot flashes. So right now there's a bit of an issue getting the Duavi, given that there was an issue with some packaging in the past. And so I've been in touch actually with the company to see when it's going to be available, and they think within the next year. One other potential non-hormonal therapy that may have some future use is that of the microRNA LET7 mimic, really. So we and others have actually shown altered expression of microRNAs in endometriosis. And one that's particularly interesting is that of LET7B, which in women with endometriosis has been found to be decreased. LET7B is normally responsible for blocking inflammation, specifically blocking NF-kappa B, which is a primary mediator of inflammation. In an animal model of endometriosis, a murine model, we did find that treatment with LET7, or essentially supplementing LET7, really allowed for a decrease in lesion size, which you can see on the left-hand side. And then translating that to humans, so I had looked at transfecting LET7 mimic into primary cells from women with endometriosis, so endometrial cells, and found that treatment with the mimic actually led to decreased expression of NF-kappa B, which is, as I mentioned, a primary mediator of inflammation. So again, not a medication that's currently available, but hopefully one in the future. And the novelty really lies in the fact that it's a non-hormonal therapy. And of course, we cannot forget about the role of surgery. So while we do normally like to try medical therapy first, really with surgery, not only can it allow for diagnosis and staging, but ultimately it allows for a decreasing disease burden. And the goal is really symptom control. So how I usually think about this is if we have a patient who we suspect endometriosis or know that they're already coming with a history of endometriosis and their primary symptom is pain, first line, we would try combined oral contraceptives or progestin-only pills, as well as nonsteroidal anti-inflammatory drugs. And if the pain persists, then we can trial GnRH analogs or aromatase inhibitors with a progestin or COCs in premenopausal women. But surgery as well plays a role, especially for patients who have been failing therapy or who feel that this is something that's really important to them to really immediately decrease disease burden. So the important thing really to consider here is just post-operative medical therapy with the goal of helping to minimize the risk of recurrence. So what I'd like to leave you with is when we think about endometriosis, while we do typically think of it as a pelvic pain syndrome or an infertility syndrome, it's really important to recognize that it's profoundly more than that. It's associated with fatigue, depression, low BMI, bowel dysfunction, anxiety, bladder dysfunction, and even cardiovascular disease. So what we see in the pelvis is really the tip of the iceberg. The disease extends far beyond that. And with that, I'm happy to take any questions, or I think it's the Q&A next.
All right. Wonderful. Thank you for this beautiful presentation. You are really a star. Hopefully we'll see you again in our future conferences. I am joined by my faculty commentators. Are there any questions to Valerie from you, or shall we take other questions? Dan? Dan Martin. Time to hear you a little bit today.
I was typing out a question to send an email to her. In your 2021 Lancet paper, you discussed stem cells as engrafting pre-existent endometriosis or endometrium. However, in your talk today, it sounded like you were discussing stem cells as initiating endometriosis. Can stem cells initiate endometriosis in the absence of other signaling?
Yeah, I think they can. I think that kind of goes along with, why did the endometriosis end up in the lung or end up in the liver? There's probably some role for aberrant stem cell trafficking, where not only can the stem cells that may have been existing already contribute to disease progression, but perhaps they're also contributing to de novo disease formation.
Would that also imply that the same stem cells might de novo put muscle tumors and other benign tumors in the liver?
Perhaps. I'm not a liver specialist, but perhaps that could actually be the case.
Thank you.
Certainly the de novo or the bone marrow derived or stem cells have a big role in the systemic expression. I think focus has been going towards that, the way I heard Hugh Taylor talk about it. But, ignoring the progenitor base stem cells from endometrial origin, stem cells through retrograde reverse cell trafficking into peritoneum, I think these guys kind of work together. So in my opinion, you can't ignore the pores of the peritoneum and the holes in the diaphragm, that goes. Anyways, Dr. Horace Roman, do you have any questions or comments to make? We're gonna take some questions from the crowd right now. In the meantime,
I'd like to thank you to involve me in this prestigious panel of experts in endometriosis. So it is always a pleasure to exchange with you. And I have no specific question because I agree with almost everything has been said. Maybe less with with some thoughts of Philip Koenig's about the randomized trial, because I think they are actually useful, however very, very difficult to perform in surgery. But if I take only the example of Endor, I think the results of this randomized trial, which are not in agreement with what I expected to find, made me understand that the preservation of the nerve is most important, whatever the technique is done on the rectum. So I think it was an excellent afternoon, and
thank you.
I congratulate you for this.
You. So I have to take these questions because it's unfair for our listeners and watchers who are giving these questions. We need to answer. Here's a question. Supplemental progesterone is often used to treat endometriosis. Okay, fine. What are the best methods to measure progesterone resistance? This is coming from a patient. Is it the ratio 2/16 ratio, just estrogen versus progesterone? Others. Do we measure practically progesterone resistance? As far as I know, we don't. But Valerie, what do you say to that question?
That's a great question. So right now, what we're looking at is progesterone receptor expression in the lesions. This is done after surgery. And so the lesions are taken and we stain them for PR, progesterone receptor, and then quantify how much is being expressed. But what's a little challenging when it comes to endometriosis is that there isn't a current standard for how you define high, medium, or low PR expression. So it's different from breast cancer, where because it's a cancer, the pathologists actually have very clearly delineated what's considered, for example, progesterone receptor positive versus progesterone receptor negative. So what I did is I essentially used an algorithm. So I used a statistical algorithm to really better define what would I consider high PR expression, what would I consider low PR expression, what would be considered medium. And that was really based off of what was going to lead to the best way to not inadvertently misclassify women. And so that's how I came up with that high, medium versus low. And then really where I see this applying to clinical care is to be able to utilize it post-surgery. So after women have had surgery, looking now at what their progesterone receptor expression is. And so then we know if their progesterone receptor expression is low, then we should not be putting them back on a progestin-based therapy as a way to minimize risk of recurrence. We should use something like a GnRH analog or an aromatase inhibitor.
Quick question. Is aromatase inhibitors approved by FDA in the States?
Not for endometriosis, although it is used for treatment of endometriosis.
Okay, so let's get another question. I have to take this question. What is the estimate cost of thoracic endosurgery? Are there resources for uninsured and underinsured patients? I'm not going to get the cost of it, but I'm going to get, are there resources for uninsured? Yes, there is. Please write to Foundation. We have a special program. We're trying to help certain group of people who qualify. We do help patients who are candidates for surgery in our hospital. And I'm trying to disseminate the same principle to other surgeons in the United States to get going on patients who really need care, who have issues of financially, insurance-wise, not to come up with resources. Please write to the foundation or me, drsechkin@mac.com. I will do everything to get your case moving along. There are a lot of microbiome questions. I don't know how to take any of them, but let's take one of them. Let's see if anybody will volunteer here. Is it common for endometriosis patients to have SIBO, low ferritin, B12, vitamin D, also have comorbid conditions like migraine, hypothyroid, and depression? Well, you know, the issue is, this is not my forte, this question, but anybody willing to tackle this question? The idea is SIBO, low ferritin, vitamin D, comorbid condition like migraine. I'm not surprised. Nobody's willing to take this question. Okay.
Maybe I can give an answer. Maybe not about concerning the vitamin B12, but concerning the vegetative symptom, because the patient is reporting about migraine and depression. That is typical when you have an endometriosis of the genital organ. You will have an overactivity of the autonomous nerve system, mainly the sympathetic nerve system. And when you have an overactivity of the sympathetic nerve system, the patient will be affected by tachycardia, pallor, fatigue, migraine, nausea, vomiting, oppression, depression, all these symptoms. And I had not the time to show that in my lecture, but when you see really the face of a patient affected by endometriosis, you will see all the different kind of signs with this pallor, with the dryness of the lips. That is a typical sign of endometriosis, or at least overactivity of the sympathetic nerve system. And you will see a dilation of the pupil. That is typical. So Valerie was talking about depression. That is also because of overactivity of the sympathetic nerve system, which is the fight and flight system. It's not a nice system, even it is called sympathetic nerve system. So these symptoms are definitely part of endometriosis disease. Yes.
And I can take another part of that question as well. Thank you, Dr. Passover. In terms of whether or not some comorbid conditions exist with endometriosis, yes, because it has an immunologic basis as well, it's not uncommon to see some immune disorders also being present with endo. We usually think about thyroid disorders as well as several autoimmune disorders can go hand in hand with endometriosis. In terms of the microbiome, so it's not my particular area of research, although I did just attend a conference where the microbiome was discussed. It's an ongoing area of research, and I'm hoping that in the next few months we'll have more information about that.
So then I have to ask this question. There's this question popping up. We know that E. coli gets more toxic as it hemes more iron. We know that E. coli is found in endometriosis tissues. I didn't know that. We also know that people with endometriosis have high levels of E. coli in their bowel microbiome. Can this cause pain? Well, good question from a patient. Who wants to take this?
There's a whole series of publications by Kahn and others that suggest that's true. There are lots of different studies going on in the microbiome, and those include E. coli and other bacteria. It's hard to, I think we're still waiting on answers to that. I think that's a really good subject to study, but I don't think we have any real answers in terms of what that means clinically at present.
I mean, the size of a bacteria is 1/10 of a cell, maybe. How come so many, for the last 20 years, as we read all these path reports, this, that, or anything, or complication that comes with E. coli, how come we never see this in our publications? For example, I thought the E. coli and the issue of pelvic inflammatory disease that has to do with chlamydia, gonorrhea, and that kind of stuff was history. Now we're coming back to pelvic inflammatory disease and endometriosis. And this is an interesting thing. You can't really reject it, but the science behind it, we need to be very careful. Obviously, because it's microbiome, it changes everything. It's not the true bacteria itself. It's the gene material of the bacteria. So we will learn, I guess. We're looking forward.
And it's going to be much more than just pelvic inflammatory disease.
Apparently.
I think this is going for pelvic inflammatory disease sounds like it's way too focused. I think we need to be more generalized and look at a bigger picture.
Yeah.
You know, patient, we make a study for maybe 20 years. We check the bowel in patient affected by endometriosis by laparoscopy, and we found that 60% of the patient affected by endometriosis presented an elongation of the rectosigmoid, dolichocolon. And it's typical that the left sigmoid is completely detached from the pelvic side wall and building kicking. And that is a typical outlet of constipation syndrome. And definitively when the patient are eating something, they have bowel motion every day, but what they are eating is taking much longer to come out. And for this reason, they have definitively an accumulation of E. coli in the upper part of the rectosigmoid.
I totally agree. That's also called redundant colon. We see it so many times. Exactly. It's the main cause of constipation. It's reasonable to expect E. coli colonization on these patients. Beautiful comment.
There is a very good symptom to try to recognize that when the patient reports about bloating with radiation in the back pain, check the fingers of the patient. If the finger are very thin, very long, you can be sure that the rectosigmoid will be very thin and very long and dilated.
Yes. I think we're coming to the end of our conference. It can go on and on. I have the rest of questions, and I promise I'll get back to these people who originated the questions, because time constraint and time in Europe and everyone donating their time free to us. I really appreciate it. I want to thank my foundation staff, IT managers, Harper, Jean Rebelar, Andre Leberal, Mina Sechkin, and so many other, especially Dr. Martin, Dr. Rich, who has always been supporting and really with me for a long time. I know I'm forgetting some other people in the foundation. Jake, I remember, and I thank you for your support. Please forgive me if I forget anybody else. Diana Falzone, thank you for supporting. Tonight is the Oscar dates. I hope one of our supporters will mention endometriosis. I don't want to mention celebrity names, but she will be on. We are excited to watch her. The last comment comes from Sergios Titsimikas from Greece. He writes, what a lectures. Thank you for all this outstanding Sunday. Greetings from Greece, Thessaloniki. Thank you, Sergios. Thank you very much. We hope to see you again. Guys, for all the faculty who is still on, Passover, Alexander, Mario, if you want to say something last word, you're welcome. Please, Togas. Thank you very much, Dr. Giovanni, Alessandra, Valerie. I really appreciate your support. I'm looking forward for better days without war, without damn COVID. I hope we deserve the better and best. You know, life is short. I can't wait to meet you in person again. Harry, Togas, Martin, thank you so much. I give you someone last word. Why don't you have Mario say the last word and we're bye-bye.
Thank you, Tamir. It's a really great pleasure for me. You did a very great job, and I'm very honored to be part of this amazing meeting and event. So thank you to you, to the foundation, and all the people and the friends in the faculty. Thank you so much.
With that, much love and be well and healthy. Looking forward to see you again. Bye-bye.
Thanks.
Thank you, Summer.
Thank you again.